Experts.
Ma'am, we are good to go.
So, good evening, everyone, and welcome to day 2 of the 11th Annual International Symposium in Diabetes by Cmre. As all of you are aware, Cmre is Consortium for Medical Research and Education. This is a research body that Dr. Chawla and I are co-directors of for the last few years. And last 11 years, we have been conducting this International Symposium in Diabetes. And it has grown from strength to strength in the last 11 years. And I'm so happy that we are able to connect not only in our country, but also spread the message of diabetes education to healthcare practitioners all across the globe. We have partners like DIPSI, we have partners like AASD, Arabic Association for Study in Diabetes, and yesterday we had a very successful virtual meeting on day 1 with the AASD, where we had faculties from across the MENA region, across Cairo, Egypt, all those countries, and we had 900 plus logins for the virtual program, which speaks about the quality and success of the academics that we do. So this is part 2, day 2 today, and we are very happy to have the joint CMRE DIPSI symposium being aired today, where we are going to discuss diabetes in pregnancy, especially gestational diabetes, in detail for the next 3 hours with the who's who of diabetes in pregnancy. So let's have it from the masters, and I'm sure this is going to benefit each and every healthcare practitioner who has an interest in diabetes and pregnancy and GDM. So on behalf of my co-director, Dr. Rajiv Chawla, I welcome all of you to this symposium, the joint CMRE DIPSI symposium. And I would request Dr. Chawla to say a few words before I invite our DIPSI president, Dr. Sahai, to say his words of wisdom.
Thank you. Good afternoon, sir. Good afternoon, everyone. It's my pleasant duty to welcome you all on this virtual dais, all the faculties and delegates who are gradually now getting logged in. This is 11th International Symposium being organized by CMRE in association or in joint partnership with DIPSI as well as ASD. This we have been doing year after year, and as Dr. Shalini said, it is getting stronger and stronger. And just to correct her, yesterday we had close to 1300 total logins, and even in the last session, we had close to 900 logins when we closed
900
the
to the end.
last session of Professor Adi Mehta when we were close to 9, that was quarter to 9. And one more achievement which we have this year is that we have also partnered with ACE, that is American Clinical Endocrinology. And today we are going to do a symposium with them 7 to 10 p.m. where we have two virtual faculties logging from ACE, and we will have two sessions from Delhi, and it is going to be a physical program at Hotel Lalit itself. So last many years, we have also partnered with DIPSI for propagation of gestational diabetes knowledge, skills, and our own guidelines, which we released first in 2021, and a edited version was released in 23, and it got published in International Journal of Diabetes in Developing Countries in August issue in 24. We also did a DIPSI declaration, which is also published recently in the thematic issue of International Journal of Diabetes. So aim is to reach to every physician and a practicing gynecologist so as to make them aware about the original clinical research evidence which has come from Professor Sheshai group, and reach to every practicing physician and gynecologist so that this can be so that their treatment can be rationalized based on DIPSI guidelines, and it has become a standard care across the country. All these guidelines have been adopted by Government of India, Ministry of Health also. So aim is to reach through this symposium, which we organize jointly with DIPSI under the banner of CMRE, to reach to every physician and gynecologist of this country. With this small introduction, I once again welcome all the faculties on virtual dais, Professor Shishai, Professor Rakesh Sahai, Professor Piki, Dr. Shalini, my colleague, Dr. Bhavtharni, Dr. Hema, Dr. Usha Shriram. She has already joined from Chicago, almost 4 a.m. in the morning. She was so keen to be part of this symposium. So I think it is going to be a wonderful scientific feast for everyone. And I'm sure that next 3 hours we are going to have a excellent scientific session. Over to you, Dr. Shalini.
Thank you, sir. With that, I welcome DIPSI President Dr. Rakesh Sahai, and we would love to hear from you, sir, your blessings and your support for the program and your vision. Sir, you are muted.
Professor V. Sheshaya, our chairman and patron of DIPSI, and we are very happy that he is joining us here today on this program. We have with us Dr. Rajiv Chawla, who was also a past president of DIPSI, Dr. Shalini Jaggi, a very active member, and Dr. P.K. Saxena, also being very active in the field of diabetes and pregnancy, and Dr. Bhavtarani and Dr. Usha Sriram, who has joined from across the globe. So I'm very happy that today DIPSI is partnering with CMRE in joining in this program, which is a very important program, which is covering different aspects of diabetes and pregnancy. And I think the vision of DIPSI has been to spread the message of of diabetes and pregnancy across the country to all people across, to all people across the country, so that the ultimate goal is to see that every woman during pregnancy gets adequate screening, proper diagnosis, and appropriate management of her diabetes, so as to provide a healthy, transgenerational benefit of this goes on, and this future generations are healthy. And we are now moving on to even doing a primordial prevention, looking at primordial prevention, and we are very happy that Dr. Shesha is here with us today. He has enunciated the concept of primordial prevention, where we are looking at the blood glucose levels right at the 10th week of pregnancy, identifying, or right from the 8th week itself, we are saying that we are monitoring the glucose levels and appropriate management of that towards primordial prevention. Dr. P.K. Saxena has published a very good work on this aspect, and so we are very happy that we are having this session today in order to increase this awareness about gestational diabetes and diabetes in pregnancy itself to all the participants across the country and across the globe. Today, I'm very happy that we have participants from across the globe. So I wish all of you a very good evening, and I'm sure this session is going to be very interesting and a real learning session for everyone who is participating in this session. With those few words, I would like to welcome everyone once again. Thank you.
Thank you so much, sir. And it is my proud pleasure, privilege, and honor to welcome our founder of DIPSI, the man whose vision, whose flag we all are carrying, Professor V. Seshia, sir. Without your blessings, I think nothing would have been possible. And the way that India has been placed on the world map when it comes to gestational diabetes is all thanks to your vision and all your hard work, your lifetime's work. So welcome, sir, and we would seek your blessings before we start.
Rajiv, Shalini, and other members of here, Rakesh, my friends, my colleagues who are here, young colleagues. I have got nobody, my colleague, all young colleagues. It's wonderful introduction all of you gave about our symposium today. And I'm very happy Rajesh has chosen me to speak on a different topic which I never covered so far. So this is a good opportunity for me to share with all my colleagues here, and I think everybody is I'm appreciating their work. So probably the audience which are going to listen to our talk, it will be much more better for us to implement in us. And I must say here, Shalini work she compared IADPG with DIPSI. I've been telling and telling every country is, I don't, even America it is like that. ADA guidelines is different, ACOG guidelines is different. So you see in our country, again, a group of diabetology is different, and another physician group is different. How, this country, how can you afford to have so many guidelines? So anyway, I'm very happy Chawla should start working on this. Let him, what do you call, introduce only DIPSI guidelines. And again, Rakesh is there. Rakesh, and his father, Professor Sahai, known me so many years. And we are all colleagues in this. So I am very happy to participate in that. That's why I come much earlier. So I'm supposed to be last person. I want to speak as the first person. I mean, introduce everybody. Thank you very much for meeting me. I get great. I appreciate you and Raju for inviting me for this symposium. Thank you very much. Looking forward to see you in Delhi.
Yes, sir.
Yeah.
Shani, I should come Delhi, no?
Oh,
Yeah.
you should come, sir. Most welcome, sir. We would love to have you, sir.
Next year.
Sure, sir. We'll plan.
Thank you,
Shalini,
sir.
I'm going for
Thanks for your
RSS.
blessings and good wishes always,
Coming
sir.
for,
We are
yeah, we'll
blessed.
be meeting, sir, in RSSDI.
Thank
Yes,
you.
Yes,
Yeah.
sir.
Shalini,
RSSDI is in
yes.
Delhi this time.
Oh, yeah. I told Rakesh about that.
Tuti, you may run Saraswati
So
Vandana.
thank you so much, sir. Let's just take blessings from God and we'll have Ganesh Vandana to start.
Okay.
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ
वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So I think with the blessings of God, we kickstart day 2, the joint DIPSI CMRE symposium. And this is where we are going to discuss all the intricacies of pregnancy, gestational diabetes, and a few new concepts, what we have latest. And to kickstart, our opening batsman is none other than President DIPSI, Dr. Rakesh Sahai sir, who is going to talk on a very new topic, early GDM. Because we've all, conventionally thought GDM happens in second trimester, it happens in third trimester, 24, 26 weeks. But, we have sufficient data that it happens much earlier. How early is what Dr. Sahai is going to talk to us. We all know him. He's professor and head department of endocrinology, Osmania Medical College and Hospital, Hyderabad, India. He's president, RSSDI, immediate past president, Endocrine Society of India, also president, South Asia Federation of Endocrine Societies, and president DIPSI. He's section editor, tropical endocrinology, endotext online textbook on endocrinology, and editorial board member of IJEM. Numerous awards and fellowships from country as well as across the globe. You can see here more than 180 publications in national and international journals, and he's authored n number of chapters in various textbooks and monograms of diabetes and endocrinology. So welcome, sir. And we would like to hear from you on what exactly is new when it comes to early GDM.
Thank you, Dr. Shalini, for the kind words of introduction. And as you said, that I would be focusing today on just this new aspect which has been discussed. Although I would say that this is something which in DIPSI we have been discussing about this from a long time. The guideline we have been speaking. I mean, we have been recommending early screening of gestational diabetes right from the first antenatal visit itself. And we are saying that we need to repeat this in the second and third trimester. If the first report is normal, then we repeat it in the second and third trimester. But internationally, I mean, this was not being followed across the globe. While we are very happy that in our country we have been following this this guideline as per what has been recommended by DIPSI, and also the Ministry of Health guideline also recommends this. So I'll just share my slides and. Yeah. Is it visible now?
Yes.
Yeah.
Put it in slide mode.
Yeah.
That
Just,
show mode. Yeah.
sir, I think it is. Yeah. Now it is in full
Yeah.
screen.
Visible, sir.
So thank you. Thank you. So as I was mentioning that I'm discussing this concept about early GDM, which is being discussed across the globe now. And as I mentioning, this is something which was being discussed in DIPSI from a long time. As Professor Shesha is here, he has always been recommending that we should be screening for gestational diabetes right at the first antenatal visit, and then repeating it in the second and third visits, third trimesters if it is normal in the first trimester. But across the globe, this was not what was being followed. And so now we all know that GDM is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. And this encompasses glucose intolerance irrespective of the form of treatment and or whether diabetes persists after pregnancy. And we all know that it occurs because of a pancreatic beta cell dysfunction in a background of insulin increase in insulin resistance due to pregnancy. Most guidelines, as I mentioned, although the DIPSI and Ministry of Health India, Ministry of Health guideline from India has been recommending first screening at the very first antenatal visit, and then repeating in the second and third trimesters. But most of the guidelines across the world have been focusing as has been speaking of GDM as screening for GDM only in the 24th and screening for GDM between the 24 to 28 week of gestation. So that has been the how it has been going on across the world. And therefore, what was referred now that some of the studies have shown that this early gestational diabetes is also a very common entity, and which was seen in, if you look back at the data from Dr. Shesha's group, we see that almost about close to about of the women, about 15 to 30% of women in the first trimester also had abnormalities. And the occurrence, I mean, amongst the women with GDM, at least one third or of them had early GDM also. So occurrence of now this entity has been sort of labeled as early GDM if it is happening in the first trimester of pregnancy, and late GDM if it is happening in conventionally between 24 to 28 weeks of gestation, which is also some of the researchers have used this term conventional gestational diabetes or late gestational diabetes to differentiate from this early GDM, which is being recognized in the first trimester. So early gestational diabetes has been defined as gestational diabetes diagnosed before 20 weeks of gestation. And in 2021, the global prevalence of early gestational diabetes varied from 0.7 to 36.8%, as reported in a systematic review of 41 studies. This was the prevalence that was seen across these 41 different studies from across the globe. And if you look at the predictors, the higher body mass index, a history of gestational diabetes in previous pregnancy, family history of diabetes, or multiparity have all been factors that predict the occurrence of early GDM. And adverse pregnancy outcomes were reported in women diagnosed with early GDM. And this is what we have been discussing in the, if you we have been aware of the fact that the earlier the occurrence of GDM in pregnancy, the greater is the need for insulin, greater the need for therapies, and the greater risk of various complications. So adverse pregnancy outcomes associated with early GDM are macrosomia, cesarean deliveries, induction of labor, then hypertension, preterm delivery, shoulder dystocia, and the incidence of postpartum dysglycemia and the need for insulin is higher amongst these women with early GDM. There's also evidence that postpartum conversion to pre-diabetes or type 2 diabetes, as well as the need for insulin use in the postpartum period also, was higher in women who had this early GDM as compared to those with conventional or late GDM. So this is a very interesting study which has looked at 166 individuals. This is a distinct showing that there is a distinct insulin physiology trajectories are seen in euglycemic pregnancies and gestational diabetes mellitus. So this is a study where they looked at the participants underwent oral glucose tolerance at less than 15 weeks of gestation that is an early pregnancy, and then they repeated this in mid or late pregnancy, that is between 24 to 32 weeks, and then did it in the postpartum period also. So they, based on the values obtained, they looked at the insulin disposition index and the Matsuda index, and they also looked at what is called as a insulin physiological index. And based on that, what they have seen is that in these 166 individuals with diabetes risk factors who were followed throughout pregnancy and postpartum with serial oral glucose tolerance, those with early pregnancy there was an early pregnancy augmentation of beta cell function in excess of insulin resistance, is which is seen in the in all women, in normal women who did not develop gestation. Deficient augmentation of beta cell function in early pregnancy appears to contribute to the development of GDM. And early onset of gestational insulin resistance is a distinct feature of early onset GDM. So this is some of the features that we've been seen. The green dots are those who did not meet the criteria for GDM in pregnancy. It means they were normal throughout pregnancy. They had normal glucose. Those women had normal glucose tolerance during pregnancy, and you can see the distribution of their Matsuda indices, and you can see that clearly they are different from the women who developed early GDM. Those are ones in the purple dots are those with early GDM who were detected before 15 weeks of gestation. And so the pregnancy insulin physiology index is a good estimate of the beta cell compensation for insulin resistance, and it predicts GDM when measured at less than 15 weeks gestation. So this is a index which they have highlighted, is very useful in terms of differentiating in or identifying those women who are likely to develop early gestational diabetes. So if you compare this early gestational diabetes versus conventional gestational diabetes, we can say that those with early gestational diabetes have greater decrease in insulin sensitivity, or rather they have higher insulin resistance. They have greater the quantitative insulin sensitivity check index decreases progressively. They have higher waist circumferences, blood pressure, and serum triglyceride levels compared to those with conventional GDM, suggesting a greater prevalence of metabolic syndrome in these women who have early GDM. And the fasting hyperglycemia is the predominant derangement and the driver behind the worsened perinatal outcomes in early GDM. Postprandial hyperglycemia is predominantly associated with large for gestational age and macrosomia and other adverse effects of conventional GDM. So pathophysiology of early GDM could be due to a dual defect of beta cell dysfunction and insulin resistance, making the metabolic profile of women with early GDM uniquely different from that of those with normal glucose tolerance, and even from those who develop the conventional or later developed GDM later in pregnancy. So this is how we see that there is a greater degree of insulin resistance and more of beta cell dysfunction in women who developed early GDM. In South Asians, the obstetric and sonographic evaluation showed higher anterior abdominal wall thickness even at 20 weeks, which is quite earlier than what happens with the conventional GDM, despite lower fetal measures, whether you look at the head circumference, abdominal circumference, or femur length, or bipedal diameter, all these being lower. Even with that, there is higher anterior abdominal wall thickness. This shows that the alterations in fetal growth can occur earlier than the conventional GDM diagnosis in South Asians. Fetal growth assessment reveals deviation in fetal growth trajectories even before the conventional GDM diagnosis, emphasizing the need to screen early in pregnancy, especially in our population. And this is what we have been speaking for many years right now. Now that and that is the main reason for using introducing the early screening in pregnancy by DIPSI. Now, whether fasting glucose should be used for diagnosis of GDM is one point of discussion, because in the DIPSI criteria we have been looking at mostly the postprandial glucose levels, post-meal glucose levels and post glucose challenge glucose levels, because of the fact that that is the one which is predominantly affected in gestational diabetes. But one point that is in favor of fasting glucose is that these are the changes in the fasting glucose levels can be seen early in pregnancy, associated with, and these are associated with worsened perinatal outcome, including a higher chance of large for gestational age infants and macrosomia, even in the absence of later development of GDM. So this is a point which needs to be further studied, where we have seen that where it is shown that fasting glucose levels in early pregnancy may be a factor that needs to be looked into. Pre-pregnancy BMI in the overweight range or above, in conjunction with a fasting glucose of more than 92 milligram per DL, may represent pregnancies at higher risk of complication and should be considered for close monitoring. Considering the limitations of currently available literature and the possible association between fasting hyperglycemia and worsened perinatal outcomes, the earlier proposed criteria of fasting glucose of more than 92 can be reconsidered as a possible threshold for the diagnosis of early GDM, because there's a lot of confusion now regarding what should be the diagnostic criteria. Although they have spoken of early GDM, but the criteria that were used was the IID PSG criteria itself, and there is a discussion on whether there should be a change in the criteria for there's a confusion about what should be the criteria for diagnosis of early GDM. The same cutoff will help to, I mean, the argument is that the same cutoff may help in maintaining consistency and uniformity, but needs to be validated in large multi-center studies. Now, whether an oral glucose tolerance can be used, that's again a point of discussion, and what has been suggested is that a first trimester OGTT with IID PSG cutoffs is not acceptable, not an accurate predictor of GDM, and close to half patients with deranged first trimester OGTT revert to normoglycemia at 24 to 28 weeks without any intervention. More false positives with first trimester OGTT are driven mainly by a higher number of women with elevated fasting plasma glucose. So again, the fasting plasma glucose, although it has been shown in some of the studies to correlate with some of the outcomes, but it has been shown that many of these women who have a higher fasting plasma glucose may actually revert to normoglycemia subsequently in the second and third trimester. So this is something which has been a matter of discussion and confusion. One study from Oman with 564 pregnant women suggested that early and multiple screening with OGTTs increases the detection rate of GDM with an improvement in the clinical outcomes. Another study with 125 singleton pregnancies diagnosed as early GDM using the IID PSG criteria before 16 weeks of gestation revealed that fasting hyperglycemia was associated with congenital malformations. And however, the mean pre-pregnancy BMI in this group was much higher than what we normally see in women from our country. And OGTT conducted during 18 to 20 weeks correlated with OGTT at 24 to 28 weeks and was linked to the development of large for gestational age and neonatal hyperinsulinemia. The DALI study, which was the vitamin D and lifestyle interventions for GDM prevention study, found that women with early GDM and BMI more than 29 kg per meter square represented a metabolically distinct group with higher insulin resistance and obesity and a higher risk for elevated blood pressure, triglycerides, free fatty acid, and 3-beta hydroxybutyrate heart rate. Now, the other issue that has been looked at is the using HbA1c itself as a predictor as a diagnostic criteria. A lower threshold of 4.8 for HbA1c has been proposed by some to lead to which saying that it may lead to an improvement in the pickup of gestational diabetes. A lower value could reliably rule out the risk of conventional GDM and identify women not requiring an OGTT between 24 to 28 weeks, because lower thresholds often has poor specificity and positive predictive value. Their role in predicting the risk of conventional GDM, however, is limited. And so therefore, there has been a lot of discussion on this as to what should be the cutoff of HbA1c to predict the development of GDM. A value between 5.25 and 6 has a significantly better positive predictive value, and that can be that has been suggested. A recent meta-analysis of 10 high-quality studies concluded that the risk of developing conventional GDM increases with the HbA1c of more than 5.7, and values more than 6 identify all women at risk of GDM. For early GDM, the value between 4.8 and 5.9 in early pregnancy seems to be a reasonable cutoff to rule out and predict the risk of conventional GDM. A single value that can strike a balance in terms of specificity and sensitivity has not been established, and the role of HbA1c in diagnostic pathway of early GDM requires further validation. So, while for the conventional GDM, we have been looking at a value of more than 5.7 as a predictor of development of GDM, but for early GDM, this has not been clarified in any of the studies. Some of the studies have looked at HbA1c of 5.9 events such as macrosomia, preeclampsia, major congenital anomalies, and soldier dystocia. And they report that many et al. Reported that early pregnancy HbA1c was a better predictor of pregnancy outcomes than fasting plasma glucose. So there's a lot of confusion about what should be the cutoff for HbA1c and for diagnosis of early GDM. Now, I would now just take you through this recent study called the treatment of booking gestational diabetes mellitus, that was to look at the benefits of treatment of early GDM from the toboggan study. So this was implemented in 17 sites across Australia, Sweden, Austria, and India. In this trial, 43,000 pregnant women were approached and consent was obtained from 4,000 women. Early screening was done using 75 gram OGTT following the IAD-PSG thresholds, and this was carried out in 3,681 women before 20 weeks of gestation to diagnose EGDM or early GDM. The 802 women were diagnosed to have EGDM, and they were randomized to either intervention arm or a control arm. Intervention arm in the interventional arm, there were about 406 women and 396 were in the control arm. And follow-up data is available on most of these women. So the primary composite endpoint was the adverse neonatal outcomes. This occurred in 24.9% of women in the interventional arm and 30.5% of women in the control arm, with an adjusted risk difference of 5.6 percentage points, which was statistically significant. So this showed that treatment of early GDM had led to an improvement in the adverse neonatal outcomes. When they looked at pregnancy-related hypertension, they found that this occurred in 10.6% in the intervention arm and 9.9% in the control arm, and which was not statistically different. And the adjusted mean difference in mean neonatal lean body mass was also not statistically different between the groups. There were no differences observed between the arms in respect of other adverse events. So the major benefit that was seen was in terms of the adverse neonatal outcomes. A secondary data analysis comparing the women with early GDM and those who had conventional GDM who initiated treatment in 24 to 28 weeks was carried out, and 254 women with EGDM and 467 women with conventional GDM and 2339 women who were controls were analyzed, and the composite outcomes were increased in early GDM with the odds ratio of almost a 60% increase in the composite outcomes, but not in early GDM as compared to late GDM. So showing that this early GDM is a very important aspect which has to be addressed. Higher birth centiles, preterm birth, and rates of neonatal jaundice were seen in the early GDM group, but not in the conventional GDM or the late GDM group. The need for insulin and metformin was also greater in the early GDM group, again highlighting the importance of early screening for gestational diabetes. The limitations that they have highlighted in their study from the authors from the toboggan study is that GDM management was not standardized in late GDM treatment. Targets were used for early GDM. The findings they felt were highlighting the need to diagnose and initiate treatment of women with early GDM. So based on this toboggan study and the other data that has accumulated on the early GDM, in some of the guidelines have been changed in 2023. The American Diabetes Association also is now recommending risk-based screening to diagnose overt diabetes with 75 gram glucose at the first antenatal visit itself. And while Diabetes in Pregnancy Study Group of India is one of the first to recommend the screening for hyperglycemia in the first trimester of pregnancy, other guidelines are also slowly understanding the importance of early GDM, and they are bringing out this change in their approach. So finally, there's a lot of confusion in terms of, across the globe, that whether early GDM should be screened, who should be screened, whether it should be universal or not. But we are very clear in terms, in our country at least, that from DIPSI, we are very clear that we need to screen every woman, because we have a high risk of gestational diabetes, and we are screening every woman at the first booking visit itself, and continue to do this in the second and third trimesters. Treat those who are picked up as having GDM in the first visit itself, and those who are screen negative, they are screened in the second and third trimesters also. So this is something which has been the discussion on early GDM. So with that, I'll conclude, and I'll be happy to take any questions. And I think the subsequent talks, we're going to have a lot of interesting discussion on the diagnosis of GDM and the management of GDM itself. So I was focusing only on some of the new literature that has come out on early GDM.
Thank you, Dr. Rakesh, for a awesome session on early GDM. Of course, we'll have certain questions in the panel discussion toward the end. So I'll request you to stay back. Just a comment what you said, that there have been various studies focusing on HbA1c as a predictor for development of early GDM. Recently, we published in IJJDC a editorial I wrote with Dr. Hema, where we reviewed postpartum screening and the importance of fourth trimester, like first, second, third, and fourth trimester in long-term prevention of GDM in those females and doing some help to the offsprings. There we came across a couple of the studies that actually there is no consensus on HbA1c in terms of prediction of early GDM. That is one. Second important thing is one study I came across. Fortunately, sir is here, Dr. Shai and Dr. Balaji group. They have done a systematic analysis, which I have published and cited in that editorial also, where, if I correctly remember, it was 5.3 as a mean HbA1c in Indian patient. Based on that evidence, they said that anything more than that, they are the one who are likely to get converted to early GDM. Although it is very difficult to say that anyone who has 5.5, which is absolutely normal, why will she convert to GDM? Because even at the time of conception, even if it is 5.5 or 5.66, that our first trimester will have actually lower sugars. Mean fasting will be close to 74, and postprandial will never exceed 99 plus minus 10. That means it will never cross 110. So I think the importance of existing or baseline HbA1c at the time of conception is very, very, you may say, fallacious, because no way it will be able to predict until unless someone has HbA1c more than 5.7, falls into the category of IGT or pre-diabetes, and they are the one who are likely to get converted to type 2 diabetes. Amongst us, me, Dr. Shalini, we have shared about 40 pregnancies, those who have had developed GDM at 8 to 10 weeks, and they had normal HbA1c close to 5.5. That means HbA1c may be absolutely normal, but still you might have a early GDM coming as early as 10 weeks. That is why Professor Shai rightly says that there is a need for primordial prevention, and you must screen everyone at 8 weeks and do that intervention, either MNT or insulin or metformin. 2 studies now we have published that if you intervene at that stage, probably you might be able to avert that hyperinsulinemia in beta cells of fetus to prevent long-term conversion to NCD. Just a comment. And if you want to answer it, then towards the panel, I'll request you to
We can have all the discussion in the panel discussion, sir, because
Okay.
otherwise
Okay.
we'll
Okay.
Right, sir. So with that, we now move on to our next session. Unfortunately, Professor Balaji had an emergency, so he's not able to log in. So we've requested Dr. Bhavtarini to take over his topic as well. So she will be talking on screening for GDM, why, when, and how. All of us know her as Honorary Professor of Diabetology, State IMA, State Coordinator IMA Diabetes Course, Governing Council Member of RSSDI and DIPSI, faculty in a lot of training programs, Best Teacher Award at IMA, WDF Regional Coordinator for GDM, faculty for a lot of things, and the flag bearer of DIPSI. So welcome, ma'am.
Thank you. Thank you, Dr. Shalini. I immensely thank Dr. Rajiv Chawla and Shalini for giving me this wonderful opportunity. Excellent program. I congratulate you both. Now coming to the topic, which is Balaji's, I'll say how much I can make it, I'll do it. This is screening GDM, why, when, and how. That's what I'm going to focus today. See, these problems, congenital malformations, small babies, big babies, microsomia, hydramnias, and hypertension in future life, obesity, cardiac problems. For all this, GDM is the mother of all these non-communicable diseases. So we need to screen. Why? This is the reason. And why we are focusing on pregnant women. If we focus on her, we are going to hit 2 mangoes in a single shot. That is, we are preventing diabetes in the mother as well as the child. And that is 2 generations at the risk of developing diabetes or prevent, that is the mother herself and the offspring. If you take, according to IDF, we know that low and middle income countries account for 85% of the annual global deliveries and 80% of this global diabetes burden, and 90% of all this maternal and perinatal deaths are due to poor pregnancy outcome. Stepping down from ivory towers to ground reality, if you take pains to go and see what is happening in the lower socioeconomic places, that is, I have traveled through all these non-metro areas, primary health centers, and found it's very difficult for the pregnant woman to come in fasting. Out of 5,000, only just 369 has come in fasting. That too, they have been asked to come in fasting for some other reason, and not that they have come really in fasting. See the huge crowd, what we face in the rural areas. For doing the regular GTT, we need 3 venous samples. There is not adequate strips, reagents, syringes, lab technicians, paramedicals, doctors. Even the drinking water is not available. Somebody has to donate. And every PHC has to tackle at least 100 to 150 pregnant cases on this antenatal day. And the PHC opens by 8 a.m. only for fasting GTT. Even if it takes just 2 minutes for each case, for all these cases to be covered, it takes more than 1 hour, by which time few cases would have crossed the 1 hour and few would have crossed even the 2nd hour also. If both the medical officer and the staffs in the PHC can finish their routine in a single visit, it will be easy for all the patients, staffs, attendees, medical officers, and to the nation as such. The second visit becomes unnecessary. And if you see the proportion of obstetrician to patients, it's very low, and there is no medical officer at all in some PHCs, and they are deputed from elsewhere. In Tamil Nadu, if you see, they give around 18,000 rupees to all the antenatal cases. So even the affordable, they come only to the government hospitals to get this free money. Naturally, the crowd becomes more. And if you take the pregnant woman, she's a household, she's a caretaker of the home, and she has to take care of her house members. Not only that, all the domestic animals, what she has, goat, cows, and this dogs, all this. And after finishing her routine, only she can come. And she is not in the town. She is in a remote area where there is no transport facilities, and they have only at particular time of the day. And to reach that bus stop itself, she has to walk for up to 1 kilometer. And then to reach the PHC and get a turn, it takes another half to 1 hour. By all this time, she cannot keep herself in fasting. And the PHC also, it's in such a way that it is not open round the clock. That is, she cannot go as she likes. She has to report in the morning to get a turn. And again, because of the huge crowd in the PHC, to get a turn to see the medical officer and get the advice first, it takes another 1 hour. So all these are difficult in fasting for a pregnant woman. They can easily faint. And elders in the family also don't allow them without eating something in the morning. They strongly believe that pregnant women should not fast for a long time. And they don't come alone. They are always accompanied by some attenders. By them, both are daily wages. If they are already, by this visit, they have lost 2 wages, they are asked to come again in fasting, they will not return, and we'll have dropouts. So thinking all this, and see this lady, she is working on a May 1 Labor Day, that too on Sunday. If she is not doing her work, her family will be deprived of food. So she has to work even on that day. In pregnant, fasting is always low. You know that insulin sensitivity high and the muscle takes up more glucose, neoglucogenesis comes down, and there is a less hepatic glucose out of. So fasting blood sugar is very low. And again, if you see we go for early ketosis, they are more ketose prone because of the accelerated starvation. And fetus is a continually eating border in an intermittently eating host, and she has to eat for 2, and she feels hungry more easily. And she has another problem, hyperemesis. The hyperosmolarity associated with a GTT solution frequently leads to GI intolerance and nausea and vomiting. If they come in fasting, they vomit, and all efforts of coming in fasting again becomes waste. So pregnant refuse to undergo GTT in fasting and tolerate glucose better in non-fasting state because vomiting is less and the problem is solved by screening and diagnosing in the same visit. We know that there is no deliveries. Number of deliveries has increased on one hand, and GDM is also in the continuous rise on the other hand because of the sedentary lifestyle, PCOS, ethnicity, strong family history, overeating, late marriage, and further delaying the child, and early occurrence of diabetes. All these put together, the occurrence of diabetes during pregnancy is increasing, and we need to take care much. Everybody in the GH are overburdened, and they always want and welcome whichever is easier, simple, at the same time useful, which will prevent the mortality and morbidity in the mother. And another thing, we know that we Indians are 11 times more prone to diabetes than Caucasians, and we have a strong genetic predisposition, and all these causes necessitate universal screening. That is, every other pregnant woman has to be screened for diabetes in pregnancy. So what is the solution? All these practical problems make pregnant ladies unable to come in fasting. Our DIPSI, Diabetes in Pregnancy group, solves the problem. Our Menta has given a single step, which is very easy for them, which can be done in the fasting or non-fasting state. The advantage is the pregnant woman need not be in fasting. Non-fasting would simplify the procedure and causes least disturbances in the pregnant woman's routine activities, serves both as a screening as well as diagnostic procedure. Again, if you take WIGO, WHO, and IDF, this fulfills the expectations of all these associations that in lower socio-economic countries like us, we have to do something in the pregnant woman, whatever they can, depending on the resources available, that is to screen every pregnant woman for glucose abnormality for a diabetes-free generation in the future. And DIPSI was started with a motto to prevent diabetes in the community by catching as early as the GD when possible with this simple single test. And if you do the capacity building for this medical officers, paramedical staffs, and public health, by the simple question, that is whom to screen for GDM, when to screen, and how to screen for GDM. These questions were very much confusing for the doctors, and they explained the difficulties of convincing the patient to come for 2 days and give 4 samples, and the facilities not available for such a long procedure, and difficulties in waiting and fasting. The response was very poor earlier, that is in 2004. In contrast, after implementing the simplest DIPSI single-step procedure approved by the government of Tamil Nadu, also called as Tamil Nadu model and accepted by Government of India as our national guidelines, WHO, FIGO, and IDF, the response is so good because mainly of its simplicity and more economical. So remember, most complicated problems in the universe as a simple solution, said Albert Einstein. Yes, our Menta has given a very simple solution, just to do one test with 75 grams of oral glucose in the fasting or non-fasting state. And just remember one value to diagnose, 140 or more. And further monitoring also, it's very easy. All postprandial has to be less than 120 given by our mentor, Professor Dr. Seshia. So when to and universal screening is because we are 11 times more prone. And again, early screening, it's because we have this GDM getting expressed in all trimesters. This again, our Menta has done a study in 2007 and proved that GDM in the first trimester is 11%. GDM in the second trimester is 22. Of course, it is more in the third trimester. But if you're going to do only in the third trimester, you are going to miss almost 50%, which occurs in the first and second trimester. And this test he has repeated again. This he has done long ago. That is in 2007. He has shown that it manifests in all trimester, first, second, and third. Then again, he repeated in the 2016, that is 10 years later, what he has found, it has doubled. In first trimester, what happened to be 11 has become 22. And again, the second trimester, which was 22, has become 35. And of course, it has come down in the third trimester. It is because of the paradigm shift of our lifestyle, which is keeping on changing. And already there has occurred a transgenerational transmission of this diabetes from generation to generation. Now it is commonly occurring in the very first trimester. So only our Menta, in spite of catching them in the first trimester, we are not able to bring down the incidence of diabetes and other non-communicable disease in the future. He has gone to the level of primordial prevention of diabetes, that is to catch these women at 8th week so that we stop the insulin secretion in the fetus, which is the cause for hyperinsulinemia, which is the cause for all non-communicable diseases in the future of the child. Thank you.
Next is your session only.
Yes.
That is management of
Yes.
GDM. So I think you are already introduced, so you may continue with your presentation. Toward the end, we will have discussion. Thank you. And thanks for accommodating at the last moment.
Thank you.
Thank you.
So again, coming to my topic, that is hyperglycemia in pregnancy management in 2024. Again, my pranams to my mentor, Professor Dr. Seshia, and immense thanks to Dr. Rajiv and Shalini for this wonderful opportunity. And if you talk management, it depends on the type what they have. We know we have pre-GDM and GDM, that is the pre-existing type 1 or type 2 diabetes, and also the diabetes detected for the first time during pregnancy. Along with that, we have GDM. We need to know what type of diabetes before going for management. We know that these are all prevalent GDM, whereas the one which is occurring only because of the hormonal diabetogenic stress is the GDM. And why we say these are different, the incident is different from prevalent, because the visits vary according to the blood sugar, the glycemic goals differ, that they have different fasting and postprandial, they have different HbA1c, they have a different meal plan, HB% is different, they have a different BP and pulse, different treatment regimes, and also the time in range.
Problem? Stuti? Stuti?
Yes, sir.
Some problem?
She logged out, sir. I'll just call her
Please,
and
yeah.
look into it.
Just help her out. In the meantime, can we have some discussion on diagnosis?
Dr. Chawla, how do we know early GDM is not pre-pregnancy diabetes?
That is where we do an HbA1c if it is absolutely normal. For pre-pregnancy, that is what I was discussing. normally we take as 5.7. Dr. Shishai sir and Balaji had an evidence that mean HbA1c in normal female who conceives is usually 5.3. If it is more than that, we should look into that. That probably they are the one who are likely to get converted to type 2 diabetes. But most of the international evidences say that anything 5.7 to 6, they consider it is significant. But obviously, when we are talking of early GDM at 10 weeks or 12 weeks, we have to have an HbA1c which is absolutely normal, less than 5.5. Only then we can say it is a new onset GD. Otherwise, it becomes a pre-existing. Yeah, Dr. Bhavtarni is back. Over to you, madam. You are muted. Please unmute yourself. You are muted, Dr. Bhavtarni.
I'll do it. Yeah.
Please.
So I think the previous slides came. I hope this is the slide where I stopped. Am I correct?
Yes.
Yeah. So all these differ between the incident and prevalent GDM. And again, I want to stress first and foremost is diagnosis important, which I have said already. It is the single step procedure with 75 grams and single value to remember 140 and for further monitoring 120. So with this, you have to do it as early as possible. Otherwise, by 11th week, the fetal handling starts. If you're going to do it later, you're going to miss GDM in the mother and you'll have false negative tests. The mother may be having normal blood sugar, but the baby will have all the problems because of hyperinsulinemia, which has developed because of fetal handling. And 1 in 6 live births to women with have some form of hyperglycemia. In this majority, almost 90% is GDM. And this GDM is because of our improper lifestyle. 90% of this woman can be managed by medical nutrition therapy and exercise. You put them on medical nutrition therapy and exercise for 2 weeks. If in spite of them, they are not coming down, fasting is more than 90 or 2 hours, more than 120, think about adding some pharmacotherapy. Whereas if the blood sugar is at the beginning, it's more than 200 or 200, you have to go away, straight away, go with insulin along with this medical nutrition therapy. Our medical nutrition therapy goal is to achieve a normal blood glucose level without any ketosis and provide adequate weight gain with appropriate fetal growth and development. It should be a carbohydrate limited diet with just 33 to 40% of total calories, with remaining calories derived from protein and fat, along with vitamins and minerals. And ADA gives guidelines from dietary reference intake, that is DRI. This gives that we need to take 175 gram of carbohydrate during pregnancy, that is 35% of 2000 calories. Whereas in non-pregnant, if you see, it's just 130, but we all are taking more than 250. Of course, we have to cut down the carbohydrates during pregnancy, and with a minimum of 71 grams of protein and 28 grams of fiber. Emphasis should be more on monounsaturated and polyunsaturated fats, and we need to limit the saturated fats and avoid trans fats. And of course, in our country, the women is given more importance only during pregnancy, and it's celebrated throughout. This has to be brought down. And nowadays, it's a day of fast food everywhere. They have all this being more sedentary. All these has to be avoided, and this just simple slogan is make your food and take only homemade food. That's all. And what is the increment you allow? Of course, in the first trimester, they don't need any increment. Second, of course, it's very easy, just 340 calories, etc. And third trimester, additional 452 calories in a simple way. Or you go according to the weight gain. And remember, they can put on weight just from 7 to 12 kgs during pregnancy, not more than that. See the weight gain, if it is 0.8 to 1.2 times, so ideal, then you can go for the ideal calories, that is 30 kilocalories per kg. And if it is 1.2 to 1.5 times the ideal body weight, reduce it to just 24 kilocalories. And if it is very less, that is 0.8 of the ideal body weight, you have to increase the calories to 35. You can go even to 40 kilocalories also. And if it is 1.5 times, that is, she's putting on more weight than the ideal body weight, that means you have to restrict to 18 kilocalories per kg. And remember that the pregnancy is not the time where you can reduce your weight. It's just reducing the calorie, but you should not go for weight reduction during pregnancy. And the very main thing is, instead of taking 3 meals, what we usually take, it has been split into 6, in between 2 snacks and 1 bedtime snack. And remember this ADA plot model, which is very easy: half plate full of greens and vegetables and only quarter of whole grains, and the other equal amount we have to give importance for the proteins. So what we are taking is 3/4 plate full of carbohydrates and very little of protein and the vitamins and minerals. This has to be avoided, and we need to go for this ADA plate model. Regarding non-nutritive sweeteners, there is a limited data, but FDA approves this acesulfame, aspartame, sucralose, neotame, stevia, all that. But American Medical Association did not recommend the use of saccharin, and ADA and American Dietetic Association consider these non-nutritive sweeteners safe only when they're used in moderation. And exercise is very important therapy during pregnancy. They can do any form of exercise according to their wish, either walking.
Logged off.
Shruti, you are helping?
Yes, ma'am. She's here.
She's there, Dr. Bhavtarni. Yeah. You're muted. Please unmute yourself. Unmute yourself.
Sorry. So no current from morning. That is the problem. So they have to continue the routine activities, pre-pregnancy activity. Along with that, they have to increase their activity. But nowadays, it's a day of precious child. And again, what they say, they should not do this exercise, that like that. In that case, they can do the upper body ergometric exercises, but do not start with any vigorous exercise during pregnancy. And after trying all this medical nutrition therapy, that is the food and exercise, you then only think about pharmacotherapy. And remember, insulin is the best both for the safety of child as well as the mother, because it will not cross the placenta and stimulate the fetal beta cells, whereas oral drugs cross the placenta, not our metformin. And you need to keep a target, that is all pre-meal and fasting less than 90, and 1 hour less than 140, and 2 hours less than 140, according to the 5th International Workshop Conference on Gestational Diabetes. And Jocelyn, what he says, that if glycemic control can be maximized to the extent that the fetus no longer recognizes that its mother is diabetes, then the treatment of other during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring. He has told long back, which our mentor has got the idea and is trying to do all this. And what are the insulins that can be used during pregnancy? You need to know that all human insulins, regular NPH mixed all mixtures can be used. As far as analogs are concerned, and rapid acting, you can use Aspart and Lispro, but not Luluzin. In ultra fast acting, yes, it can be used. In long acting, Detimir and Degludec are approved. Glargine needs more studies, but if the patient is already on Glargine, they can continue Glargine. Premix, all analogs, no mix, Humalog, all can be used. If it is a GDM, we have to go for either basal or mix one day or split mix. In case of pre-GDM type 1 and type 2, we have to go for basal bolus therapy. That is a rapid acting for all meals with one long acting. Or if it is a GDM, just once a day premix, or sometimes twice a day we have to go. And if you take the insulin physiology, in early pregnancy, they have an enhanced sensitivity. So they require less insulin and more risk for hypoglycemia. But in the second trimester, the insulin resistance increases. So the total daily dose also starts increasing linearly. That is 5% increase per week up to 36 weeks. So there happens doubling of the total daily dose compared with pre-pregnancy. And there is increase in both basal and bolus. bolus takes up a larger proportion because postprandial is the main race and we need to concentrate more on this. This is the one causes more problems also. And then levels of end of the third trimester. And if you see any placental insufficiency, that is sharp reduction in total daily dose, think of fetal demise. This also can happen. And Orden Langer, what he says, it is appropriate to use the dose needed to achieve new normoglycemic levels without undue concern about giving too much insulin to our patients. Our main concern should be blood glucose result rather than the dose of insulin. And again, don't worry about hypoglycemia. Drury has told long back that hypoglycemia is common, of course. Happily, it is not a harmful, and he has recorded almost 100 pregnancies in which hypoglycemic coma has occurred at least once without any harmful effect for the mother and baby. But still, you have to go for hypoglycemia prevention, educate the mother well about avoiding hypo by doing frequent home glucose monitoring, educating regarding the symptoms of hypoglycemia and teaching them self-monitoring of blood glucose and use of analogs to achieve better PPG control, which has a lower risk of hypoglycemia, and also CGMS with pumps where necessary. And whenever you put them on insulin, you have to teach them the injection technique, storage, and do a pre-injection counseling, teach them SMBG, prepare them, and device mismatch, all has to be taught. Storage, injection site, techniques, hypoglycemia, all has to be taught before putting them on insulin. Regarding the site, in the first trimester, women should be reassured that no change in insulin site or technique is needed. Second trimester, go for the lateral aspects of the abdomen, can be used for injecting insulin, staying away from the skin over the fetus. And third, of course, as mentioned in the Fit India guidelines, it can be injected over the abdomen while ensuring that the skin fold is properly raised. And in apprehensive patients, you can go to the thigh or upper arm to inject themselves. And of course, in very brittle cases like type 1 or type 2, you have to go for insulin pump. And peripartum, maintain the insulin dose in such a manner you avoid maternal hyperglycemia during labor because you need to prevent fetal acidosis, neonatal asphyxia, and also neonatal hypoglycemia. And intrapartum, withhold the morning dose of insulin if you're planning for induction or cesarean delivery early in the morning. And better start with a 5% dextrose solution, 100 ml per hour. Simultaneously, you start a separate regular insulin infusion. That is 0.5 units per hour with hourly blood glucose measurement. You have to go according to the blood sugar and maintain the blood sugar between 80 and 110. And during delivery, when active labor begins, insulin infusion is used in pregidium. In contrast, GDM with a detachment of the placenta and placental hormonal stress, it requires no insulin once the labor begins. It may be no insulin may be required immediately after expulsion of the placenta in progebium, whereas in a non-diabetic, insulin has to be adjusted according to the blood sugar, or usually it becomes halved. And a word about OHA, they are using Ordered Langer has told in 2000 New England Journal that glyburide can be used. As far as our country is concerned, it is not approved, but metformin is very safe throughout pregnancy. This glucophage metformin was approved in the first as the first oral anti-diabetic to be used safely from conception to birth. Not only that, insulin resistant only causes preeclampsia. So this metformin again lowers the risk of pregnancy-induced hypertension and preeclampsia. Once we follow the primordial prevention, what our mentor says, we have a almost carefree cakewalk throughout pregnancy without any problem whatever occurs because of this metabolic aberration. If it happens to your pre-GDM, preconceptional control is very important by educating them, proper nutrition, obstetric assessment, screening for complications, all are necessary along with glycemic control. And you see to the HbA1c, bring it down below 6.5, see to that whether they are on ARB, ACE or statins, and do a comprehensive eye examination and screen for creatinine and ACR, because all these get aggravated during pregnancy. Your target HbA1c should be less than 6 here, or relax if they go for more hypos. And of course, CGMS may be used in addition to this, but always go for blood sugar monitoring also along with that. Here, of course, the pre-meal glucose can be between 70 and 95, 1 hour 110 to 140, and 2 hour 100 to 120, along with aspirin at 12 to 16 weeks, and also folic acid supplementation. And regarding the timing of delivery, GDM control with diet and exercise, not before 39 weeks unless otherwise indicated. And in GDM with well-controlled medications, delivery can go up to 39 weeks. And poorly controlled, of course, and you need the expert opinion. Earlier delivery is better to avoid prematurity and also stillbirth. So it's better between 37 and 38 weeks. Word about lactation, this is very important. Once the baby is born, as Dr. Shahai was saying, postpartum care is more important and equal to that antepartum care, what we give. Here you should recommend more early lactation. Lactation has got a lasting favorable effects on the maternal metabolism to protect against future disease risk. It brings down the diabetes incidence both in the mother as well as the child. And whatever metabolic aberrations which has happened during GDM all gets reversed by promoting lactation and resets all the maternal metabolism. Follow-up is very important. You repeat the GTT at 4 to 6 weeks after postpartum with the same 75 grams glucose, and again repeat it after 6 months and every year. But the values are here. It's enough if the fasting is less than 100 and 2 hour less than 140, not like where we keep it less than 90 in pregnancy. The fasting is low in pregnancy. Now, here again, our mentor will explain in his speech that it can be done at the 3rd day, that is at the time of discharge, which is equal to what we do at 4 to 6 weeks. This has been done in Chennai as well as another study in US. As far as the time and range is concerned, we need a very strict control in GDM than type 1 or type 2. And we need a 24/7 round-the-clock control. So always follow with blood sugar before and after for all 3 meals with bedtime blood sugar. Maintain time in range very tight for GDM patients. And again, we go for prophylactic steroids during pregnancy. Here again, the blood sugar is very much brittle, variable. There is a high variability and increase in blood sugar. There you have to increase the dose up to 40% in the night alone when you give the first dose, and the 2nd and 3rd days you have to increase the dose by 40%. So all 4 doses has to be increased by 40%. 3rd day you reduce the increment to 20%, 4th 10%. Then almost by 5th, 6th days you can revert back to the original days. This days you have to follow properly. So screen all pregnant women for glucose intolerance early in pregnancy. Once diagnosed, prescribe nutrition therapy, exercise, and SMBG. Start insulin if the SMBG values are above target. Preconceptional optimization is very important, utmost importance. And basal bolus regime is approved for pre-GDM as far as pre-GDM is concerned. And metformin can be used from conception to delivery for primordial prevention of diabetes, which my next speaker is going to talk. You do a 2-hour PP at 8th week of pregnancy. If it is between 110 and 119, you start them on metformin and continue it delivery till delivery to prevent GDM and also NCDs in the future. Thank you.
Thank you so much, ma'am, for that comprehensive coverage on management of hyperglycemia in pregnancy. And I'll request you to stay back for the panel discussion at 5:30. So with that, we started with early GDM, then we talked about screening and diagnosis, and we went on to management of hyperglycemia in pregnancy. What happens postpartum and then between 2 pregnancies is again a very, very important low-hanging fruit that we often miss. So this is something that our next speaker, Dr. Hema Divakar ma'am, is going to shed light on. A very, very active, a very, very voracious flag bearer of DIPSI as well as management of diabetes in pregnancy. She is CEO and Chairman, Asian Research and Training Institute for Skill Transfer. She's won the FICCI Award for Excellence in Capacity Building, Divisional Director, FIGO Well Woman Healthcare, President Karnataka AHPI, State Representative HSSC Karnataka, Chair Nutrition and Breastfeeding Committee SAFOG, UNICEF Ambassador for Impact for Nutrition, ex-chair of Well Women Healthcare at FIGO, ex-president of DIPSI, ex-dean Karnataka College of Obs and Gynaes, past president FOCSI 2013, and numerous awards, orations, fellowships to her credit, and a very great orator who talks with all the passion that you see in her work. So welcome, ma'am. We're so happy to have you join us. And she will be shedding light on preconception counseling as well as postpartum follow-up.
Thank you so
Welcome,
much.
Dr.
Namaskar.
Shobha Madam.
And thanks to Rajiv ji and Shalini for putting us all together yet again on a common platform, which I very affectionately call the Sweet Connect, because it's so delightful to see Piki and Bhavtarni and Meena, Visha and others. And of course, to constantly draw inspiration from Sheshaya sir, whom I have been seeing his, of course, he's sipped a cup of tea, but he's been sitting with his attention to
Always.
every word of what each one of us are going to be speaking. And it's quite amazing
3 hours, he is always
sight.
attentive. Always
Amazing
attentive.
sight to see
Amazing.
such meticulous attention that he pays time and again. Thank you, sir, for yet again being here. So as how this, Bhavatarani was saying, that such a complex situation in India, this is saying far away and so many patients and this can't be done. But, slowly and steadily, India is leaping forward. The new India is getting better and better each day. And therefore, in this background, you will see health for her. It is our duty, utmost duty, to ensure health for her throughout the life course. Otherwise, we are really failing our girls and women. And another board which I've put up there, Femtech 360, that is my new passion area and craze, because I really think like how we are connecting today with the virtue of technology. We can achieve a lot with the remote monitoring, remote control, etc. So we do hope that 3,000 plus startups in India and several more across the world will bring to our doorstep something which will make us do better and quality driven. And of course, out of the box ideas that we have had from the DIPSI mentors and leaders have set the standards for the entire globe. And the outstanding example of that was the single step test, which everybody took on to during the COVID times. So that was quite amazing that when there was so much on the rooftop shouting at the evidence that we didn't have, etc. And quickly they got their act together, because necessity is really something that we cannot bypass. So the issue at hand is, Bhavtani showed one beautiful picture of, such a grand festive backdrop where the pregnant woman is being so much pampered. But seriously, before and after that, she's forgotten. That is the truth, the ground reality. Because pre-pregnancy, she'll think, let me see when I get pregnant. Then post-pregnancy, she's had enough and more in pregnancy. So she says, no, not anymore. Now I had, now let anything happen. Shall we just confirm if you can see my slides, dear? Yes? Yeah. Okay. So this is really a call to the OBGYNs, because we are the ones who are in continuous, that so many of our patients from their menarche to menopause, they're with us. From their adolescent time, their mother is pulled on. This baby was born in your hospital, and then the journey goes on. So like Usha said, we tag her for her entire life. We have things to do with her at every phase of life, and we really are going to be missing the window of opportunity if we don't pay attention to the available opportunity, the pre-pregnancy, during pregnancy. Because Meena just asked about how do you make sure that the JDM was before or after. We have decluttered and say hyperglycemia. When she comes to us, she's pregnant and she is hyperglycemic. What is our aim? Focus and get her sugars down. That's it. For the best benefit that the baby could have in the programming and the best benefit the mother could have. So that, with that spirit, we are working, and we never thought this diabetes issue will come on our lap so heavily that we have to pay attention to it sooner or later. And thanks to Sheshaya sir and the Dipsy group who really opened our eyes into so much more that not only we can do, but we should do, because there is a whole impact on the present and the future generation, that the NCDs, which are killing the women. We say, save the mothers during delivery. And what are we saving them for? The quality of life and the economics of the family. If every mother who has had high sugars in pregnancy continues to have type 2 diabetes, cardiovascular diseases, everything, just imagine the burden on the family. So prevention is really something. And these are the time spans where we can pay attention to the mother and infant combination. Also good because the target is available to us. We cannot go chasing pre and post, but definitely in pregnancy, 80,000 rupees or 18,000 rupees or whatever Bhavatani said, they will come. Institutional deliveries, amazingly more in India. So at that time, it's the best time to invest, to test every pregnant woman, to do the best, control her sugar, so that the infant, next generation, when it grows into childhood and adolescent, we track them, make sure that the glycemic status, obesity, etc. is okay, then follow them in adulthood. If it's a girl child, she may also become pregnant, and then the cycle goes on. The intergenerational, what we've talked about, it's a classic example of how we can rotate with the karma theory throughout her life. So here again, the same vicious cycle is shown. See, prevent obesity, PCOS, preeclampsia, etc. in pregnancy. There's a young woman with diabetes, or she's at high risk because of obesity and other epigenetic issues. Then she becomes pregnant. You have to control her hyperglycemia. Then the infant born, don't lose track of that. Again, because that may get into the state of obesity and diabetes in the youth. So as I said, we have to break this vicious cycle somehow or the other. The preconception disorders, which are all listed here, they are the opportunity to be seized to do the best in time, because the impact of not doing anything here, you would be creating 1.9 million extra neonatal deaths, 0.82 million stillbirths, 0.16 million maternal deaths by the year 2025 if you do not do. The numbers are mind-boggling. And as we all know, the majority of the burden of deliveries lies in the low middle income countries, including India, which has 30 million deliveries every year. And so these millions can very well relate to us. This is the famous Figo wellness wheel we have produced. And just as in the fun fairs, and you see, that wheel goes like this, it's turning, rotating, all that. Anywhere you catch the women in this cycle, do the best for the next phase of her life. Adolescent, you've got, prepare her for reproduction. Reproductive, you've got, okay, long-term problems in menopause. So never lose this opportunity. And the goal of preconception care, obviously, is optimal blood glucose control. There are often comorbidities, blood pressure to be measured, cholesterol, etc. Must make sure that folic acid should be taken. Now, there are newer makes of folic acid with iodine. Hypothyroidism is also one great problem in our country. Iodized salts are there, but still, anyways, you're giving folic acid, choose those which has iodine so that at least that problem is also somewhat taken care of. She may be already on some medication, so you have to review and adjust them. Smoking, alcohol, it's increasingly becoming common in the metro cities, and we really have to, take that history and advise them. And education, not only the mother, but the whole family, because diet, whatever said and done, they'll go home and do their own things because they believe that we are, really restricting her cravings, etc. Exercise, again, IVF pregnancy is high risk. They think that they should be bedridden only. So there's a new kind of problems. The pharmacological treatment and the evaluation, which I said also can be done now remotely, should be. So preconception, we have three situations. She's already a known diabetic, or she has high sugars prior to her first conception, or she's had previous pregnancy with GDM, which may have been detected, may have been missed, but she has a potentially the next pregnancy also, Pakka GDM she will have. But many of our patients are now paying so much attention in the interval period after the proper counseling that first pregnancy, they may have been on strict diet control, OHAs, and towards the term, they may have also been on insulin, but second pregnancy, pre-pregnancy onwards, it's become a lifestyle change. And they seldom require a dose or two of the OHAs closer to term, and definitely not the insulin. So this change is happening, and we have to invest our time in education for sure. For individuals with diabetes, if you do not optimize the blood sugars, again, you're in a jam because HbA1c will be high, sugars are high. It's a period of organogenesis. Whether 25% chances of anomalies, but 75% may still be normal, whether the small anomalies are missed, whether obesity itself is causing miscarriage, everything becomes a huge mess on our table when this data is documented. And we are really, always more apprehensive than the patient as to what we may find in her next visit. Those with PCOS and obesity, we are urging the fertility specialists to whom these obese PCOS go. They have to really, it's a very good opportunity for pre-pregnancy care. They're not conceiving, they're going there. So let's not blame them for not coming to us. Even when they're coming, are we doing enough? That's the question. So this target also, we are sensitizing the infertility colleagues, which have become a totally different compartment. They're working in their own silos, but we have to pull them and say that, these things, they have to really pay attention. And previous gestational diabetes, we have to mark, we have to circle. And please remember, she has had a previous IUD or a large birth weight baby in some other setup where she may not even have undergone a sugar test. Potentially, your mind should think that she may have been a case of previous GDM, which has been missed. So you have to be very cautious about how her glycemic levels will be in this pregnancy. Again, going back to the technology, many times now they come for preconception counseling. There's a long list of things we can ask. Sometimes we may not have the time, or they may not have the patience. Some things like domestic violence, smoking, alcoholism, etc., should be taken in a very subtle, sensitive, anonymous way. Moreover, lots of things about the deficiencies, vaccination status, previous pregnancy details, everything. 80% of the patients these are available in 10 different languages. So they can easily fill up, or at least they'll say, don't know. So you can quickly check back on what else you need to check with them. At the end of it, if the response is green, they're good to go. If it's amber, they need some tests. If it's red, then it's a red alert, because there may be some more tests that we may have to do. Nutrition exercise, beautifully explained by Bhavatarni, showing all kinds of plates. That is ADA plate. Now we've got Dipsy plate, where we have written March 10th, Shesha's birthday, GDM Awareness Day, and then about 25,000 gynecologists have already got it. Year after year, every year we are giving 5,000 plates on Sir's birthday, and then it's going on. So that plate is got. We have particularly chosen some Indian food stuff to be picturized there, so that, they get it into their heads. Preconceptional checklist with FIGO, which is just taking 2 to 3 minutes. The FIGO nutrition checklist, preconception and in pregnancy, has become a very integral part of the OBGYN care now, because we've made enough noise and everybody is filling it up. Again, the apps are coming to our rescue. Some very good apps on nutrition. You may not have time. Bhavatari may say only about idli, but somebody else wants a fish. So what to tell? So there is a lot of things that our recipes are also available on the apps with exactly what they contain, what is the calories, what is the carbohydrate, protein. They are very much empowered, and they're enthusiastic about following it meticulously. So let's use these more and more. And the target blood sugar levels, adjustments of insulin if she's already on that, regular follow-up, again on the WhatsApp, Bluetooth, charts, tracking, everything can be done in a remote way, and we can very meticulously get a hang of that. So here is a case, cross-connect between the diabetologist and the OBGYNs. So if she's already under the diabetologist care because she has pre-existing diabetes, she comes with the invitation card of marriage. Please ask her to come and see us, because we have to counsel her as to her BMI, her sugar levels, her HbA1c to be very strictly maintained and monitored prior to conception. Until then, we may have to give her some contraceptive advice, some weight loss, some PCOS tuning, glycemia, of course, jointly we can, hold and control. But usually what happens, you may send, we may tell, but unplanned pregnancies are very, very common in the country. That's oh, I was not planning the pregnancy, so I didn't do my strict dieting. Oh, I didn't check my sugars in the last 6 months, but she's become pregnant. And HbA1c is 8.8, fasting is haywire, PPB is even worse. And what to do next? Because congenital malformations, etc., are really a threat. So this is, again, we have missed the bus. We may not have told her as seriously. If we threaten her a little bit, this happens, that happens, though we will tell in a reassuring way, but she should recognize the seriousness and importance of that. Already, many of our patients are now on many medications, some of which, frankly, we do not even understand what medications are there. And so we always write a note to the physician or the diabetologist, whoever is seeing her, and some SLEs and some autoimmune diseases, lots of issues. So many times we are confused whether this is safe. Psychiatric medicines, lots of them are. So we really need to confess that we have limitations in this. So we need to double check and make sure that everything that she is taking pre-pregnancy is well in order. Despite this, the maternal history, advanced age, you cannot buy back the age. That is a risk factor. Poor nutrition, lack of physical activity, how much ever you tell her, it's a habit. Cultural factors, the socioeconomic status. There were diverse diagnostic criteria. At least in our country, all the OBGYNs are now sincerely following the single step test. We don't want to be confused at this stage. We may shift to the earlier testing and, the preventive mode very, very soon. As soon as we get our act consolidated, we will disseminate it very, very seriously and thoroughly throughout the country. And absence of self-compliance and, above all, the lack of resources and trained medical staff. So this we have averted with our accreditation program. And the way the G75, S75, 75 grams of glucose, they are delighted in so many maternity homes, the sales have gone up so much, because everybody has started doing. So that is our indirect way of knowing how much coverage is there. And we bring to the notice of the whole team that there is a whole 360-degree round, complications which we will be avoiding if we pay attention to the entire meticulous monitoring system. All of these, not only to the family and the patient, but to us also, it really causes mental distress. But now the mental health care has become, again, nutrition and mental health, government is also paying enough and more importance. We are having a nutrition checklist. We are also having a depression and anxiety score checklist, which we do for every woman now, so that, we filter the cases. And because the stress also can increase the sugars, we have not even recognized, and that's really bad. And here again, the remote anonymous consultation for the mental health has come in very, very handy. And the stress triggers and the variable contributors, how the moods are fluctuating, everything she can track, she can keep a journal. I never thought that many women would do it, but they're doing more than expected. So let's give them a chance to do better than the best. Prenatal to postnatal, there's a lot happening. It's a continuum. Here again, I want to bring to your notice missed opportunity. First pregnancy, as I said, big baby. 11 years back, we were not doing the single step test so seriously. And very many years after that, she's conceived. And we said, yeah, now we'll follow the protocol. And at 12 weeks, we'll do the testing. Already too late. The single step test at 12 weeks is showing the sugars as 248 mg%, which means nobody has seen her prior to the pregnancy. Again, a lost opportunity for preconceptional care. Simple advice post-delivery. Exclusive breastfeeding 6 to 10 months. Decreases the type 2 diabetes in the mother by 57%. And this is again something which we must all do. Obstetric emergencies was what we were dealing. Today, NCDs has a tsunami. Tomorrow, it's a cardiovascular disease and hypertensive disorders. But once more, again, I want to emphasize, being one of the femtech passionate leaders in the country, that these women who have delivered in the district hospital have gone back to their little villages. These are our wellness ambassadors or Swasthya Sakhis. They have been asked to do the BP, sugar, anemia check meticulously, and they have an access to these checkups in their local wellness centers. So we have to act now, because NCD-related complications is a multiplier of an ongoing pandemic of NCDs. You don't have the handle on it today, it's gone forever. So opportunities for action, preconceptional and post-delivery, out of sight, out of mind should not be. We even ring up and call the patient back, because then she recognizes, at least, we are serious about it. Everybody in the system should be made aware, not to let these women lose. Post-pregnancy counseling, very, very important, because postpartum IUCD, postpartum HPV vaccination, postpartum BP check, postpartum sugar check, lots of things to be done in between, and annual follow-up forever and forever. And at all visits, discuss the obstetric history, because we will pick up the risk factors for her NCDs as well. So it's our dream to ensure 2022 is the date I had put. I'm still keeping to that, because we're already a little late in this, but let us remind that this is what we had promised ourselves, all pregnant women to be tested. We are nearly there, but not quite. This is Anil Kapoor's greatest dream. Mother and child pair post-GDM follow-up has to happen, and we have to collaborate with everybody, including of the NGOs and the activists, to do the best. So this is one of the last slides, the life cycle approach for prevention of GDM. We start with all pregnant women. They are the easily available target, right? So we start with all pregnant women having universal screening. Nobody should be missed. So we catch them all. And then we go to community awareness, GDM risk factors, lifestyle, everything. Keep her pre-pregnancy fit. And post-delivery, that is after 30 years of age, 35 years of age, again, make her aware of all the lifestyle changes. NCDs has to be tested. Comes into the circuit postpartum, inclusive of the exclusive breastfeeding. Please do not forget to counsel her. So this whole cycle, round and round, cannot be complete unless we build the capacity of the healthcare providers. And you'll be surprised to know that in our nationwide Manyata initiative, we had a success story. I think then the consultant is telling, I have another person next to me, can I make her say something? So she was a housekeeper who told exactly properly about the single step test, the instructions that she too can give the patient. So it is just, it's not rocket science. It just requires the will to do, and we will be able to do. So the capacity building every single day, the batches happening round the clock, tens and thousands of the upskilling of the staff for assisted to maternal newborn care, for Anemia Mukta Bharat, for Poshan Yukta Bharat, for breastfeeding facilitators, for cervical cancer eliminating coordinators, all kinds of digital courses we've started, so that it gets into their head. And it is indeed a call to action. We need to disseminate, advocate, and collaborate with each other. We strongly believe that small steps makes a big difference. And let's hope that the dream of preventing diabetes altogether. See, we eradicated polio, smallpox, etc. Now we are thinking of cervical cancer elimination in a big way. Okay, the diabetes also is treading the same path, thanks to Sir and the others in the team who are already embarking on some major studies, which will have their reports out for us to tell the rest of the globe that together we can and we will. Namaste.
Thank you so much, ma'am. It's always great to listen to you, because the passion that rings in your voice tells us that all the work that you're doing is just in the right direction, and it's such a pleasure to join you in your path in all these endeavors. And I really hope that our collective vision of preventing diabetes does come true one day. So,
Thank you.
I request you to stay back for the panel discussion.
Sure. Oh, yeah.
Meanwhile, ma'am talked about prevention of diabetes, and this is where we have this concept of primordial prevention that all of us have been talking about ever since Dr. Seshia actually, thought of this and envisioned the entire concept of primordial prevention of diabetes, which starts much earlier than we always thought, right? Intrauterine, right in the beginning of pregnancy. And there have been a lot of people who've been skeptical, thinking that there's no evidence and this is just a hypothesis. And that is where today we have Dr. Picky Saxena with us, who is going to tell us how the concept of primordial prevention is evidence-based and how we are all gathering evidence on actually telling that this actually may be a concrete step towards primordial prevention of diabetes. Dr. Picky is a senior director, professor, and unit head, Department of Obs and Gynae at Lady Hardinge Medical College, New Delhi. Somebody who's very, very passionate again about GDM, diabetes in pregnancy, and we've worked very closely with her in Delhi. She's in charge of Assisted Reproductive Services, LHMC, and SSKH, winner of 34 gold medals in national international conferences. She's editor of 10 books, published more than 250 articles, chapters, more than 350 invited talks to her credit. She's chairperson of AOGD Infertility and Reproductive Endocrinology Committee, National Coordinator, FOCSI Committee on Medical Disorders in Pregnancy, convener of SIG Early Pregnancy, Indian Fertility Society, National Coordinator, Counselor Empowerment Program, Governing Council member, DIPSI, so on and so forth. She's been everywhere. So such a pleasure to have you, Dr. Picky, again, somebody who's very, very passionate about GDM. So let's hear her on the evidence that we have on primordial prevention.
So is my slide visible, Dr. Shalini?
Hanji, yes.
Yeah.
You just need to make it full screen.
Slideshow mode.
Sir, it's not, I can't see it. I'll stop sharing and
So
share.
you can, yeah.
You reshare.
Yes, sir. Is it full screen now, sir?
Yeah.
Yes.
So, I thank you very much, Dr. Rajiv Chawla and Dr. Shalini, for giving me an opportunity to be here and present this original work, which we have all worked together. And we have tried to see if the hypothesis of and the vision which sir has given, the primordial prevention of diabetes, not just GDM, is it holding true? Let us see the evidence. So we know that GDM today, we have been hearing it, and we all know that GDM today is the mother of all NCDs tomorrow. We were discussing about early GDM, and this is the concept which sir has given, which is going to talk about pre-GDM. And we know that when nearly, I'll just take this pointer. When nearly 15% of the beta cells of the pancreas are not functioning well, it presents as impaired glucose tolerance in non-pregnant patients. And during pregnancy, this comes out, corresponds to GDM. So already this function is, this dysfunction is there. And because of the placental secretion of glucogenic hormones, the insulin resistance increases, and this dysglycemia comes out and causes its feto-maternal complications. So it is now time that we change the focus to primordial prevention of diabetes and other NCDs, starting from the adolescence and the preconception period, which we have been hearing through Dr. Hema and Dr. Bhavtani. GDM is not a transient condition, but it is recognized as a stress test, indicating a physiological dysfunction that we just talked about. Nearly 2/3 of these women are going to develop GDM in the subsequent pregnancy, and 50 to 70% within 2 to 5 years are going to develop type 2 diabetes. So maternal hyperglycemia sets off a vicious cycle, which will affect not only the mother and her child, but also the future generations to come. We know that it all begins in the utero. Nutrition in early life has permanent changes. Maternal nutrition, be it anemia, obese woman, PIH, or hyperglycemia or preeclampsia, all that is going to lead to fetal malnutrition and develop a thrifty phenotype, which is well adapted to survive in the intrauterine period, but it has permanent changes in the way that it has decreased beta cell function. And as the child grows, there is catch-up obesity, diabetes, hypertension, and the full-blown metabolic syndrome. The Barker hypothesis again emphasizes this, that the developmental origins of health and disease, adverse intrauterine events permanently are going to program the postnatal structure, function, and homeostasis by methylation of the DNA and acetylation of histones, which is going to lead to adapted birth phenotype. This causes change in number or function of cells, endothelial dysfunction, oxidative stress, and epigenetic changes. So for the first time in the world, the novel concept of primordial prevention of diabetes, what we are going to talk about right now is just the first baby step, that is prevention of GDM. But we know that GDM is the mother of all NCTs. So once we are going to prevent GDM, we will be able to prevent diabetes. And this hypothesis was given by Pradhamshri Professor V. Seshayya. Sir is the father of GDM in India, we all know. And in his honor, 10th of March, is his birthday is celebrated as the GDM Day in India. And the DIPSI criteria, I think, which is one of the most outstanding invention by any Indian scientist, which has made the test so easy so that we can do it regularly for all pregnant women. This was adopted by the Ministry of Health and Family Welfare and is an integral part in the national guidelines. So we have been hearing Dr. Bhaftani told us the targets, thresholds of glycemia in pregnancy, but it is time to think, do we need to challenge the current therapeutic targets? And this was a paper which was published in the American Diabetes Association. Hernandez et al. Studied 12 studies involving 45 years of data. They studied normal glycemic women and found they recommended that the fasting blood glucose should be not more than 71 plus minus 8 and 2 hours postprandial should be less than 110. In sync with this, last year in August 23, the revised DIPSI guidelines were released. We all know the criteria of GDM. We have been noticing that even below this criteria, when the patient is having blood glucose between 121 to 139, these women are also having adverse fetal-maternal outcomes and they are prone to develop type 2 diabetes. This is known as the gestational glucose intolerance. But now what we need to focus on is this early gestational glucose intolerance. This is not early GDM. And this is, sir has hypothesized that all women who are having a 2-hour postprandial, not post-glucose value, more than 110, are prone to develop GDM and all the fetal-maternal complications, both the short-term and the long-term. So this is the target group for primordial prevention. Before they develop GDM, we need to target them so that the intrauterine programming is avoided. So let us talk about another very important hypothesis. This is the fetal glucose steal phenomena. What happens is, why we are talking about this 110 milligram per deciliter. The renal threshold of the baby is around 110. When the blood sugar in the mother is above this value, it is going to pass across the placenta and stimulate the beta cells of the pancreas to secrete more insulin. And it has been seen that in the amniotic fluid of these women, there is hyperinsulinemia, and this has been found to be a surrogate marker of intrauterine programming. At the same time, we know that because of hyperinsulinemia in the baby, there is deposition of fat and setting in of macrosomia occurs at as early as 14 to 16 weeks. Even after this time, if we are able to achieve normoglycemia, this macrosomia and the other consequences like polyhydramnios or preeclampsia, all these things may not be, we may not be able to prevent them. So fetal hyperinsulinemia, high levels in the baby, are going to pull the blood sugar from the mother to the baby, and they are going to lower down the blood sugar of the mother. So if this time we are giving the mother a glucose challenge, she may not come out to be positive because the blood glucose level of the mother is low, but this is at the expense of the baby. And this phenomena is known as the fetal glucose steal. As the beta cells of the pancreas develop at about 10 to 11 weeks, therefore, it is very important to bring down the blood glucose level below 110 by 10 weeks. And this can be done by starting some intervention. Earlier, we thought it can be done by medical nutrition therapy, but I'm sure you will agree with me that medical nutrition therapy alone in 2 weeks will not be able to reduce this level. So this other paper was published. This is again by Dr. Shaya, and it says that the prediction and prevention of gestational diabetes mellitus and its sequelae by administering metformin in the early weeks of pregnancy. And what they say is that at 8 weeks, if the postprandial blood glucose is more than 110, it gives us a grace period of 2 weeks where we can start medical nutrition therapy along with metformin, a low dose of metformin, so that we are able to bring down the blood glucose levels below 110 by 10 weeks. To prove this hypothesis, we undertook a study, and we are planning a multi-centric all over nation study to evaluate the correlation between first trimester 2-hour postprandial glucose greater than 110 for predicting gestational diabetes mellitus. This was the first step. So the objective was to evaluate the diagnostic accuracy of 2 hours postprandial blood glucose more than 110 at 8 to 11 weeks for predicting GTM. This was a prospective cohort study, and we were just discussing what should be the ideal level of HbA1c to predict GTM. We have studied that as well, and we have compared the postprandial glucose value vis-a-vis HbA1c in predicting GTM. So let us see what happens. This is a first-hand experience on 200 patients. This study was done from 2022 to 2024 in the Department of Obs and Gynae at Lady Hardinge Medical College and Sucheta Kriplani Hospital, New Delhi. We enrolled pregnant women with the period of gestation from 8 to 11 weeks. Sir was guiding us throughout the study. Dr. Anjalakshi ma'am and sir have played a critical role in carrying out this study. So after approval from the ethics committee and a written informed consent, eligible women below 11 weeks of gestation were enrolled. A thorough history and examination were performed as per pre-structured performa, and all recruited women underwent a 2 hours postprandial blood glucose, HbA1c, serum insulin levels. They were all measured between 8 to 11 weeks. All these women underwent DIPSI screening for GTM at 14 to 16 weeks, then again at 24 to 28 weeks, and third time between 32 to 34 weeks as advocated by the DIPSI group. If any time the woman was diagnosed as GTM, no repeat testing with glucose load was given, and she was treated as per standard protocol, MNT or pharmacotherapy. At the time of delivery, we again collected maternal and cord blood glucose, and HbA1c was measured, and serum insulin was also measured. Cord blood glucose to indicate the level of insulin and glucose in the baby. So in the results, out of 200 patients, 5 patients underwent spontaneous abortion before 10 weeks, and 6 were lost to follow-up. So at the end, we had 189 patients who followed up till delivery. What we see here is that the age of the woman having postprandial glucose more than 110 was 27, which was significantly higher than those in the less than 110 group, which was 25. Similarly, the BMI was also significantly high in the more than 110 group as compared to less than 110 group. See here the history of high risk factors. History of abortion was 3 times higher in the more than 110 milligram group. So was the history of PCOS and family history of GTM. So all women who had postprandial blood glucose more than 110 were in fact having a very high risk of developing GTM. So in the study, overall, 51% women developed GDM out of 189, 97, that is 51% of our women developed GDM. And by the way, in Lady Harding, we are testing all pregnant women by DIPSI test. There is a specialized DIPSI room where the sister is sitting and doing glucose monitoring by a glucometer, AccuCheck. And we have a prevalence of about 40 to 45% of women who are coming with hyperglycemia and pregnancy. Out of this, nearly 10% are pre-GDM and rest are GDM. So what we found was that the women who were having postprandial blood glucose less than 110, only 4 out of 92 developed GDM. That is 4% only. And in the women who were having a postprandial blood glucose of more than 110, 93 out of 97, which comes out to be 95% developed GDM. Out of this, in the less than 110 group, 2 patients developed GDM in the between 12 to 14 weeks, and 1 patient in 24 to 28 weeks, and 1 in the 3rd trimester. Whereas 73% in the postprandial group, more than 110 developed GDM in the 1st trimester, 15% in the 2nd trimester, and 7% also in the 3rd trimester, which again emphasizes that high-risk patients need to be also tested in the 3rd trimester, which is not at present recommended in the national guidelines. Distribution of medical morbidities, what we saw was that the hypertensive disorders of pregnancy were 3 times higher in the higher blood group, more than 110 postprandial blood group, as compared to 8% in the less than 110 blood group. IHCP was also higher, not statistically significant. Again, dyslipidemia, they had high triglyceride values and low HDL values in the more than 110 group. So metabolically, we can see they are having much more derangement. Polyhydramnios was also more in these women, although it was not statistically significant. So out of these patients, 75% were controlled on diet, 11% required insulin, and 13% were controlled on metformin. Amongst the delivery outcomes, 22.68, that is nearly 10 times more women delivered by had a preterm delivery in the more than 110 postprandial group, as compared to only 2% in the lower group. Mode of delivery, 32%, that is nearly double the woman underwent cesarean section in this higher blood group, as compared to only 18% in the lower blood group. Coming to the birth weight again, this was very surprising for us, because less than 2.5 kg, 39% of the women in the higher blood group, as compared to 17% in the lower blood group was present. Finally, we found that these women were those who were also having hypertensive disease of pregnancy. So, or some renal abnormality, probably that is why these women had, and they were also preterm deliveries. So that is why the birth weight was less than 2.5 and more than 3.45 kgs, which is considered to be macrosomia, 30% in the postprandial blood group, more than 110, and only 9% in the lower blood group. We also correlated the 2 hours postprandial sugar at the time of recruitment with cord blood glucose, which was in the, which signifies the fetal blood glucose levels. And we found a very high correlation coefficient of 0.66. Similarly, the insulin levels in the mother at the time of recruitment and the cord blood insulin levels also were significantly correlated, 0.465. So here we can see the HbA1c, which we measured at the time of recruitment. We found that that was also a good predictor of GDM, but the sensitivity, specificity, and diagnostic accuracy varied from 80 to 83%. Whereas our 2 hours postprandial blood glucose, which is a simple physiological test, the routine of the mother is not disturbed at all, can be done by a glucometer, even at home by an ANM or an ASHA worker. The area under the curve, as you will see here, is 0.6969. And the sensitivity, specificity, positive and negative predictive value all came out to be more than 95%. When we did the univariate logistic regression to find the significance of the risk factors, the individual PPBS level of more than 110 had an odds ratio of 403, indicating a substantially high risk compared to those with PPBS less than 110. On applying the multivariate logistic regression, individuals who were having PPBS more than 110 had significantly higher odds of developing GDM compared to those whose level was less than 110. So the study conclusion was that PPBS more than 110 milligram per deciliter at 2 hours exhibits a diagnostic accuracy, sensitivity, specificity of more than 95% for prediction of GDM and provides very strong evidence to prove the hypothesis of primordial prevention. Early identification of these individuals at risk, we are not talking about early GDM, we are talking much before that. We are talking about identification of individuals who are at risk of developing GDM based on PPBS more than 110 at 8 weeks. This may facilitate timely intervention and management strategies, thereby reducing the problems of GTM. This was the second study which is still going on. In this, all the women more than 110 were recruited. To one group, we gave metformin. To the other group, we did not give metformin. And we found that to the women who we had given metformin, only 1.6% developed GDM. That is, metformin was, along with MNT, was able to prevent GDM in these, most of the women. Whereas in the non-metformin group, 84% till now developed GTM. So results so far indicate that metformin 250 milligram BD significantly prevents development of GTM in women with 2 hours postprandial. This is in the process. We are writing the paper and soon we will be sending it for publication. And the very important and good news is that the regulatory approval for metformin from use from conception to birth has been already approved by the European Union, and the NICE guidelines also say that it is safe for use in pregnancy. So to conclude, non-communicable diseases are programmed and imprinted during pregnancy. A simple, cost-effective intervention in the form of metformin initiated at 8 weeks has a huge potential to achieve normoglycemia and prevent the development of intrauterine programming for primordial prevention of diabetes and may turn the tide of diabetes NCD pandemic, as GDM is the mother of all NCDs. So we need to focus on the fetus for the future. That is what Dr. Sashaya and Dr. Hema Divakar ma'am says. And I thank you all for a very patient hearing. One thing I did not show in this, the best sensitivity of HbA1c that we found in our study, the best sensitivity and specificity was at 5.3%. And we also did a AUC graph for postprandial blood glucose, and it was 110, which showed the best specificity. So here we can say that 5.3, if the HbA1c is more than 5.3, we have to be very careful and better to do a cheaper test, physiological test, that is PPBS. So thank you. Thank you very much for a patient here.
Thank you, Dr. Pikky. I think this was excellent evidence. Yes, more and more evidence as it comes. Maybe very soon this hypothesis becomes a recommendation endorsed by the government as well. And maybe the way forward is to gather more and more evidence. And this seems very promising, especially the second study where you clearly showed that 84% women actually developed GDM when they were not intervened in terms of giving metformin as small a dose as 250 milligrams twice a day. So maybe
Right.
once we have more data, I'm sure this hypothesis will stand the test of time. And we all practice science-based medicine, evidence-based medicine, and this is exactly the kind of evidence that is needed in larger numbers. And I'm sure the study, once it is done across the country, different centers, we will be little wiser and we will connect again and discuss. So thank you so much. Please stay back for the discussions. And now the best for the last. So that is where we have our mentor, our founder, Dipsy, Professor V. Seshia, who's going to shed light on why we all talk about GDM diagnosis, GDM prevention, GDM management, because pregnancy is a window to future NCDs. The entire burden of NCDs, maybe if we take timely action right in the beginning, maybe the graph that is going up in terms of NCDs can come down. I don't think he needs any introduction. We know Padma Shri Professor V. Seshia as the founder patron of Dipsy. He established the first department of diabetology in the country at Madras Medical College way back in 1978 when I was 4 years old. So, you know, at the time when we were toddlers and he was doing work in this field, talks about his vision and his dreams. Honorary Distinguished Professor of Tamil Nadu, Dr. MGR Medical University for the lifetime. You know, he's Vice Chair, Executive Board, IADPSG, recipient of Dr. B.C. Roy National Award in 1988 for development of diabetology as a specialty in the clinic in the country. Winner of Lifetime Achievement Award by IDF 2017 and was awarded the Padma Shri in Medicine in 2022 for all the lifetime that he has devoted to the cause of medicine and pregnancy and GDM for the country. So, sir, waiting for your session.
For giving this. I'm அது இல்ல இது இல்ல 1 second எடுத்தா போயிட்டு போச்சு அவ்வளவுதான் வந்து என்ன போயிடணும்
சிதம்பரம் நினைத்ததை எடுத்து வச்சிருக்கீங்களப்பா
1 second நான் அப்பவே சொன்னேன் இதுக்குதான் வந்து ஒண்ணு பாவம் 3 hours வெயிட் பண்ணிட்டு இருக்காரு இது இங்கே எடுத்துட்டு போயிது
சார் அதை எடுத்துடலாங்க சார்
எடுத்தாச்சு See, my friend Rajiv and Shalini, all speakers over here, I'm mesmerized by your talk. Really, it's mesmerization. Now, I've been asked, can you get the slide? Sir. Sir, this is the first slide.
சிதம்பரம் இன்னொன்னுப்பா
நான் இப்படியே பண்ணிடலாம் 3 மணி நேரம் உட்காந்துக்காரு இங்கே இந்த ஸ்லைட்ஸ் இதான் இது கூடியா இதுதான் சார் இது போட்டேன் இதெல்லாம்
அப்பா இத ஸ்டாப் பண்ணுப்பா டயக்னோசிஸ் அண்ட் பெத்தோபிசியாலஜி எடுத்துரு
இதுல வந்து ஃபர்ஸ்ட் போடுப்பா
இத ஃபர்ஸ்ட் எண்ட் ஸ்கிரீன் கொடுத்தீங்கன்னா வரும்பா
ஏன் ஃப்ளோர் மாட்டேன் ஸ்லைடு அப்பா so difficult ma
you can unshare this Stuti, can you just unshare this once?
Yeah. Chidambaram, I வந்து first end screen கொடுத்து you have to then come out with that.
Now you can share that PPT.
Down you have that green one, share screen.
Yes.
Yeah.
Sir, we got it.
Now just make it full screen. Slideshow. Slideshow.
It's okay now.
Yeah.
Yes,
Yes, sir. Yes, sir. Perfect.
That's perfect.
I am not a young fellow. Yeah. I find difficult to sit for 3 hours. Anyway, I'm going to talk on this topic, pregnancy as a window of future NCDs. And this slide I have taken from Rajeshwar a long time ago. The same lady sitting here. Now, female gender is the key for diabetes prevention, which, like Kingo said, that as the title was given like that. Now, how? Because the body's susceptibility to lifestyle diseases was programmed intrauterine. That's what is everywhere we are talking about 3 hours. Now, this wonderful statement I want to make, and many of you may not know what I'm speaking here. Chanakya, 2000 years ago, was a philosopher, economist, teacher, jurist, and royal advisor. He has complied Arthashastra and Chanakya. What he said is true even now. When a life gets seeded in a mother's womb, its age, deeds, wealth, education, and death all determined right there intrauterine. So that's what I want to discuss. What this was told 2000 years ago. Now, same thing somebody told about the David Barker. The body susceptibility to lifestyle disease was programmed intrauterine, just like Chanakya. Fetal origin of adult diseases. Now he has proved again. So now coming back to here, GDM is a diabetes mellitus may play a crucial role in the increasing prevalence of diabetes and obesity. Further, insulin resistance, increased atherogenic lipid profile, inflammatory markers, hypertension, and endothelial dysfunction lead to increasing risk of cardiovascular diseases. That is why I told long time ago, GDM is the mother of non-communicable diseases. Now, development horizon, it is again very important message here. The worm is well supplied with mitochondria, but the sperm contains a few, even those few do not persist in the offspring. At fertilization, it's only the nucleus of the spermatozoa that enters the womb, and thus all the cytoplasm, mitochondria, and mitochondrial DNA are exclusively maternal oriented. This is a very clear point here. Mother is very, very important for everything in life. Intrauterine programming here, gestational programming is a process whereby stimuli, maternal fuels, or stresses that occur at critical or sensitive periods of fetal development permanently change structure, physiology, metabolism, which predisposes individuals to disease in adult life. So now maternal hyperglycemia and progeny. What is here? This is a very important message here. The offsprings of Pimandans who were in utero. The mothers had diabetes, have a greater risk of diabetes compared to early child siblings born before the mother developed diabetes. So this shows intrauterine milieu is very important compared to inherited destiny. We always think about genetics here. They will look for here. Development origin of health and disease, phenotype here, genetics, and comes here intrauterine environment and an extrauterine environment, that is postnatal environment. Of these, most important will be the epigenetic, that also more intrauterine environment here. Genetics loads the gun. It may be there, but environment shows environment is very important. That environment is a intrauterine environment is very important to develop the consequences. Now, aftermath of GDM. Now we'll go back to topic. Following GDM, the risk of over diabetes immediately after pregnancy is 10%. Whereas 80% of GDM women develop type 2 within 5 years. And then they are at higher risk of cardiovascular complications due to dyslipidemia, hypertension, and abdominal obesity. Unfavorable changes in HDL and TG levels compared with women with healthy pregnancy, and finally prone to recurrent GDM. So higher intimal medial thickness compared with women without a history of GDM. Now, clinical scenarios of forgetting to type 2 diabetes. Here, gestational age, a diagnosis of GDM, hyperglycemia is diagnosed in first trimester, history of GDM in earlier pregnancy, the degree of glucose intolerance and insulin requirement during pregnancy, excessive weight gain during pregnancy, inability to shed pregnancy-induced weight gain post-delivery, and shorter duration of breastfeeding, and finally, longer duration of follow-up. Now, as somebody told about this fourth trimester, yes, postpartum period must be viewed as an important window of opportunity to identify women with a higher risk of type 2 diabetes and prepare for healthy future pregnancies. Several exposures have prudently recognized the importance of providing continuity of care in the postpartum period known as the fourth trimester. I think I read this article from Rajiv and Hema. So it is very beautiful, fourth trimester. That is, what is fourth trimester? Very important. I will discuss here. GDM is the mother of non-communicable diseases. GDM women has sevenfold increased risk of type 2 diabetes. Up to one-third of GDM have over diabetes. Impaired fasting glucose and IGT contribute another one-third. 5-year cumulative incidence rate of diabetes mellitus is over 50%. One-third of women with diabetes mellitus pass through the stage of GDM, which is the important window of opportunity for progression. As title was given here, this is true. The important window of opportunity for progression. Postnatal screening for DIPSY guidelines here. Most of you have discussed about this today. Early postpartum, that is 6 to 12 weeks, test 70 gram 2-hour OGT. 1 year postpartum, 70 gram OGT, 2-hour OGT. Annually again, fasting plasma glucose and postprandial plasma glucose. Early postpartum OGDT. As per DIPSY guidelines, the postpartum screening for glucose intolerance, 2 days, this is again somebody told about this. 2 days postpartum OGT has similar diagnostic value of 6 to 12 weeks of postpartum. I think Bhavani told this point. And here, OGT is predicting IGT and associated with 10% adherence to the test. And for this, what I told a long time ago. Now, importance of follow-up. Postpartum glucose testing is a golden opportunity to identify women with persistent glucose intolerance. Thus, that shows again postpartum very important here. The best way to prevent the development of type 2 diabetes in patients with GDM is postpartum screening so that appropriate intervention can be taken at the earliest. And further, timely diagnosis also serves as secondary prevention of long-term complications associated with diabetes mellitus. Identifying women at risk of diabetes postpartum provides an opportunity to delay or prevent the onset of our diabetes with lifestyle modifications or medications. Preventing, delaying the onset of our diabetes mellitus in a woman of childbearing age also protects future offspring from the harmful in utero effects of hyperglycemia, that is, intrauterine programming, birth defects, risk of obesity, and diabetes. This screening universal, this simple, all of us know about, all of discussed. They're recognizing these high-risk women at the earliest during and after pregnancy is beyond doubt, as early detection has been shown to improve not only short-term outcomes but also long-term as well. And further, globally, postpartum screening rates are poor, mostly less than 50%. So that shows postpartum part very, very important. Lifestyle modifications and pharmacological intervention can prevent or delay women with a history of GDM from progressing to type 2 diabetes as effectively as in people with prediabetes. A study done in the center here in Chennai, with title if early versus late postpartum deficit test in this GDM. In this study, it was found, duration of study was January 22 to October 22. This is in the Madras Medical College. Study population 150 women, diagnosed as essential diabetes, prospective cohort study, all GDM patients delivered in same Kasturba Gandhi hospital. So in this study, exclusivity was known case of type 1 or type diabetes or associated medical disorder like gestational hypertension or heart disease, CZ or disorders. So now what happened, what was procedure followed will be here. GDM mothers were advised to take 70 gram OGT, just like DIPSY only, 2-hour PPG on postnatal day, third day. This test was done. And further, mothers were counseled regarding weight reduction lifestyle modification, and healthy diet. All are asked to have a usual postpartum GD follow-up with 2 hours surgical mobility at 6 weeks again. More normally, many places they're doing only 6 weeks. In this study, we did in third day, and then again did in 6 weeks. While the patient had to come for vaccination or postnatal day 42 after infant. So further advantage will be here. Women need not be fasting, because we are always following diabetes pregnancy study group study, that is 2 hour for PPG single test procedure. Women need not be fasting, causing the slightest disturbance in routine activities. The mother could not refuse this test as she had already undergone this test in the antenatal period. Please, this is very important, because every woman undergoes this test in the antenatal clinic. So the same test which you are going to follow here. Further, the above suggestion would avoid confusion among healthcare workers, because if the same procedure is followed to diagnose glucose level in the antenatal period, will be followed also in postpartum period. Rightly, Minister of Health, the Government of India has approved the use of plasma glucose calibrated glucometer. We use only glucometer, not a venous blood, for capillary blood glucose estimation. It is a patient-friendly point of care approach. So this is what happens. Results are here. Sensitivity 100% and specificity 95% is very high in predicting the postpartum IGT and diabetes on third day itself. It is same on 45th day again, the same again. Hence, Tier 3 postpartum screening will help to cover 7% of GD movement. This is what happened here. Group 1 on third day and 40th day. Group 1 less than 140 blood sugar level, 16 number, mean was 128 here. Again third day. Again 45th day, it is again 130. There's not much difference. Same the group 2, 140 to 199, number 50, in that mean was 166, and then 45th day 173. So there's not much difference. Again, group 3, more than 200, 40 people were there. In the 226 was the value, and the follow-up at 40th day, 200. That shows the third day itself, what you're going to do is adequate. It is not necessary to do again 6th week or 8th week or 40th week. So finally, this study shows day 3 postpartum screening is possible using the DIPSI test, as the pregnancy hormonal value reverts to normal after 48 hours of delivery. That's it, but you have to wait. That day only must do the test. Furthermore, this effectively diagnoses women who are at high risk of diabetes, and this can replace the conventional 6 weeks of DIPSI test. Need not go for 6 weeks. The maximum number of GD patients can be screened by day 3 testing. Finally, to prevent non-communicable diseases, the solution is to sensitize the government, which has a well-placed health delivery system, about the importance of GDM screening during pregnancy and glucose tolerance in the early postpartum period. So postpartum screening of the GDM, aiming for universal coverage, is a very important study here. The public health care, ASHA workers, all of us know about that, are already performing GDM screening test by single test procedure in antenatal clinic. So the same test procedure can be followed to detect glucose level in the postpartum period also. So there's no different, because all of them know what you are doing in the pregnancy time. Same test you can do it here. So if more than 140 milligram diagnosed as IGT and more than 200 as diabetic, diagnosing a this is postpartum screening which got this paper published. And then postpartum oral glucose level testing, a justifiable step towards diabetes prevention, SARA medicine. So preventing diabetes will be here. And I think diet is very important. This shows pregnant women who participated in the diet and exercise program had a greater gestational diabetes risk reduction. Also, has less weight gain and reduced number of birth by cesarean section. This is a method of avoiding it. And then here also, step to prevent the offspring from developing type 2 diabetes. This is lactation at least for 6 to 10 months may lower diabetes risk after gestational diabetes. Very, very nice study done here. You have to give lactation of 10th month. And then breastfeeding for the first 6 months protects offspring developing type 2 diabetes. That is only shows, the study shows that lactation is very important. So, friends, I'm coming to last message. Prevention of NCD. Preventive measures against NCD to start during intraactive period and continue throughout as life from early childhood. Prevention of type diabetes must begin in utero and continue throughout the life course, as everybody told in the here. GDM offers an important opportunity for the development, testing, and implementation of clinical strategies for NCD prevention. So it is possible, prevention is possible. So pregnancy and avoiding NCD here, like Kingo was told, it starts with a healthy pregnancy, low birth weight or large for gestational age weight, and elevated risk for in adult life, obesity, diabetes, hypertension, CVD, all lead to intergenerational. It goes from mother to child like that. Intergenerational transfer of risk, and so the mental health, the link to the NCD epidemic. So maternal health is very important to prevent diabetes. So it's a beautiful statement where Norman Frankel said, no single period in human development provides a greater potential than pregnancy, a long-range payoff by a relatively short-range period of enlightening metabolic benefits. It's a very short period, 10 months, we can avoid diabetes. It all starts in utero, which we already started in this first slide. Hence, for diabetes for a generation, you have to focus on the fetus for the future. So there's always a hope, as everybody has listened to a talk from in the afternoon. Wonderful talk everybody made. I'm sure in future, I've already written a chapter in the book in tech, hope and scope for diabetes free generations. That's what that author's editors will, it's a wonderful paper, will publish it. And that's what we are telling here. Focus on the fetus for the future. So we can avoid diabetes in this country. Hope so. Somebody is listening here will see what happens. I wish you all the best and support your work I'm suggesting here. And I would suggest here this this our Sahai, Rakesh Rai, or other fellow bunches of, they all should join together and see, you organize, and then the people who are here, 10 or 15 people should again sit. Very serious discussion must make and what we can do, because already Vicky has told the evidences and we have also showed evidence. It is possible to implement this what we are telling about the guidelines which are going to follow for the prevention of diabetes in the country. Hope it is successful. Thank you very much for the opportunity given to me. Thank you.
Thank you so much, sir. You have always led the path, and I think can you unshare this?
Unshare, sir. Please unshare it.
Stuti will do it. Stuti will do it. No problem. So now we're open to a panel discussion, and I think we have all the stalwarts in diabetes and pregnancy and GDM here. So I'll request all delegates who are logged in to send us your questions so that we can have a fruitful discussion.
Can I ask the question?
Sure, ma'am, please.
So my question to Dr. Bhavtarni is that you said decrease the carbs to 40%. Does that apply to my type 1 patient who's pregnant?
Actually, Meena, the present day recommendation 2024 recommendation is 33 to 44%. I wanted to give the latest what we say. Usually, previously we were saying 40 to 50%, all that. But now the latest is we are consuming more carb and we are already insulin resistant. To break that, You have to bring down as much as you can.
Type 1. We are talking
Type
about
1.
type
No,
type
no. I'll tell you.
Type 1,
yes.
you're asking for
by
type
type 1. So that is what I'm asking. In type 1 patient who's pregnant, what is the distribution of carbs, fats, and proteins? My question.
Even there, I feel, yes, you can give the same. They say up to 40% you can give carb and more protein. The same thing applies.
I don't think so.
See,
Picky, won't you get growth retardation?
Meena, pregnancy is not the stage for any sort of dieting.
That
But
is what she's
definitely,
saying, that
yeah.
40% carb is less for
Yes,
a type
but
1
I'm
in
not
pregnancy.
asking that.
Yeah, that is what I'm saying. That for pregnancy, we need to have a balanced diet, which will be at least 30% plus what is the prior to conception. That means if you are
No, no.
if you have been
No,
what I mean,
sir.
Can
That
you
is
come
not
in
the
here?
question. What she said was that in
Carb.
DIPSY guidelines, we are saying 40% carb, but for a type 1, reducing carb to 40% can push her into ketosis. And I have seen this happen with 2 of my pregnant type 1 patients, where we reduced the carb. We told her to go high on the fat and the protein and the fiber and everything. We reduced the carb and her urine ketones started coming out positive. That is where we actually went up and increased her carbs back to almost 170 grams per day to let that ketosis go away. So this is, yes. So this is an amendment that maybe in a future DIPSY guideline, we can have a separate section on diet recommendation for a type 1 pregnancy, where we can actually have all the scientific evidence on the amount of carb that goes well for a type 1, because it is going to be different for a type 2 and GDM compared to type 1. Dr. Sahai, your opinion on this?
Insulin resistant. She is
Yes.
not. She's in
Type 1 has no insulin resistance. So for a type 1, reducing carb to 40% can predispose her to ketosis. I've seen this happen clinically.
Shalini, even in type 1, they go in for hyperinsulinemia. Even in type 1, they go for hyperinsulinemia because they have to tackle. And this, I'll give you reference. There, we are putting, even for patients, we are reducing the carb and increasing the protein. This becomes a lenti carb and we are not facing any problem.
So, madam, can we
How will she get hyperinsulinemia if there is no
I'll give that reference. I'll give that to you.
No. Madam, what you're saying is that we were talking about fetal steel. Dr. Picky, you can come in here. If the sugars are little high, these sugars cross the placenta. There's a transplacental sugar transfer to the fetus, and he perceives as high sugar, and the fetus then pancreatic beta cells become
fetal.
Fetal hyperinsulinemia. And the sugar, mother's sugar now becomes normal, but the but aren't we subjecting her, the fetus to IUGR? My question to Dr. Picky, if we start bringing down the sugars to less than 110, you are talking about primordial prevention, but won't we lead to IUGR babies? We are more worried about the present baby than the mother developing an NCD in the future or the child developing.
No, but how do you think, Dr.
110 is the fetal renal threshold. 110. It is not like us adults.
Only if it is
110. We are maintaining 110.
That's all.
We are not bringing less than
we are not allowing it to cross. Once you cross, all the problems will start, both for the mother. Fetal insulinemia causes problems both for the mother as well as the child.
Meena, I remember this. You are referring to a discussion we had recently in Mumbai. I know when there is always a concern that if a Indian baby born has an average weight of 2.8 kg, and if you try to give a very low dose of metformin, maybe 250 BD or 500 BD, there is always a chance that you might have little reduction in baby weight. So that in the long run may get converted to increased visceral fat and greater risk for developing adolescent obesity. And that way also it may increase NCD. This is what was the discussion going on that day. But what Dr. Bhavtarni is saying, and what we learned today also from the discussion, that because the renal threshold moment sugar crosses 110 milligram, only then there is a excretion of glucose, and that actually brings out hyperinsulinemia into the beta cells of the fetus. So as long as we can ensure that sugar does not exceed 110 milligram, that way I don't think 250 milligram metformin, as Dr. Picky has rightly shown in entire data of 200 patient, is a very high dose that it will push fetus into a undergrowth or IUGR, as long as we are able to ensure a sugar close to 110, 105, or maybe 100 to 110. Because I told you the normal physiological 2-hour sugar in a normal pregnant female is 99 plus minus 10. It never exceeds 110. So as long as you can ensure a sugar between 99 to 109 precisely, I don't think you will induce a IUGR in the fetus. And in other way, actually, you will prevent overstimulation of the beta cells of the pancreas of the fetus, and you will avoid that glucose steal phenomena into the mother. Because if the fetus is already over secreting insulin, so that will, if you subject that mother to a 75-gram glucose test at 13 or 14 weeks, that will bring down mother sugar to less than 120, and you will actually miss an opportunity to pick up early GDM. So that is what is the...
And again, the blood sugar is not like us for the fetus. It's very low. It needs only very little. Not like us on 10 or 100. See, what is
Meena, that Hernandez et al. Study of 45 years, that has very clearly shown that 99 plus minus 10 is
10
the
is,
normal.
Normal. That is the normal.
Even if it is 99 or 100, it is absolutely normal.
It is fine.
The fetus will never have hypoglycemia.
What she is saying
very recently, 2 days back, I heard a study by Dr. Sabdarshi Bhattacharya from Delhi, I think, Apollo. He has followed these metformin babies up to 11 years. He says, no problem what we say, that a reduction in this thing or nothing, mid-arm circumference changes, nothing. He has put a paper, and he has very recently, 2 days back, I heard from him.
That
he is saying the old one.
But Dr.
But you have to be very careful whether there is any placental insufficiency, hypertension, already IUGR.
Then you will not get
Then you will not
you have to be careful. Otherwise, once, as Sir says, if you are starting metformin after 12 weeks, it will be problematic. Not after 12 weeks. It has to be started before, so that we don't have any problem. So you have to unmute. You have to unmute. Sir, you have to unmute.
Sir, you are not audible.
Sir, unmute, unmute.
Unmute, sir.
Tamil.
You tell him in Tamil.
Sir, unmute. Sir, mic நீங்க open பண்ணல. Mic open பண்ணல.
But at the same time, I would like to just bring in, because many of these women in whom we are restricting the calories, we should tell them to take adequate proteins, because many of the babies are turning to be low weight or FGR. So they have to take a adequate diet depending on their pre-pregnancy weight and their physical activity. And protein should be given in adequate amount.
Should be in a proper proportion.
Dr. Shalini, that how can we give protein 70 grams in a vegetarian person is almost impossible. In spite of milk having 1 glass milk having 6 grams, and egg, even if they are vegetarians.
All pulses.
Pulses, gram.
Pulses, so many pulses.
Pulses have carbs. Pulses have carbs. So most pulses would also have carbs with them.
Yeah, but that is a lenticarb.
Yeah, lenticarb.
But that is a complex carbohydrate, which is not going to be so.
No, we are not saying, but we are saying it's a challenge to go down.
It's a challenge. Definitely
in the country like
that
India.
is why we are getting so many babies who are low weight in spite of the mothers being GDM, which was evident in our study also. Less than 2.5.
So maybe do you think, Dr. Picky, that maybe simply restricting carbs to 40% needs to be again relooked into?
Yes, 100%.
I personally see that from my clinical experience.
Shalini, our people are giving plenty of carb during pregnancy, that too more refined carb. If you see the actual plate, what they are taking, it is full of carb. That's what I showed, the 75% carb. They think that is healthy. That idea has to change.
I think the government of India thali concept is the best. It shows the local foods, simple foods, the easily available non-processed foods which are shown in the thali, and
No,
we
but
are
in
We have
that's
we
right.
have
But in context of
we have
type 1,
replicated the picky the same thali in our
yes, it is
DIPSI
there in our
guidelines.
DIPSI
Yeah,
guidelines.
we use the
yes,
same
yes.
thali
Yes.
which has been approved by Ministry of Health, Government of India,
It is there in
adopted by them.
GCPR also everywhere.
சிதம்பரம் இருக்கா அப்படியா இல்லையா? உங்களுக்கு unmute பண்ற மாதிரி இல்ல. Sir wants to talk, but he is not. He doesn't know to unmute.
Sir,
There is
sir,
no help
silence
there.
is louder than
Someone
words.
is there, but
I think
Yes. He's
the
telling like this.
Shruti can do it.
Tuti, can you unmute, sir?
Yes,
Yeah,
somebody do it.
Unmute,
can do that.
sir.
He'll get a message and you just
Yeah,
click
the
OK.
host can do it.
Yeah,
Yeah.
host mute.
So in the meanwhile, I just wanted to say, as OBGYNs, when we did a large study in our enthusiastic years, where we really were drilling into our head about very, very restricted diet, some women went overboard. You know, we were thinking they'll not be compliant, but they were very, very strict with themselves.
Yeah.
90, we are telling fasting, she's keeping it at 70. We are telling her, but she's thinking that if she gets it lower and lower, she's a champion, you know, that kind. So when we analyze the birth weight, only like 2 out of 100 babies were above 3 kilos. A large number of them were average weight, but quite a significant number were low birth weight and growth restricted. Then we started getting alarmed. Maybe we are like, you know, acting too much hyper. We're just scaring her out of her wits, and we're asking her to be so strict.
Sir
So,
is unmuted. He wants to comment now.
yeah, please.
Yeah,
Yes, sir. Yeah. Your words of wisdom.
Yes, sir.
No, what I thought, Dr. Meena sitting there. Where is she?
She's there. Yeah.
Meena? Yes.
Open your video, Dr. Meena.
Where is Dr. Meena?
She's there.
She's here, sir. She's there.
She's there, sir.
Stuti, put everyone on the screen.
Just put she's right
And
next to you,
questions
sir.
are very good, but I think you must include her also working on the same field. Then we'll have get an answer. Otherwise, everybody will have their own ideas, you know. See, now, it's very, otherwise, see, where is Dr. Meena?
She's here, sir.
Meena, just raise like this. Sir is not able to see you. Sit upright.
So, okay. Yes, everybody has got their own ideas, but it's very difficult to cut. Everything has got physiology. Nothing is imaginable. We have got data everywhere. Physiology is there. And as Rajiv was telling, as Anantan was told by the publication, so many people have published. I don't think anybody should have doubt. Anyway, if they don't believe, it's a different matter. But that's why I told you, Rakesh Rai and what his name is, Vanshi Sabua, they must join together, see that at least for 10 or 15 people sit together, like we can give you guidelines, what they should follow. Because the two people have done the study, we are going to publish in International Journal of Diabetes Developing Countries shortly, and Cures is already published. How can they, unless it is published and without data, how will they publish it? You must believe it. You can't have, it's not possible. See, in this country, how many people can afford to take insulin? When we have with data, she has proved metformin, nothing has happened, and the international people also say metformin is very safe. Anyway, so everywhere it's a problem there. Only thing, proof of pudding is eating. The problem, you know, proof of pudding is eating. Unless you see that, unless do that work, it's difficult to convince them and believe them. So if you tell IIDPG, you all follow. The Rakesh, the one doctor put in, he is a professor, head of the Department of Endocrinology. What he tells in his qualification puts endocrinology, diabetology, metabolism. All you put here, 3. He says, no, we can't do anything. Okay, he's already endocrinologist, he's a diabetologist, put all 3 degree qualifications. Like that, people may imagine and do. Difficult to follow them up. You follow what you believe with the evidence, that's all. Without evidence, nobody can speak, nobody should continue. It is not a court. One lawyer will something will put somewhere, another lawyer will do something. It is what happening. So anyway, now Rakesh is there. Now you do whatever you want. Try to convince people what is correct. Already 2 people have done the data. Let the third people also do that. Let us see what happens.
Yes, sir. Absolutely, sir.
Vinod came, when we had Calcutta Dipsy meeting, he gave such an amount of guidelines. Those days I'm telling you.
I think that was 2004.
Yeah, something like that. Calcutta guidelines.
Yeah, Calcutta. Yeah.
Yeah.
Now you have Delhi. You have current Delhi Dipsy declaration. It's already published.
Yes, it's already published.
It's already published, and it is released by Government of India, PMO, Minister Dr.
I love to listen to you all people. That's why I'm sitting for 3 hours. No problem at all. See, everybody speaks so well, so well. It's like a music for me. Anyway, okay, should go through that.
So, any closing comments before we close, sir? Anybody would like to give us some?
Dr. Hema, Dr. Picky,
Dr. Sahai,
Rakesh.
sir.
I have one
Okay, Dr. Meena wants to say something. Okay.
Yes, I want to say that I'm finding it extremely difficult for my type 1 diabetes patients.
No, we are not talking type
Guidelines
1.
are few. As of now, I have 3. And in Hindi, I won't speak in Hindi because Dr. Bhavtarnia and our esteemed Professor Sesha don't speak. But I can't sleep. Meri raaton ki neend ud gayi because 3 type 1s, very difficult. Lot of, we are trying to give them basal, 4 boluses, and they are still, and diet, everything, and we put sensors. So I think we need more work on type 1s. And I agree with Dr. Sesha, sir. I have no right because I've not worked, but I'm ready to pull in data now.
I want to see you again.
Meena, what we are talking is for the majority. What we are seeing in our practice.
Especially,
Why we
now more and more type 1s will become pregnant because we are looking after them very well, and they are all getting married. And
but there you can relax and go
Meena,
according to the
Meena,
ATMS. Of course, we
That
have.
I think, as you said, you need to sit down and.
Dr. Bhavtarni, what she was saying was long-standing type 1, they tend to become something like 1.5. By 30, they are already
No,
obese
sir.
also.
What she is saying is for type 1 pregnancy management, we need a separate recommendation
that I have
and
understood.
guidance. That is what she's saying.
Hyperinsulinemia issue. What she was saying was she was talking about 1.5 diabetes, that by the time they are 28 or 30, maybe if she's on insulin for 15 years.
Fetal hyperinsulinemia.
Then
That is
hyperinsulinemia
okay.
comes in. That is what I am trying to explain, why she was saying that there is a hyperinsulinemia even in type 1.
Actually, this hyperinsulinemia and GDM happens only in those who are already resistant. We are testing C-peptide also. We are finding it very high in these people. And once the fetal handling starts, this is transferred to fetal. Initially, mother is the problem, but later, this fetal insulinemia is the cause for all problems.
Dr. Shalini, do you say that a type 1 will also have evidence of insulin resistance and will become double diabetes during pregnancy? My question. Like we have double diabetes now.
Not because of GDM, but not because of pregnancy, but by virtue of being on insulin for say 15 years.
Now
if she
she's
became
pregnant.
type 1 at 7 years, and now she is conceived at 28, 30, by then she might have put a lot of weight, and during the pregnancy with counter-regulating hormones, there could be hyperinsulinemia. She's not wrong.
That's what.
Meena, this is common. They don't follow what diet we say. They are very irregular. So they have put more on exogenous insulin, take a lot of, even this exogenous, it has caused insulin resistant features and syndrome.
Dr. Hema,
Dr. Meena, it is very, very
Dr. Hema, a word of wisdom from your side
Before you leave.
leaving. So I thought I'll catch you before you leave.
No, I would like to say that in this matter of hyperglycemia, there is always going to be an opportunity for confusions to clarity. Because it starts with these kind of controversial questions and different perspectives, but slowly the decluttering happens, and then it is a lot that we need to learn over the years, because as I was just expressing, that initially we were all out to just really restrict and cause tiny babies. And we didn't even, until we saw the data, on the table. We said, how so many babies are dying? Our average weight was 3 kilos. Now everybody's 2.2. That was very alarming. And I thought we really went overboard. Similarly, now we have gone wiser, that we are slowly and steadily, in a mature way, gradually collecting the data, auditing, reworking backwards and forwards. I think there is a lot still need to be done. But as OBGYNs, two things I would still like to place. That yes, continuum of care, because at every stage we have an opportunity and we should do better than what we are already doing, because not as many as the OBGYNs are sensitized to the before and after issues as well. And many times, many tertiary care hospitals, they have the luxury of a diabetologist, nutritionist. So the patient gets so fragmented. She just gets going here, there, everything. She cannot understand what each one is saying. So in a wholesome way, OBGYN has to learn and take the responsibility so that the patient gets reassured and morally encouraged to follow one system without getting confused. That is point number. Secondly, public-private partnership, the village nutrition and health days, we need to join hands to test every single woman. The coverage is not happening, in as much as we would have wished to. So government is questioning us again and again. So we don't mind from Foxy and other platforms to lend hands if there is any such issue. And now we are sending block level pay. Each and every household, they are, going and testing. One Gruha Bhagya, Gruha Arogya program, what we have now started in Karnataka. I said, but collectively we said integrated approach. 5 things for every woman over 30 years. Okay, most of the villages may have finished their childbearing by 30 years, but 5 things they must ensure test: anemia status, blood pressure, sugar, breast cancer, cervical cancer. These 5 things, so they must do, and there are a lot of pickups and so many who have not been tested ever before. We have a wonderful opportunity yet again. So my closing comment is, let's pay more attention to not missing opportunities. Let's do better than what we're already doing now. So that's it.
Dr. Hema, neither you nor sir touched upon our recent editorial, our joint editorial, Index Pregnancy, a Window Opportunity to NCD. Actually, I gave him this topic thinking that we will talk of 4th trimester care also, like 1, 2, 3, and the 4th for post care, screening and planning. Actually,
after 30, every woman is tested. Means that is the window. Whether she has been tested or not in pregnancy, we may have missed there, but we have to pick up, because at 30, 35, in that age group, if she is having a high sugar, that means somebody has missed in the GDM, and then she's continuing. So on the whole, yes, the window is there, but we have to open the doors.
Absolutely.
We have to open it wide. So that's my dream. So let's all work together towards that. And I think sooner rather than later, we will succeed in our mission.
Madam, we have done.
Ma'am, you got muted. Bhavtarini ma'am, muted.
You got muted.
We have done a study in the retrospective aspect of the present female diabetics and found they are having big babies, BOH, all these, which have been not diagnosed.
Absolutely. There's a large number lying out there, because even when we see the coverage, even today, of everybody having institutional deliveries, but like how PK has created those stations and then they are doing, that's a very strong way of ensuring. Now with this rushed kind of approach, kind of everybody knows, but the gap between knowing and doing is still not plugged in. That we have to really, really ensure that what we already know, let's do it properly. Okay, then there is more to do. Always more to do.
Every week we are having a stillbirth meeting, and most of the stillbirths are again due to some sort of hyperglycemia, some opportunity missed. So although we are having so many conferences, so many webinars, still we need to go to the masses, and even in Delhi it is happening. We are getting unbooked patients who are not being taken care of properly. And sir, we are going to talk about the 4th trimester of pregnancy in my postpartum panel tomorrow.
Yeah, that is important. I thought that we will touch upon. Actually, I gave this topic to sir, but probably he didn't get the clue.
I think Lagay Raho principle.
And The hypoglycemia in pregnancy. We are writing on book chapters. You are also writing on chapter. In that, I have written that 4th trimester.
Yeah.
We have presented some papers in which you all were authors in RCOG and 4th trimester of pregnancy last year. Dr.
And
Hema,
again, Picky, it is not like our sir says, it is coming down and down. Previously, it was 12 weeks. Now, before 8 weeks, problems are starting.
Yeah.
It's because of the age of that pre-GDM is becoming more and more.
Late marriages, junk food, sedentary habits. And
So
ma'am,
they're writing now, PK, books and books of from bench to bedside. अभी उधर लेके आओ. We get into practice and just actually do. We will do.
Absolutely,
Yeah.
absolutely.
So thank you once again.
So with that,
Wonderful opportunity and huge
Wonderful being
congratulations.
with you,
Thank
sir.
you.
With you,
Thank you,
madam.
sir. Thank you, Dr. Shalini.
Thank you so
Thank
much,
you, Dr.
everyone. I
Picky,
think
Dr.
we've had
Rakesh
great
Sahai.
discussions, and it is my proud
Wonderful.
privilege and honor to propose this vote of thanks to close this. Before closing, just a quick word, the closing comments by Dr. Rakesh Sahai, because he wanted to say something and we didn't let him speak.
No,
So,
no,
sir, all yours.
No, 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 no. I
For
think
anyone, it
Dr.
is difficult to speak once 7, 8 top
Sir, let him speak,
women
please.
icons
Yes,
are
sir,
speaking.
please
No, no,
speak.
I think I mean whatever I wanted to say, Dr. Hema has very nicely put it that there's a lot of opportunity there, window of opportunity is there, but we need to work hard to see that we reach out to everyone, each woman that has pregnancy. We need to reach out to them and see that we provide the best care, and that is the great challenge that we have, and we should work towards that. So thank you.
Absolutely. So thank you so much, everyone, for logging in today for the DIPSI Symposium. And we've had great 3 hours, and I don't know how the 3 hours just flew by, discussing so much that we did on diabetes and pregnancy and GDM. And I think there's so much work that still needs to be done. Because I think we are all in an era of evidence-based medicine, and we need more and more and more evidence to actually recommend and go forward in delivering the best standard care to our patients. And the whole idea, the vision that all of us share, preventing diabetes, preventing GDM, and having a world free of NCDs is something that all of us aim for. So with that, my thanks to all the faculties who've been part of this symposium, right from Dr. Seshia sir, Dr. Sahai sir, Dr. Hema ma'am, Bhavtarini ma'am, Picky ma'am. I think we've had great sessions today, and I'm sure our delegates go back home enriched, especially in this field. So thank you everyone for logging in, and it's time to say goodbye. Thank you so much for a very, very
Thank you, Dr. Shalini.
full of learning. Thank you so much.
Thank you. Thank you so much.
Thank
Thank
you.
you.
Thank you, everyone.
Thank you,
Thank
sir.
you,
Thank you,
Raju.
sir. Thank you, Shalini.
Thank you, Shalini.
Bye,
Thank
bye.
you.
Bye.
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 Bye, Picky.
Bye.
ठीक, ये खोला, जूम खोलना। ठीक, हेलो
हेलो।
स्तुति, आवाज आ रहा है मेरा?
हाँ हाँ, आ रहा है।
हेलो,
हाँ जी।
आवाज आ रहा है?
यस, लाउड एंड क्लियर।
तेरा पीपीटी शेयर करना एक बार मेरे को,
एक पीपीटी शेयर किया हुआ है मैंने ऑलरेडी।
जूम में।
हाँ, जूम में।
नेक्स्ट करना।
एक मिनट।
नेक्स्ट।
हुआ?
ओके, हाँ हो रहा है। साउंड क्लियर है मेरा, ऑडियो एकदम?
हाँ, ऑडियो क्लियर है।
ओके, और तेरे यहाँ से कोई अगर वीडियो है तो वीडियो शेयर करना।
कोई वीडियो शेयर करूँ मेरा?
हाँ हाँ हाँ, कोई है रिकॉर्डिंग अभी?
हाँ है, एक मिनट रुक जा।
हाँ हाँ, क्लियर आ रहा है एकदम परफेक्ट। हाँ हाँ, यहाँ से मेरा तो को दिख रहा है यहाँ पे वीडियो पूरा क्लियर?
यस, आई कैन सी यू।
ओके, ठीक है।
वीडियो शेयर करूँ ना? एक मिनट रुक।
नहीं नहीं, कोई है नहीं अभी यहाँ पे, रिकॉर्डेड लेक्चर नहीं है ना?
रिकॉर्डेड लेक्चर इनका डॉक्टर शशांक जोशी का है, जो मैं यहाँ से प्ले करूंगी। चाहिए तो मैं
हाँ तो एक बार प्ले कर एक बार।
हाँ, रुक अभी।
Hello, everybody. Today we are going to discuss obesity treatment
ठीक है,
prior
स्टॉप कर दे, स्टॉप कर।
as we
ओके।
ओके ओके, check. Hey, check.
Hello.
Yeah, good evening, Dr. Monica. Yeah, good evening, Dr. Monica.
Monica has joined. She has joined.
Hello, Dr. Monica. Welcome. Can you hear us? Dr. Monica, can you hear us? No, she can't hear.
Good evening, Dr. Monica. Can you hear us?
She can't hear us. सुन नहीं सब कुछ देखो ऑडियो में कनेक्टेड है. Dr. Monica, can you hear us? एक बार उधर से चेक करो. Send her a text on chat and ask her. Can she hear us?
Yes, I can hear you.
Okay. Welcome, Dr. Monica.
Hi.
Hi.
Thank you for inviting me.
Pleasure to have you on board.
Just waiting for Dinesh to join.
Dr. Trents is also joining in. So we're just waiting
Yes.
for her to join.
Yes. She will be joining in a few minutes.
Sure, sure.
There's a presentation before my presentation.
Yes,
Mine is the
yes.
second sequence.
Yes. Yours would be second, and then we have Dr. Trents.
Okay, sounds good.
So maybe what we'll do is we'll start and she can join us. So a very warm good evening to everyone who's joined us today for the second day of 11th Cmre International Symposium in Diabetes. Now today we have a very special occasion because this is for the first time that we are partnering with ACE for a joint symposium. So this essentially is an ACE Cmre joint symposium in diabetes and obesity. And Dr. Chawla, my co-director with Cmre, is going to talk to you a little more about the partnership that we have developed with ACE. So we have two representatives from ACE. Welcome, Dr. Trents. So you're here. So Dr. Monica Agrawal and Dr. Trents, who are joining on behalf of ACE and will be with us in this symposium. So we are basically going to talk about the epidemic of obesity and diabetes that has engulfed the entire world, and India is also not left out. To start with, may I introduce I'll first invite Dr. Rajiv Chawla and Dr. Mohammad Hasnain to join me on the dais as chairs for the first part of this symposium. Can I have their CVs on screen? CVs. I need it here. Okay, so forget it. Okay, so Dr. Rajiv Chawla, I think all of us know him. Cmre is a joint venture between him and me as co-directors. And this is Consortium for Medical Research and Education, an academy that both of us run as co-directors, basically aimed at propagating continued medical education in the field of diabetes, obesity, and metabolic health. We've been doing annual programs every year, and this is the 11th edition of the program, and we've grown from strength to strength. Yesterday, we had a virtual program which was joined with AASD, the Arabic Association for Study in Diabetes. And we had faculties from across the globe, right from Cairo, Egypt, to MENA countries, to Dubai, Emirates, and then we had speakers from America as well as UK. So we had almost 1,300 plus logins in the virtual program yesterday. And when we finished at 9 p.m. with Dr. Adi Mehta's session, we had 900 people already logged in for that session as well. So we had a great response yesterday in the virtual program. Today, between 3 p.m. to 6 p.m., we had a joint DIPSI symposium with Diabetes in Pregnancy Study Group India, a DIPSI Cmre joint symposium, wherein for 3 hours we discussed pregnancy and diabetes in detail, and this again was well received, and we're getting a lot of appreciation for the sessions and the academics that went on. So as part of the second day of International Symposium in Diabetes, now we are here for a joint ACE Cmre symposium, and I welcome all of you. Dr. Mohammad Hasnan, our guest, our partner in this journey, has been with us right from the beginning when we started with the first Cmre symposium. All of us know him as a great faculty who's worked a lot in. He's professor of medicine at Mohammed bin Rashid University, Dubai, senior consultant in endocrinology and diabetes at Dubai Hospital, and professor medicine, Gulf Medical University, UAE. He's co-founder of the Diabetes Diploma MSc for Cardiff University, UK since 2007, consultant in Department of Endocrinology and Diabetes in the UK. He graduated from the Faculty of Medicine, Alexandria, Egypt. His main research interest in the field of diabetes and Ramadan, and we've seen him publish a lot of literature on Ramadan as part of the DAR group. He co-authored recommendation papers on this subject for the ADA 2005 and 2010, and for the British Medical Journal 2010, Diabetes Canada in 2017, as well as the IDF DAR Practical Guidelines 2016 and 2021. His other areas of interest include educational programs for people with diabetes or HCPs, where he won the first prize for this from Diabetes UK as well as EASD. He has published over 100 papers, participated as first author, co-author in various studies, regional, international guidelines, and has been felicitated by the IDF as well for his work. So welcome, Dr. Hasnan. With that, may I now ask the chairpersons to kindly take over and start the proceedings for today. Dr. Shashank has just landed, so he'll take some time to come. So meanwhile, I'll request Dr. Rajiv Chawla to kickstart and talk on the obesity paradigm in India. Dr. Shashank will be joining us very soon.
Good evening, everyone. It's a very proud moment for all of us. For the first time, as Dr. Shalini informed you, partnered with ACE, which is American College of Clinical Endocrinology. We took this initiative, and I'm very happy to share with you that for the first time, because ACE also wanted to be very, very inclusive on this part of the world. They didn't have too many representatives from this part of the world, and they are trying to involve all the physician community in Asia Pacific. So ACE has constituted a APEC board, that is Asia Pacific board, where across Asia Pacific we are going to coordinate. We are going to be their sole representative. This board is headed by Professor Shashank Joshi. Then as members we have Professor Rakesh Sahai, Dr. Bansi Sabu, Dr. Amit Gupta, Dr. Shalini Jaggi, and me. We are on the board of APEC, which has been constituted by ACE. So we wanted to carry this partnership further, and we wanted to have a joint symposium with ACE, because this time was very less. So ACE agreed for having a virtual hybrid mode symposium for the first time, and maybe subsequently we will have a physical presence from ACE in the coming years to have. And as a part of this APEC board, we have a recording from Mr. Johnny White, who is CEO of ACE, and we will like to run his message. Yeah. So it's a welcome message from Mr. Johnny White. And as Dr. Shalini told you, we are in the 11th year of our Cmre, which is organizing international symposium year after year. We have been having partners like Cardiff University, and day one we have Professor Mohammed Hasnain, who is more than a family member to us, who has been a very, very strong core committee member of our organizing committee and always as a co-chair. And since then it has gone a long way. We are in the 11th edition. Professor Colin, we are missing his presence this time. He's also a core committee member, and so is Professor Inash Sheltout. So I want to put it on records, their virtual presence here. Both of them, they couldn't make it this time. Dr. Inash missed her visa just by 1 or 2 days, so she couldn't make it. She was part of our program, which was virtual yesterday with ASD, and she has given you the figures. We had a very, very successful joint venture last night only, finished at almost 9 o'clock. So fortunately, over the years, with the help of all local faculties and members, those who have been part of Cmre since day one, this program has been growing year after year and is one of the most sought after program. And just to share with you, for the physical conference, we closed our registration at 1,000. Let's hope more and more people join for the program, which is going to start tomorrow at 9 a.m. So may we have the video message from CEO of ACE, Mr. Johnny White.
Hello, everyone.
Before we start the program, yeah.
And it's great to be here with you internationally at the 11th International Symposium in Diabetes. First, I want to tell you a little bit about myself. Again, I'm the CEO of ACE. I've been involved in running healthcare organizations for many, many years now. I started my career at the Endocrine Society as a director, and then moved my way on to the Cardiovascular Research Foundation, where I was the executive director. And then I also was the senior director at the American Academy of Otolaryngology. In addition to running these organizations, I've also spent some time as an adjunct faculty member at Georgetown University and at a community college here. So I bring a lot of experience to this role, and I'm excited to be in this role and excited to be back in the endocrine profession. Now, I want to talk a little bit about some of the things that we're doing at ACE. First of all, our global inclusive community. We're an organization that's welcoming all types of healthcare professionals, not only endocrinologists, but also primary care physicians, nurse practitioners, pharmacists, and diabetologists. So if you are interested in finding a home that's providing education on how to treat patients with endocrine disorders, you definitely want to come to ACE. As you can see here, if you want any information about membership, you can go to our website. That's ace.com/join us. I definitely would love to see you a member of our organization. And then when you become a member, you also want to look at our designation, and that is our FACE designation. That's a Fellows of the American Association of Clinical Endocrinology. There are a few requirements. One is you need to be a member for 3 years, and that 3 years goes by pretty quickly. So I hope that you join today and you start your journey into becoming the FACE, having the FACE designation. You must attend one of our ACE major meetings within the next 4 years, or the last 4 years. This meeting could be the one that we have in the US, or the conference that we have in the Middle East, which we've been doing that program for the last 3 years. And then there's an application fee. So again, if you're interested in that, please go to our website. That's ace.com/FACE distinction. An initiative that I'm really proud of is our certificate programs. We just launched our certificate programs. We're doing a series of certificate programs. We just launched our Fundamentals of Diabetes Technology. And then by the end of this year, we'll have the Obesity and Weight Loss Certificate and the Inpatient Diabetes Certificate. And then next year, we'll have more certificates. These programs are very, very unique. It's not your traditional program where you're seeing a lecture and slides. It's very interactive. We have some animations and so forth in these certificates. And so it's more of a hands-on virtual type of format. So I definitely recommend that you look into these programs, because those that have taken it so far have given us some really good feedback, and they're very satisfied of what they're learning in these programs. And so again, on our website, ace.com/certificates. And then lastly, I want to invite you to our annual conference next year, May 15th through the 17th in Orlando, Florida. It will be at the Hilton. This is a program that you do not want to miss. This past year, we were in New Orleans. There was a huge buzz at the meeting. Everybody was excited about all the science that we presented and the opportunities to network. So I'm hoping that I will see you next year in Orlando. Again, May 15th through the 17th. Thank you. And I appreciate you giving me this time to speak to you today.
Thank you. Thank you, Mr. White. I think he has already, in his address, put forward the initiative which ACE is going to have in this part of the world, starting from getting more and more membership, more and more people attending physical conference of ACE at America, and subsequently more and more people we will like to have amongst the FACE nominations also. They are going to promote many educational modules and certificate courses through ACE EPIC, and this is how it is going to start. So as these are going to be very baby steps in the beginning, and we are initiating that, and subsequently I'm sure over the year we will have much more initiatives getting fulfilled, as is their dream to be more inclusive in this part of the world, because unfortunately, in spite of ACE presence being everywhere, this part of the world has not been very, very actively involved. So that was the vision with which we have approached them, and they have been kind enough to grant that EPIC board to this part of the world to take these initiatives forward to all the physicians of the community. So with that, I think we can start the scientific agenda. And what I am going to do is I'm going to do a context setting on obesity paradigm in India. And then we have two learned speakers from ACE, Professor Monica and Professor Tines, those who are going to take this program further. Please display the slides. Yeah. So what I'm going to do is give you a background of obesity paradigm and touch upon the pathophysiology of obesity in this part of the world, and give you in pharmacology or in pharma industry, a dossier is presented whenever you want to come out with a new concept. So what I'm going to do is to give you a weight dossier, and flow is going to be first to have the burden of obesity, understanding obesity, how it all happens, what is the role of brain in regulating appetite, the benefits of an early intervention if we do it timely, and towards the end, we will hand it over to both the learned speakers from ACE to talk about pharmacotherapeutic approach or landscape for obesity. So the reality is it is a global struggle against obesity. Unfortunately, in India, we are fighting in India, on one hand, we are fighting undernutrition and infectious diseases. On the other end, we have a growing epidemic of obesity. Even in India, we are living in a scenario what could be labeled as diversity, and numbers are extremely scaring. In 1922, 2.5 billion adults with age 18 years and older, they were overweight, including over 890 million adults who were living with obesity. So this number is exceedingly high. This corresponds to close to 43% of adults who are just 18 and over. In 2022 only, there were 37 million children under the age of 5, those who were overweight. So you can imagine the scenario once these children grow towards adolescence age 15 or 20, how bad is going to be the situation. Over 390 million children and adolescents aged 5 to 19 were overweight in 2022, and close to 160 million who are living with obesity. So it is very rightly said that today we are living in an era of diabetes, and diabetes, unfortunately, this epidemic is growing or being driven under the rising prevalence of obesity. So India's weight was alarming statistics on obesity. Unfortunately, we have a dubious distinction today, being the third largest population with obesity in the world, only behind USA and China, as per the current WHO guidelines published in 2023. Very, very current figures. India's weight loss was again alarming statistics on obesity. ICMR Lancet Endocrinology publication led by Dr. Mohan Group, which was an initiative by ICMR, that we have 101 million patients living with diabetes. But what is much more worrying is we have 136 million people, those who have pre-diabetes, and they are likely to get converted to diabetes over next 5 to 10 years. We have close to 315 million patients living with hypertension. And unfortunately, again, this diabetes prevalence is going or being driven with the obesity, with generalized obesity seen in 254 million patients, and abdominal obesity with a visceral fat on the higher side being seen in 351 million patients. So today, unfortunately, although we are number 3 in terms of having diabetes or obesity patients, but when it comes to global preparedness to run or to fight against obesity or diabetes, we are unfortunately at 99th position for getting a preparedness to fight obesity or diabetes. We don't have, unfortunately, the Indian figures. When it comes to US figures, 23 billion is going to be the cost, the impact of obesity in India. This is as per 2019. And there is a 9% annual increase in childhood obesity. I've already told you that children living with obesity in 2023 are already 160 million. Those who are between 5 to 19, adolescent children. So very rightly, obesity has been recognized as a disease and a health issue. It is no more a cosmetic issue. It is no more only a social stigma, but a chronic disease. This is how World Diabetes Federation for the first time defined it. Obesity is a chronic, relapsing, progressive disease which needs an immediate action for prevention and control of this global epidemic, and rightly so by Diabetes Obesity Canada, ASO, AMA, European Commission, Academy of Nutrition, and Royal College of Physicians. Just naming or maybe changing the comprehension, but every organization identifying that obesity is going to be a chronic disease which has a relapsing and a progressive course. When it comes to obesity, we always thought that it was that you're consuming more and you are spending less, but probably it is not all that simple. Today, we understand that obesity is caused by a complex interplay of several factors. It is a chronic disease in which abnormal or excess adiposity impairs health, increases the risk of long-term medical complication, and most important thing is reduces the lifespan. So obesity is not simply an individual choice or lack of willingness. Most of the time we blame our own family members, our own patients, own colleagues that you are not reducing weight, you don't have the determination, or you are not cutting on calories, or you are not exerting. But it is probably much more than that. And it is actually appetite which is regulated by a complex interplay between the gut and brain. So that gut-brain axis is impaired, needs to be blamed. So there are many paths which lead to obesity. When it comes to biological, the brain controls eating behavior and appetite. It could be genetically predisposed in most of the families, about 40 to 70% getting contributed by genetics. It could be a psychological issue. Many people with stress and psychological stress tend to overeat and then tend to become obese. It could be as a result of many medications which patient might be on, and of course social issues contributing towards that. So mind over meal, probably we need to unlock the brain's influence on appetite control. This is very, very important because there is a role of brain in regulating appetite. And I told you it is probably much more complex than we ever thought. There is one eating for hunger, which is controlled by the endocrine feedback pathways or signals, which is homeostatic eating. There's another which is a hedonic eating, which is eating for pleasure. Even if you are already have had enough meal, you want to have enough of dessert because it gets you a lot of pleasure. And then the executive function comes in place, which makes you to decide whether you need to eat more or eat less so as to control your weight. So appetite is normally, it is thought that it is regulated by a complex interplay of different signals and areas. It is an increased understanding, fortunately today, of these biological appetite regulation, that you have now a couple of the drugs which are going to be the drugs of the future when it comes to eating for hunger, which is a homeostatic eating or a physiological way of eating, which is controlled by endocrine feedback through the signals. These are the hormones which are important. It is a ghrelin which increases hunger, but it is GLP-1, PYY, oxytocin, PP, amylin, insulin, or leptin, which increase satiety. So there is a balance. This is how there is a energy homeostasis. Once it comes to eating for pleasure, it is actually controlled by brain reward system. It is something that as we give rewards to our kids, you do this, I'll give you a chocolate. Something like that. You perform like this. So it is a reward function. It is the dopamine which controls wanting and the motivation, but it is the opioid and the cannabinoid receptor which control that liking for eating. That is why there were cannabinoid receptor inhibitors, rimonabant, which was a wonderful drug, but unfortunately because of some side effects like depression and tendency for suicidal, it went out of the market immediately after launch. But the most important thing to me is it is the executive function of the brain deciding to eat using your third sense, your hind brain, what to eat, what not to eat. It is here that willingness or that determination becomes extremely important. So what you need is not simply the drugs, but probably the behavioral interventions are going to be extremely important in curtailing this growing obesity. There are signals from gastrointestinal tract which regulate energy intake and glucose homeostasis. From duodenum, you have cholecystokinin and GIP, ghrelin, jejunum releases GLP-1, we know, peptide YY. Then ileum, you have again GLP-1 and oxytocin and peptide YY. From stomach, you have ghrelin, which increases appetite. And similarly, you have endocrine signals from the pancreas and the colons also. So I think there is a need for an early intervention, a timely action, because there are going to be benefits, very, very motivating benefits, if you can reduce the risk of developing chronic, expensive to treat complication. Most important thing is that you treat obesity today. If you treat obesity, if you can simply get down from obesity 1 to an overweight stage, that means reduction in BMI by 5, 50% of your patients will not develop type 2 diabetes. Your sleep apnea will go down by 50%. Your osteoarthritis risk, your risk for heart failure, hypertension, and dyslipidemia and cardiovascular mortality will also go down. So there needs to be a stepwise approach for obesity management, starting from the behavioral modification. I told you at every step, whether you are normal weight, just overweight, obesity 1, stage 2 or 3, but moment you have BMI more than 27 to 29, these are Caucasian figures. Once it comes to Asian figures, it is 22 to 27.5, because for us 23 is a normal BMI. Anything between 23 to 25 is overweight, and we are already obese moment we have 25.1. So for all these BMI cutoffs, we are already in a handicapped situation. We need to be 5 down in terms of obesity. Once it comes to pharmacotherapy, anyone who has BMI 30 to 35 needs to be on anti-obesity drugs, especially if you have couple of comorbidities like severe osteoarthritis, severe OSA, very difficult to get control of your glycemia. Probably you are the best candidate for a metabolic surgery. So we need to talk about diet and exercise, and beyond that it comes to pharmacotherapy, because there are going to be issues even if you are following the behavioral therapy. Energy restriction, dieting gets you weight reduction, but unfortunately not many people know it, that there is a reduction in leptin, satiety hormones go down and energy expenditure goes down. Your BMI goes down moment you lose 5 BMI. So that increase, that leads to an increased hunger and desire to eat. So you go back to your original weight. That is how in physiological way, body sort of persists losing further weight, but it is recommended that we must incorporate pharmacotherapy, especially if BMI is more than 27.5. And it is known from look ahead and early days trial that sustaining that weight loss only with lifestyle modification may not be possible. So you require pharmacotherapy to achieve benefits, something like 10 to 15% reduction in pharmacotherapy, because that can reduce your blood pressure, your waist circumference, your C-reactive protein, your triglyceride, and your conversion from pre-diabetes to diabetes. So I think future will be that we have much more promising drugs. I'll not touch upon drugs here, and I'll hand it over to Professor Monica, who is going to take us through from mono to di or dual to ultimately triagonist in management of pharmacotherapy. So over to Dr. Shalini to conduct the session.
So thank you for that excellent context setting, Dr. Chawla. Can I have Dr. Monica's CV? So Dr. Monica Agrawal is joining us from the US as part of the ACE faculty, and she will be shedding light on management of diabetes from mono to dual to triple agonist. Can I have her CV on the screen, please? इस screen में आएगा क्या? वो इतना में Dr. Monica Agrawal is an endocrinologist and obesity medicine specialist at the University of Alabama at Birmingham. She is professor of medicine at UAB, director of the UAB Obesity Medicine Fellowship Program, co-director of the Clinical Skills and Integrated Skills Program, CRISP, parenteral nutritional specialist, and MOVE physician champion at the Birmingham VA Medical Center. She is chairperson of the Obesity Society, TOS, Education Committee and board member of the Nutrition Board for Physician Nutrition Specialists, and she is served on several national committees at the ACE, the Obesity Society, American Society of Nutrition, and the American Society of Parenteral and Enteral Nutrition, ASPEN. So welcome, ma'am, and she will be shedding light on diabetes management right from mono to dual to the way forward, triple agonists in diabetes obesity management.
Can you see my slides?
Yes, ma'am, we can.
Yes. So, good evening, everyone. I want to start by thanking the organizers for this invitation. This collaboration between ACE and your organization is a wonderful opportunity for all of us to share insights on this important topic. Dr. Chawla has already laid the foundation for obesity as a disease, which is a global epidemic, and in US also is a big problem. I have no financial disclosures or conflict of interest. So over a span of more than 80 years, we have navigated a challenging era in the field of obesity treatment, where the therapeutic landscape has been fraught with setbacks. The period witnessed withdrawal of several anti-obesity medicines due to severe and sometimes fatal side effects. It wasn't until 1990s when we observed a shift with the introduction of orlistat, which is offered as a GI mechanism that yields modest weight loss. The discovery of leptin marked the watershed moment in our understanding of obesity. It eliminated the intricate neuroendocrine pathways for regulating body weight. Prior to that, our understanding was limited to calories in, calories out. And once we started to understand the complicated pathways, the neuroendocrine pathways, it became clear that different set of medications will be required to control this disease. But for the initial 80 years, we were not successful in having impactful medical management for this disease.
But over the past decade, the landscape of anti-obesity medications has undergone a dramatic transformation, making significant advancements with 6 new anti-obesity drugs approved in US. And there was only one withdrawal. The success rate has been significant, and it has surpassed that of previous decades. This leap forward is largely attributed to deepening understanding of the gut-brain pathway. And the newer anti-obesity medications induce substantial weight loss. And there are more that are in the pipeline with several promising candidates on the horizon. So just to go briefly over some of the medications that are available in US and that are more first generation medicines. So these are 4 FDA approved anti-obesity medications that are less potent than the newer medications that I'm going to discuss in a bit, but they play a vital role in holistic treatment approaches. These medications, they are cost effective in US and can be pivotal in shared decision-making process with patients. And the older drugs, these are the older ones, they still have a unique position in our therapeutic management plans because they offer a viable option for patients who cannot tolerate the newer medications or face cost barriers as the newer drugs are expensive. And sometimes they are not covered by the insurance here. So we have these other options available that includes orlistat, which is inhibits the absorption of fat in the gut. Then we have a combination of phentermine with topiramate that also helps with weight loss, and the weight loss can be around 6 to 9%. And then we have combination of Viprion with naltrexone, where the weight loss is about 4 to 5%. Now, it's important to remember that none of the anti-obesity medications are approved or should be used in pregnancy or breastfeeding. So they are not safe for use, even the newer generation medicines. So that's if the woman is breastfeeding, that she should not be on these medications. These medications can have certain side effects, so it is important to first screen and make sure there is no contraindication for starting these medicines. And when patients are on these medications, to assess for any side effects or safety concerns that may exist while they are on these medicines. So now moving on to the newer medications. So there is an interplay between the gut and the brain, which is a promising frontier in the targeted control of body weight. It is becoming increasingly clear that there's a multifaceted approach is needed because there is a redundancy in the obesity pathways. There's no single signal. There are multiple signals. So it's a complex disease. So it requires a multi-pronged approach for managing the obesity. And that's where the gut hormones come into play. So when the food is ingested, there is increase in certain gut hormones. These are the nutrient stimulated hormones. So the newer generation of medicines are nutrient stimulant hormone based therapeutics, that's NUSH. And when these there's increase in the GIP, glucose dependent insulinotropic factor, there's also increase in GLP, glucagon, and then amylin. I'm just going to focus on these, but there are many others. So this is the foundation for the NUSH therapies that are the mono, dual, and triple agonists. So the GLP-1 is the most talked about and the most we know among all the other gut hormones. And so the GLP receptor activation, you can see it's not just limited to obesity or adipose tissue, white or adipose tissue or brown adipose tissue. The mechanism of action can impact multiple organs and has beneficial effect across different systems. Just to highlight, you can see in brain, it decreases food intake. So there's reduction in appetite. At cardiac level, there is cardioprotection, improved cardiac output. In kidneys is diuresis. Skeleton muscle, there's increased glucose uptake, which helps with glucose control. In pancreas, there's increase in insulin secretion. Also, there's reduction in glucagon secretion. So there are multiple mechanisms of action for GLP-1. The next important member in this family is the glucose-dependent insulinotropic peptide, the GIP, which has several functions, including reducing appetite in the brain, then also increasing insulin and glucagon secretion in the pancreas, enhancing glucose uptake, and also leading to decreased glucose production in the liver, and promoting glucose and fatty acid uptake in the adipose tissue. So these are the main functions of the glucose-dependent insulinotropic peptide. The third one is glucagon, and we know it from diabetes, our understanding of glucagon from diabetes and how to manage hypoglycemia in patients on insulin. But glucagon has several other functions, including decrease in food intake, enhance insulin secretion, increase lipolysis and energy expenditure in the adipose tissue, slow down gastric emptying, and reduce cholesterol levels in the liver, promoting lipolysis. So those are the functions of glucagon. So now you can see how these three different hormones, the nutrient stimulated hormones, they work, and the newer therapeutics is working towards combining these. So there are a multitude of drugs that are in developmental pipeline, each leveraging the intricate pathways of gut hormones and combination therapies. And I'm just going to highlight a few of these drugs that are in the forefront of advancing anti-obesity medications. So when we look at this multifaceted strategy that aims to create a synergistic effect that could potentially redefine obesity management, the backbone of this is the GLP-1, which its effect on brain is critical in regulating our appetite, our metabolism, and providing neuroprotection and in the contemporary therapeutic strategies. Intriguingly, the penetration of GLP-1 into brain varies with these drugs, navigating the blood-brain barrier in unique ways, reaching certain areas while bypassing others. So this is unique to GLP-1, that it only is able to go to certain parts of the brain and bypasses the other areas. And this forms the sort of the different drugs that are being developed. GLP-1s is an important part of those drugs. So in this figure, you can see the action of single, dual, and triple agonists focusing on GLP-1, GIP, and glucagon. So these agonists work synergistically across different pathways and in different organs. I'm going to focus on the agonists that acting alone or in combination influence food intake, insulin secretion, energy expenditure, and metabolic function. We'll start with GLP-1 receptors here on the, you can see single agonist, and then move our way down to the dual and triple agonist and explore how these combinations work in helping with weight loss. Now, overall, you can see here that the incretin therapies like GLP-1, GIP, they have a wide range of positive effects on multiple organs and tissues. In the brain, as you saw, there's decrease in appetite, there's an increased satiety. There's also some role, there are studies going on looking into Alzheimer's disease, that there may be some benefit with the amyloid deposition. Moving to the cardiac benefits, there is increased glucose utilization and contractility. So overall improvement in cardiovascular health. In the lungs, it reduces inflammation and is beneficial in some early studies with reactive airway disease. Again, these studies are still in process. In the liver, there is significant improvement in inflammation and fat deposition, hepatic steatosis. So that is also helpful. In pancreas, there is increase in somatostatin, and there is reduction in glucagon secretion with the incretin effect. In addition to that, in the kidney, you can see there's diuresis and natriuresis, so it will help with kidney protection. And so these all, and lastly and importantly, sometimes that doesn't get discussed that much, incretins promote bone formation and reabsorption, supporting bone health. So it is not bad for bone health, because sometimes that's a concern that's raised. So incretins have been shown in early studies to have some positive effect on the bone. So this is a summary slide of most of the big trials that happened with the anti-obesity medications over time. You can see here the first generation medicines, orlistat, phentermine, moving on to the newer medicines, liraglutide, semaglutide, and tirzepatide. So early on, the goal for that was set for in the US for FDA approval was 5% weight loss over placebo for at least 35% of the patients in the study. So that was the standard for any anti-obesity medicine approval. And there were many medications that could not meet that criteria and failed in initial trials, because at that point, that goal seemed daunting. Even 5% weight loss was considered a big deal, and that's why we had very few drugs. Fast forward in last 5 to 10 years with the GLP-1 receptor agonist and dual agonist, we now are in an era where we can see 10%, we have 15%, and up to 20% or more weight loss. So this is and in addition to weight loss, there is improvement in overall health. So based on these innovative NUSH therapies, the nutrient hormone stimulated therapeutics, they are now being recognized as the second generation medication. So the first generation was 5-6% weight loss. The second generation is where we have started to see 15-20% weight loss with these medications. Now, there's also with the older medicines, there was a small percentage of the population that was able to lose weight, and 15% weight loss was seen in a small fraction of patients. But now with the newer medications, most remarkable is that 15% weight loss occurs in up to a third of users, and there's also for 25% reduction seen. You can see here for the newer medications, 20-25% reduction is seen. So when aiming to mitigate the severe conditions like obstructive sleep apnea, osteoarthritis, GERD, we are aiming for at least 10-15% weight loss. So if we, with the newer medications, the GLP-1 agonists, you can see 15%, 20% weight reduction and positive impact on cardiovascular health. So these are not merely clinical milestones, but this is transformative, and in some cases will be life-saving. Now, there's an important caveat to all these medications, and that's what trials have shown, that ongoing therapy is essential for weight management. So this slide shows the maintenance therapy for long-term maintenance, and it focuses that when we do the extension trials, you can see there is with the red bars, there is weight loss. The drug list is listed below here. And in the maintenance phase, the weight stabilizes. So there's not like if somebody's on these medicines, it's not continued weight loss. Eventually, the weight loss will plateau. But the good part is when they are on the medicine, there is no weight regain or very limited weight regain. So it is crucial to recognize the efficacy of these medications that extends beyond the immediate result, and it's important to be on the medicine for long-term maintenance of weight loss. There was one study done in semaglutide with maintenance where you can see this gray bar going up. So after the study was over, then in the maintenance phase, half of the patients remained on the drug, semaglutide, and the remaining were taken off the drug, and they were blinded to this. And then you can see that the patients who were not on the participants who were not on the drug, they ended up regaining the weight. So this question often comes up, what if do people have to take it long term? So the treatment has to be individualized, but in clinical studies, when these medicines are stopped, there is weight regain. So how do we, this is a summary slide of the 3 medications that are commonly available, and we use it here. So liraglutide is the short, all 3 are GLP receptor. Tirzepatide also has dual, so it has GIP. They all come in a single dose pen. There's dose titration that happens weekly. And you can see the side effects listed and contraindications. So very similar profiles, except liraglutide is a daily medicine and semaglutide and tirzepatide are weekly. So how do we dose these medicines? Liraglutide is 0.6 milligrams daily. And in a week, every week, it can be titrated. Every few weeks, it can be titrated. When it comes to semaglutide, we start with the lowest dose. So always for these medications, to reduce the GI side effects and to improve tolerance, and also helping patients adjust, because once they get on their these medicines, if they are having large portion sizes, they will have nausea and vomiting more so than if they have controlled portion sizes. So it is important. Sometimes I give longer time for patients to go up on the dose. So starting on the low dose and then deciding about titration based on how they are tolerating. Sometimes we can go up, like for semaglutide, every 4 weeks to the maximum dose of 2.4, and sometimes it can take longer. And it is not necessary that the patient has to be on the highest dose. Sometimes the one step lower, like 1.7 for semaglutide, can also do the same amount, the same weight loss compared to the higher doses. So it depends on the tolerance. And I've had patients who do fine on 2.4 of liraglutide or 1.7 of semaglutide or maybe 10 milligrams of tirzepatide, and they don't tolerate higher doses, or additional titration is not required because they have met their weight loss goals. This shows the comparative analysis of the weight loss greater than placebo, so placebo-subtracted weight loss of these three drugs. So you can see here that liraglutide, which was the pioneer among them, which is administered daily, is effective, but is somewhat overshadowed by weekly dosing because it's easier for patients to dose it once a week. It's less injections for them to take. And also there is more weight loss, 15-20% compared to 5% with liraglutide, which is not less, but compared to tirzepatide and semaglutide, it is less. There is increased risk of acute gallbladder disease with all these medications. So all GLP-1 agonists, there is an increased risk for gallstones, acute cholecystitis, but this is also true with bariatric surgery, that there could be increased risk of acute gallbladder disease if they still have their gallbladder. So there is, those are, and some other side effects and contraindications and safety concerns are listed here. So there were two series of trials done for these medicines. Semaglutide is GLP-1 and tirzepatide, the dual agonist. And I've compared both of them head to head. So STEP trials are for semaglutide and SURMOUNT trials are for tirzepatide in people with obesity. You can see at the end of the study, it's about 15% for semaglutide and it's about 20% for tirzepatide. So the dual agonist has been found to be more effective with weight loss. And these studies had a lot of patients, about 2,000 for STEP trial, initial step 1, and for SURMOUNT were close to 2,600 patients. Now, the important thing to know about these medicines, so far I've talked about how effective these drugs are, but there are people who will be treatment resistant. So it is not the failure on their part or not that they're not taking medicine or any other aspects. There is treatment resistance observed with these drugs also. And although 86% in the semaglutide group lost 5% body weight with substantial improvement in cardiometabolic risk factors and physical function, there were some transient side effects. With tirzepatide, 90% lost more than 5% body weight and 57% lost about 20%. But in addition to that, that's important to acknowledge that about 14% of the participants on semaglutide were treatment resistant and about 9% with tirzepatide. So even with these stronger, newer therapies, there will be some people who will not have response. And that's why we need multiple modalities for management of obesity. Now, moving on to some other newer drugs that are in pipeline in US, there's one drug where there's amylin instead of GIP, GLP, glucagon. This is a combination of amylin with GLP. So you can see here when the amylin analog is used alone, there's about 10% weight loss, 11% at 26 weeks. But when it is combined with GLP-1, the weight loss is about 17%. But the challenge is when the medication is stopped, you can see the weight starts to come back. So these medications have to be continued. It is the reversible nature of these benefits. And once they are stopped, discontinuation leads to weight regain. Now, the other one is a combination of GLP-1 with glucagon, as seen here. And this combination alone is 18% weight loss here. You can see the combination. And about 40% people lost more than 20% weight. So these are the drugs, the last two that I just discussed, GL with glucagon, the dual agonists that are still in pipeline and maybe coming out in next few years. Now, moving on to the triple agonist, this is very impressive. This is a synergistic effect of 3 different pathways. So the glucagon, the GIP, and GLP, so combining all 3 together. And because of this combination, this leads to a unique synergy where there is enhanced appetite suppression. There's also increased energy expenditure. There is improved blood sugar levels. So all these medicines are also effective in diabetes. So these trials are run parallel, some for people with obesity only and others with people with diabetes. So this is so far has been the most effective drug, the triple agonist. This was a phase 2 trial done looking at this effectiveness of this medication, and the trial was stopped at 48 weeks because that was how it was initially intended. And at 48 weeks, the weight loss was 25%. So had the trial continued, we don't know how further the weight loss would have been, because when it was stopped, the participants continued to lose the weight. So very effective, 1/4 of their body weight they were able to lose with this triple agonist. And the other interesting thing is, so far, like I alluded to earlier, that there's some treatment resistance with medications, the other ones. This is the first time we have a drug that had 100% success rate in participants achieving at least 5% weight loss. So this universal response is exceedingly rare in medical treatments, and this is a very unique phenomena. And in addition to that, you can see 25% of the participants lost more than 30% body weight. So we are talking about weight loss ranges that we see with sleeve gastrectomy, sometimes also with Roux-en-Y. So there is 25 to 30% weight loss. And it's not just a small proportion of small percentage of participants. A lot of participants lost that much body weight. Now, this is a summary slide for all the single, dual, and triple agonists. These are the ones that the 2 are available to us in US, semaglutide and tirzepatide. The retatrutide is still in the trial phase. It's now phase 3. So we will hopeful that maybe in a couple of years, we'll have this available in patient care. So you can see here, the important thing is the 100% weight loss with the liraglutide. Tirzepatide also had like 90% of people. There was more than 5% weight loss among 90% of the participants. And looking here at the 20%, greater than 20% weight loss, about 63% of the patients with liraglutide, 63% with tirzepatide, and about 35% with semaglutide lost that much weight. So this is a summary of all the weight loss with the 3 medications that I just discussed. At the end of trial, 15%, 23%, and 24% weight loss in patients with obesity without diabetes. There are other medications that I would not be discussing, but they are in the pipeline. They're in research studies, and you can see GLP, GIP combinations. There are different ones listed here, the different combinations, and you can see in the red how much weight loss, easily 20%, some more than 20% weight loss. Now, so far, I only talked about the injectable therapies because GLP is a peptide and it is unstable for oral administration in acidic stomach environment. But however, the semaglutide has been formulated with an absorption enhancer, SNAC, and that combination transiently increases the pH in the stomach. So the semaglutide, it protects it from degradation and can be administered orally. So there are now oral preparations that are available in US and that bypasses that challenge with the acidity. So in oral medications, there are two that are again in trials right now. The semaglutide oral preparation is available for, but the other ones, they are still non-peptide GLP-1 are in research phase. You can see 14 to 17% weight loss with these. This is a comparative slide of showing the oral and subcutaneous NUSH therapies. Here you can see in the blue are injectable therapies, and here are the oral therapies, and they are fairly effective. Now, a few concerns that I want to address with the GLPs, that is, one is these medicines are contraindicated in medullary thyroid cancer or patients with a family history of multiple endocrine neoplasia. Now, this is an extremely rare cancer, form of cancer, medullary thyroid cancer from the parafollicular cells. So there are other kinds of thyroid cancers like papillary, follicular. Those are not the C cell cancer. So this is unique to only thyroid C cell tumors. And that's a contraindications. But otherwise, if we take that group out, the studies have shown that there is no causal link to any other thyroid cancers, like the ones originating from follicular cells. So it's only for the medullary. The other concern raised was suicidal behavior and ideation. So there was a global analysis done and there was no significant increase in self-harm in patients who were on these drugs. It is recommended to observe for worsening depression and suicidal ideation, but so far on a global scale, there is no signal to suggest that there is increased risk of self-harm in patients taking these drugs. The other concern raised is what happens to muscle mass, and this is coming to with these medicines causing significant weight loss. This has become part of the conversation. But here's something I want to remind everybody, that the loss in fat-free mass happens with dieting, happens with doing any form of weight loss, weight loss, like whether it's nutrition, exercise, bariatric surgery, medication. So it happens with all of these. The important thing that we can do on our end to improve this, you can see here this green line showing the fat mass and the fat-free mass. So if it's diet alone, there is more loss in fat-free mass. But if we have protein and exercise, then we intend to lose less of the fat-free mass and have more loss of fat mass. So that's important with these medications. Here you can see that with the weight loss, the distribution of loss of fat mass versus fat-free mass, and it's mostly fat mass that is lost. Yes, there is loss of fat-free mass, muscle mass, but there's also now research looking into, is it the fat inside the muscle tissue that's affecting these numbers? But the majority of the weight loss comes from fat mass. What we can do on our end is recommend our patients to have higher protein intake, healthy sources of protein. So that helps with preservation of lean body mass. So protein is very important. Whey protein is a good option because it has a higher bioavailability and it's a faster absorption. So if they have to choose a protein, whey protein is one of the better options. The other important thing, because these medicines are so effective, sometimes we overlook exercise, but this exercise is very important in preserving lean body mass. So aerobic and resistance training based on patient tolerance, making sure patient is safe to preserve lean body mass and reduce fat mass. So in summary, this is the slide which has all the side effects that I alluded to earlier. The common side effects are mainly GI. The neuropsychiatric and sarcopenic are yet to be confirmed. There is some concern. Most of the studies now are showing that there's no significant self-harm. And then there are some in question mark where there is no conclusive evidence about thyroid cancer, pancreatic cancer. There's doubtful if there's any association at all. Any therapy we use, there is variation in response. So whether it's bariatric surgery, medications, lifestyle, and interestingly, patients with diabetes tend to lose less weight compared to patients without diabetes on these drugs. And even for bariatric surgery, for lifestyle changes, we don't really understand why this discrepancy exists, but it does. And this is true across the board for first and second generation medications. So it's just harder for our patients to lose weight when they have diabetes. This is again a summary slide, not just so you can see obesity is for GLP-1 medicines. Yes, it addresses obesity, but it also addresses diabetes, cardiorenal disorders, patients with stroke, reducing the risk of stroke, MI. So there are a lot of beneficial effects of these GLP-1 agonist. There's also now data in fatty liver disease, metabolic liver disease, and there are ongoing trials in other studies. So the one of the things that was part of the discussion is how effective are these drugs? Are they going to replace bariatric surgery? So the time will show. We have still triple agonist in the pipeline to come out, but they are getting closer and closer to the percentage weight loss that we see with with surgical interventions, and they are less invasive. So we are now bridging that gap between lifestyle and bariatric surgery with these medicines. You can see tirzepatide 20, and once we have the triple agonist, we will start having that overlap with bariatric surgery. And lastly, I want to mention this, that it is not these, because obesity is a very complex disease. It is not monolithic. There's multiple different factors to it. So therefore, we require a multi-pronged approach. So we could have primary medical therapy, surgical therapy. Like in cancer patients, we have neoadjuvant and adjuvant. So we could have GLP-1 before surgery. I do that all the time in my practice to reduce their preoperative weight. And many times post-surgery, if they have weight regain, then I introduce GLP-1. So it is a combination therapy that we would need in most cases, where we would need both. So historically and forever, nutrition, lifestyle, intensive behavioral therapy, and sleep will always remain the foundation of weight management. We had anti-obesity medicine as the second tier, and then metabolic and bariatric surgery as tier 3. But now with the newer therapies, the paradigm is shifting. With the NUSH therapies, where the weight loss is 10 to 25%, it is more, we could go the anti-obesity route, we could go do the metabolic surgery route, or we could use the combination therapy. Therefore, a collaborative, multidisciplinary approach that includes dietitians, behavioral therapists, medical practitioners, surgeons is essential for providing a comprehensive care. I'm going to stop here. I want to thank everyone for their time and attention.
Thank you, ma'am, for that very excellent deliberation on the future of obesity paradigms and how the paradigm seems to be changing now that we have drugs which are performing almost as good as metabolic surgery or bariatric surgery. And this is what we will be discussing in the panel that follows after Dr. Trence's talk, where we'll see whether the way forward is bariatric surgery out of the door, once we have all these NUSH therapies. So I'll request you to please stay back for the panel discussion. We now, it's my pleasure to invite Dr. Des Trents, who's going to talk on what's going to be new in diabetes management for 2025. She's Professor of Medicine, University of Washington, Seattle, United States. She's Professor of Medicine Emeritus in the Division of Metabolism, Endocrinology, and Nutrition at the University of Washington in Seattle. Immediate past program director of the Endocrinology Fellowship at the University of Washington, She is member of ACE's Board of Directors, serving currently as treasurer, and has chaired ACE's Cardiometabolic Conference in 2020 and 2021. She is also immediate past chair of ACE's Disease State Network Oversight Committee and past editor of Empower magazine, ACE's informational magazine relating to hormonal and metabolic issues targeted to the lay population. She's published in a number of endocrine journals, including Endocrine Practice, JCEM, Diabetes Care, and Diabetes Educator. She's been bestowed the ACE's Outstanding Clinical Endocrinologist Award in 2014, the Master of American College of Endocrinology Award 2019, Yank D. Coble Jr. MD Distinguished Service Award in 2022. So welcome, Dr. Trends, and the podium is all yours.
Thank you. Let me see if I can bring up my screen. Okay, I'm hoping everybody can see this.
Yes, we can.
Excellent. So I first also want to thank the organizers of the symposium for the opportunity to present to you and thank them for a topic that I found quite challenging in terms of being predictive of what's going to be available for diabetes management. If not, I will say for 2025, certainly in the immediate years to follow. I think this is a time that we are seeing just some exciting developments in management and treatment of diabetes. Whether they will be available in terms of cost or even able to get them will be another question. But the efficacy of some of these treatments has really been somewhat remarkable. And I think this follows up on Dr. Agarwal's certainly presentation. So given my time restraint, I will say that we have to limit some of our discussion to some 5 areas. I do want to talk about some of the newer insulins that are coming out. I will touch also on non-insulin therapies, which will include discussion building on Dr. Agarwal's presentation. I want to talk a little bit about the delay of development of type 1 diabetes, as well as the impact of some treatments we are now seeing available to slow the progression to full-blown insulin dependence. I'll talk a little bit about continuous glucose sensors and what we're seeing coming out, and just touch a bit on insulin pumps. So a lot of information to cover. I will not be able to cover it in the depth that might like to if there was more time, but I think we can reserve that for discussion if there are questions. So insulin has never been something anyone willingly wants to get onto. I think we all know that for the patients that we treat, that injections always have a little bit of a startle factor when we discuss it. So one of the goals with insulin is to try and make it as user-friendly as possible. And people have tried a lot of things, the inhaled approach as an example, but there's a recognition that if we can minimize some of the injection frequency, that this actually may benefit our patients and be a tool that we can use. And so we are seeing actually a plethora of basal insulin studies being produced, being published with the data as an example. In this particular example, published now some 4 years ago, looking at a review and a meta-analysis of phase 2 randomized controlled trials. This is insulin icodec, and its comparator was U100 glargine daily. Again, it's a once-weekly insulin. It was associated with a small, perhaps a rather insignificant reduction in A1C, but there certainly was evidence of a higher time in range. Hypoglycemic events for type 2 individuals were very similar. In contrast, and I'll mention to type 1 individuals where this has been tried and unfortunately resulted in our regulatory agency, the FDA in the United States, actually stating when the icodec people submitted their data for approval that they needed to address this issue in particularly type 1 individuals, but not so in type 2. So what we saw, and as you can see here on the screen, a little bit of a benefit in the blue being the icodec in A1C, not huge. I think it's looking better here when you look at people achieving a targeted A1C, less than 7% here, less than or equal to 6.5%, again, favoring the icodec group. And here we see that there was actually also a suggestion that perhaps there was less insulin daily dose required in the icodec treated group. Another once weekly insulin, insulin FC, and this again was in a type 2 patient population that was looked at, saw some similar results. Again, we're not seeing a lot of change in A1C, and the investigatory drug was actually looked at in 2 different doses, the target fasting being somewhat different for one group than another, 120 in one group, 140 in the other, and the comparator in this case was insulin degludec. So again, you can see not a lot of change here. If we look at the time and range, again, not a large difference between all of the insulin regimens that were tried. Variability in terms of glucose variability was also not highly different. So I think we're looking at something that would suggest that this insulin has at least non-inferiority as compared to degludec. However, there was one big difference, and I think this is what makes this particular insulin very attractive, and that is that in the investigatory insulin group, these groups had a 25% lower hypoglycemia incidence than the degludec group. So a little bit of a difference in terms of comparing it to icodec, but you can see the appeal of a once weekly insulin. If we then move on to non-insulin treatments to treat type 2 diabetes, and much of this data, I won't have to go into detail because Dr. Agarwal so nicely described everything. And I think we need to look at tirzepatide, which has really made a huge dent in the ability to treat people with diabetes as well as obesity. In our country, as the second bullet point points out, type 2 diabetes treatment with tirzepatide was approved before the obesity treatment was approved. And I think what's important with this dual agonism hormonal approach is that there is now a lot of data coming out with regard to the role of tirzepatide in heart failure prevention or treatment, cardiovascular disorders. This actually just came out in the past couple of weeks with regard to protective effect, both with regard to cardiovascular disease as well as renal disease in a population with type 2 diabetes. And what we're going to also see with regard to a benefit in non-alcoholic steatohepatitis. I think that this speaks for itself when we look at the success of tirzepatide as compared to just a GLP-1 receptor agonist alone. I'll just kind of point out to this particular dosage of 15 milligrams. So if we use just GLP-1 receptor alone versus insulin alone versus a placebo oral drug, I think the results speak for themselves that this is very successful in the treatment of type 2 diabetes, and I think increasingly may become a forerunner in terms of the armamentarium. A lot of debate going on with regard to metformin as being the first step. It's a drug they're all familiar with. It's been out for a long time. It's oral, but there is movement clearly to suggest that perhaps GLP-1 receptor agonists and perhaps the dual ones, now the GIP and the GLP-1, may actually become forerunners, given that there are more of these now being produced and perhaps not just access, but also cost will be more favorable. This then brings us to the triple agonist approach. Again, I think Dr. Agarwal so nicely reviewed much of the data. I just want to add a few points that were not covered. We know that dual works better than single with regard to the agonist receptor cohort. This particular study was not targeted to people with diabetes, although they had, and I want to just point out, a fair number of people with prediabetes, about 30 to 40% had prediabetes, and this was in both the treated and the control groups. If indeed you had a BMI that was quite generous, in contrast to what we heard in our first speaker of targeting 27, again, an American population is a little bit different with 27 to 30 BMI, requiring at least one additional related condition, hypertension, prediabetes, or dyslipidemia. Again, it's once weekly, as we've already heard, and the goal was to actually see what the benefits were with regard to weight reduction. Again, we seldom see, as again, Dr. Agarwal so nicely pointed out, something that's 100%. In fact, I think we're all taught in medicine that if someone tells you it's 100%, one should always kind of raise a little red flag and say, I'm not so sure. But the results were really rather striking when we look at it clinically. I will mention, however, that there was an increased rate of discontinuance of retatrutide in individuals treated with this drug, in contrast to those who did not receive the drug, the placebo drug. And these were not exotic side effects. The side effects that we all know are associated with at least a GLP-1, nausea, diarrhea, vomiting, constipation. Again, as I mentioned, not very exotic. So looking forward to have the ability to use this, which I think will be available, if not in 2025, certainly in 2026. What I think is unique to this drug is that there are now some subgroup differences that are coming out with regard to the benefits. And again, remember, this is not a group that had type 2 diabetes, but a fair number having prediabetes. So the greater the weight at the study entry, the greater the percentage of weight loss. Also, curiously, females seem to lose more weight than males. There were also additional improvements noted in blood pressure, systolic and diastolic. Glycated hemoglobin was checked again, although this was not a group that had type 2 diabetes. Fasting glucose was checked, lipids improvement was seen. All of these improved except for HDL. Of note, however, and I think something again clinically that we would all like to have in our armamentarium is the treatment of prediabetes. So 72%, so almost 3/4 of participants who had prediabetes entering the treatment arms actually reverted to normal glycemia, those that were treated with retatrutide. So it begins to suggest that perhaps precision medicine here may play a role, that we can actually use some of these drugs more specifically for certain patient populations. So one prediction is that there will be a movement to once weekly basal insulin in the next year or shortly thereafter, and that we will see increasing use of the once weekly GLP-1 receptor agonists or combination receptor agonists in the treatment of type 2 diabetes. Other pipeline developments to follow, and some of this, again, Dr. Agarwal touched on with regard to the glucagon and GLP-1 receptor agonist combination, again, associated with weight loss. Most of these studies were really directed to weight loss and not specific to diabetes management. But as we know, diabetes type 2 responds nicely to weight loss. We are going to see movement towards oral forms of GLP-1 receptor agonists. Many people really have struggled with injection. It's just something that is not part of what they will willingly accept, even if you tell them that if you get this drug, it will help you lose weight. So oral forms are being aggressively looked at. And again, I think this was touched on. We already have semaglutide in oral form, but not at these high doses. The weight loss is not as great as when the injectable form is used, but it still is present. And I think not just oral makes sense in terms of having this as part of our toolkit in the treatment realm, but that they are increasingly more user-friendly. So, for example, this particular drug in investigation can be taken without food, water, or other medication restrictions. So it becomes a more user-friendly type of medication, and hopefully, in turn, then something that would be more successful therapeutically. There is emerging data. We all know the side effects of the GLP-1 receptor agonists and the combination GLP-GIP drugs. None of this is terribly surprising or brand new. We've touched already on some of the thyroid tumor concerns and pancreatitis, but there is some data coming out as these drugs are increasingly being used with regard to very rare, but certainly concerning side effects. And this received a lot of attention earlier this year with what is called the stroke of the optic nerve. So you can also call it non-arteritic anterior ischemic optic neuropathy, which is a condition obviously that impairs the vision and concerning despite its rareness, fortunately. Our patients don't see this. Our patients look at the web and they see things such as hair thinning, the gallbladder issues of cholecystitis or cholelithiasis, muscle loss, particularly facially, or the gluteal areas, and that is their concern. I think some of the recommendations you've heard already from Dr. Agarwal in terms of how to prevent some of the muscle loss in particular, but we are seeing that these are reaching a lot of attention, and patients are being very concerned about whether they will continue the drug or not. And we know that many of these drugs, unfortunately, don't tend to be continued, with recent data suggesting that perhaps even 40% will discontinue after 6 to 12 months of use. There are benefits that are coming out, and actually, if you look at the literature, and I'm sure you're seeing this too, every week there is something good about these drugs. decreased sleep apnea symptomology or onset, less Parkinsonism symptom onset or severity, less dementia, Alzheimer's. The list goes on and on and on. I don't have a complete list. Some of this has been reviewed in this particular reference I have noted here for your review, although it's almost yearly that you have to have an update, given that we're seeing these reports on a weekly basis. There are some keep in mind points, I think, as we look at these drugs for our patients, and that there are some slow responders. Many people want some immediate effect. So patients are frustrated if they don't see that they've lost weight within the first couple of weeks of treatment. And so I think if we break out in terms of how much weight loss is seen, you can see that slow responders clearly are quite different than those that respond much more quickly. There's been a lot of question as to why this is. Is it because people are missing doses? Is the titration of doses to a more therapeutic level going too slowly? Kind of blame the patient, blame the treating clinician. But I think we have to keep in mind that perhaps, as was already mentioned by Dr. Agarwal so nicely, that there are non-responders. And you can actually see published reports that it may be as high as even 15% for some of the studies that have reported this. I'd like to go on next to type 1 diabetes, and although most of us see the majority of our patients as type 2, type 1 diabetes needs attention. It unfortunately is also increasing in prevalence and incidence, perhaps related to weight issues in particularly our youth, but it is something that we are seeing actually across all age ranges. So I want to talk about teplizumab. This study came out, as you can see now, some 5 years ago, and it's an anti-CD3 monoclonal antibody therapy. It is given by infusion daily for 14 days, and the results in terms of taking individuals that are at what is called stage 2 diabetes, or you can think of it simplistically as the values for prediabetes, glucose values for prediabetes, accompanied by positive antibodies. Rather remarkable in this graphic, as you can see, out to 5 years of people that have received the drug and have not gone on to our more classic type 1 diabetes picture, in contrast to those that did not receive the drug. So I think it's really something rather amazing that has come out in the literature. This is using the same medication, teplizumab, different study, different group, a little bit longer. You can see this is actually some 6 years of follow-up. And again, dramatic difference in terms of the slowing of progression of type 1 diabetes in those who are at risk in stage 2. And this is largely related to a preservation of insulin production. You can see the C-peptide level here in contrast to those who did not receive the drug, actually remaining rather stable over the course of study. So an exciting therapy to consider. One of the challenges beyond the immense expense of this therapy, in the range of some $45,000, obviously not something that vast majority of people can even think of, is that one does need to remember caveats in making the diagnosis of risk for the development of type 1 diabetes. Antibody levels need to be obviously checked because they are part of the armamentarium, the diagnosis. But I want to just point out that if one uses just one autoantibody to check, and typically people are using this GAD antibody, that this will be followed by a negative confirmation test subsequently. Antibody titers, we have learned, can come and go. A bit frustrating because you would like to actually have them go completely and not ever come back. But this kind of waxing and waning process has been known actually for some years and has only been re-exemplified now that we have even more antibodies to use to check. If, however, one does follow the American Diabetes Association recommendations in screening and you have the ability, people can afford actually all of these antibodies, all 4 of these being checked, this obviously has high predictive value for the development of type 1. And these would be the people in particular that one would want to consider seriously for the possibility of getting teplizumab. So a prediction is that there will be a movement to more screening in those that are at risk for the development of type 1 diabetes, given that we at least have the ability to discuss and offer some therapy. And I think even more exciting is that even in the very early stages of now stage 3 diabetes, type 1 diabetes, which is full-blown type 1 diabetes, that this drug, teplizumab, also makes a difference in preservation of C-peptide levels at that point of diagnosis. The challenge sometimes, however, with this particular approach is that we don't have one single standardization of treatment approach. So this particular report showed 2-day, 12-day courses. And imagine the expense adding up now, but there also have been reports of 10 days, 14 days, one course versus two courses. So I think there's still some confusion here as to what's the best approach ideally and what's obviously efficacious and affordable. Again, if we look at the primary endpoints, and there are a number of these actually looked at: insulin doses, A1C, time in range, hypoglycemia, all looked very positive for teplizumab in this group. Again, C-peptide being preserved. And remember, these are not cures, either in that stage 2 diabetes or in stage 3 diabetes, but it is actually a slowing in the loss of insulin production. And that is very important because much as you can preserve of insulin production actually translates to a decrease in complications developing, the complications that we know are associated with diabetes overall. Time in range, again, in the black, this teplizumab group, again, certainly favors the group that received the treatment. And daily insulin doses also seem to be less, not zero, but less actually in those treated with teplizumab. There's a very nice meta-analysis, again, it came out earlier this year. For your reference, I have put that below. And again, in all of the studies and all of the protocols, there is certainly the evidence that C-peptide preservation is really the goal and consistently seen. Insulin doses, as I showed in the previous graphic, were less in patients, at least initially, but perhaps over time, really not greatly different, which is rather interesting, despite the fact that C-peptide was preserved. And this preservation with the initial treatment lasts, which is, again, I think rather amazing. Studies up to 7 years would suggest that there is certainly an impact on preserving C-peptide function. Again, I mentioned it's very expensive, so people look at other types of approaches, and this is a TNF-alpha blocker, golimumab, that was used. Again, seeing it's an infusion again, but again, this is an early diagnosis, so we're talking within several weeks to at most a month or so of patients who were diagnosed as type 1. Again, preservation, as you can see in this black line, of C-peptide production, and you can see again responders with regard to placebo in the black, and now the treated groups actually in the white bars, that there is an impact also on C-peptide and insulin production. Again, those are infusions, they're expensive, but we now also know that trial has been very successful with an oral drug, one familiar to all of us, verapamil, in the treatment of hypertension, and orally certainly much more acceptable than infusion. And here too, we're seeing some preservation of C-peptide. You can see here in the treated group, C-peptide remains very stable. In contrast to those that did not receive the verapamil, the C-peptide production actually went down. It's well tolerated. Obviously, cost is not the issue that it is in some of the infusion. So I think that this shows some potential for use and consideration, and certainly discussion in patients with newly diagnosed type 1 diabetes in your clinic. So prediction, a movement to intervention, delay of onset, as well as progression of early type 1 diabetes. I wish I could say that we have a cure, but that obviously is not the case. So touching a bit on sensors, they are getting smaller. They are getting longer lasting. We just in the US had approval for a 1-year duration of the implantable Eversense sensor. But I think more exciting is that we are moving towards over-the-counter continuous glucose monitors. Both Stelo and Lingo in the US have come available actually this summer, and Lingo actually in the past week or two. We are still waiting for the Rio version, and I'll mention the difference in these. But the ability to get sensors, hopefully at the pharmacy locally, for anyone who wants it without prescription, so you don't have to see a physician, you don't need a prescription, I think will have dramatic impact, I think, for many patients and individuals. So this is the Stelo. Looks very much like the Dexcom sensors that we're all familiar with, and not much different in terms of 15-day wear. cash pay option, certainly, so insurances don't have to be approached, and they won't be if you don't have a prescription. Readings every 15 minutes. The drawback, however, is that pharmacies will not sell this first, that this will only be available for e-commerce website. I think there's some concern about just what the demand may be for this, but we are told that the costs should not be any different than those who have insurance for the prescription device. Lingo is designed for patients without diabetes who are interested in dietary choice and exercise focus. You can see it looks very similar to the Libre. It's been available already in the UK since early this year, and it's been a little difficult to get cost estimate. Again, as I mentioned, the sensor people all would like to say that their cost of their product will not be any different than the prescription covered devices. But this is actually from a blog of someone who's purchasing it, and you can see that they found their cost was quite a bit different than what had been proposed. So I think this is something we'll just have to see, again, as there's more availability and the e-commerce sites are up and going. Glucose levels, you can see, is maxed out at 200. This is not designed for people with diabetes, and there are no alarms. The Rio, which is not out yet, and so this may or may not be what it looks like, is indeed intended for people with type 2 diabetes over the age of 18, specifically who do not use insulin, and typically, as you can see, as the website says, manage their diabetes through lifestyle modifications. But you can see that this would clearly be something efficacious for those who are on oral medications or trying, again, no medication approach. No alarms, which is always a question as to how this got by our regulatory agency, with a range of 40 to 400 milligrams per DL. And again, e-commerce website, so I think it's something we'll stay tuned to see just what the cost actually will be. Hopefully, at some point, we will have the ability to have pick these up actually in the pharmacy, just like anything else is picked up. But I think we'll see a movement towards increased use of CGM, irrespective of direct glycemic pharmacologic treatments. Finally, I'd like to just finish a little bit with regard to other tools to manage diabetes. And this is really to keep in mind that insulin pumps are getting, and sensor combinations are getting easier and easier and easier and user-friendly for patients that have diabetes. So I have an example of the iLet bionic pancreas that came out now over a year ago. And the beauty of this is that there is no carb counting, a skill that many, many patients, and I think even us as clinicians sometimes find a bit daunting. So you don't need to count carbs. You don't need to do any calculating boluses or corrections. And you only need a body weight entered into the system and software to get started. And you can see that there's clearly a sensor and indeed a pump. Makes a big difference with regard to improvement of A1C, even in patients who are rather well controlled to begin with. Again, it's approved for those 6 years or older. You put in at mealtime what you estimate as a small carb meal, a medium carb meal, or a large carb meal personalized. You don't count the carbs. And over time, the software adjusts for these so that it can actually give an automatic bolus depending on which of these you actually enter. So it's not a good system for people who like to micromanage, but it's a good system for people that want nothing or very little to do with managing their diabetes. And I think additionally, as we see the port for glucagon actually become active, that this will actually translate to a full artificial pancreas. Outcomes for the iLet in particular, again, in people relatively well controlled, you can see improvement versus the standard approach, which really showed no budge. I also think that in terms of any significant difference in hypoglycemia, this didn't seem to be an issue, again, suggesting that perhaps the glucagon port isn't as necessary as we would like to think, but I think we also would like to see that additional feature. And finally, to end, I think we'll have a lot of devices coming out. We've had certainly the Vigo patch pump out for a while, but we will see another patch pump that will deliver prandial insulin that will be used. You can see this is 2 units per little press, so for people that require a lot of insulin, this may be a little bit of a challenge. Typically holds about 200 units directly. Inhaled insulin still is on the market, and I think we're starting to see perhaps a little bit more use of it now and then. and clearly devices to help manage diabetes, help in the decision-making process specific to insulin. What do I give? How much do I give? What time do I give? I think all of these hopefully make the management of diabetes for each patient somewhat less of a burden. So friendlier insulin delivery systems, keep an eye out for these. And with that, I want to thank you for your attention and certainly look forward to your questions and comments. Thank you.
Thank you, Dr. Trents. That was a very enlightening talk on how the future is very bright, futuristic as well, with the kind of technological innovations that we're having, besides all the pharmacological innovations that we have, which all are probably aimed at making lives of our patients much better as the future unfolds. We now have Professor Shashank Joshi, who's joined us. He was delayed because his flight got delayed. He's with us now. I think everybody knows him, consultant endocrinologist, Padma Shri, past president of API, RSSDI, ESI, so many associations, so on and so forth, president Indian Thyroid Society, president Indian Academy of Diabetes, past president International College of Nutrition, 1,000+ publications, authored 100 books. He's ranked in the top 0.5% in the field of general and internal medicine across 1 lakh+ authors globally, was bestowed with the highest civilian honor of the country, Padma Shri, by the Government of India in 2014. He is currently working as an endocrinologist at Leelavati Hospital, Sir H.N. Hospital, Joshi Clinic. Past president of Endocrine Society of India, Association of Physicians of India, Emeritus Professor Japi, past Dean Indian College of Physicians, past president RSSDI, Indian Thyroid Society, past India chapter chair, American Association of Clinical Endocrinology, and currently he's chair of the APAC committee that we have with the ACE, and also the immediate past chair of IDF Southeast Asia. So we all know him well. Since he's a little exhausted, we'll just play his lecture in recording and then we'll have him join physically for the panel discussion. So can I have Dr. Shashank's lecture, please?
Hello, everybody. Today we are going to discuss obesity treatment paradigms as we talk in 2024 and as 2025 will emerge. At the onset, I don't have any duality or conflict of interest for this talk. This talk is a part of an educational exercise conducted by Cmre, which is conducted by my brother, Dr. Rajiv Chawla and Dr. Shalini Jaggi and their entire team. I congratulate them. And they made a lot of sincere effort to promote American College of Clinical Endocrinology in their meeting virtually. We are meeting on virtual platform and I will be with you physically also in New Delhi for the panel discussion. So, as I said, that the first part of my talk is actually based on a consensus document. The American College of Clinical Endocrinology, or Association of Clinical Endocrinology, came out to address the stigma and bias for diagnosing and managing people with obesity and adiposity-based chronic disease, and addressing the bias and stigmatization as the determinants of disease severity. So we all know that obesity is a disease and people living with obesity need to be recognized. We need that it's a chronic care model, and obesity has an ability to disrupt economies. Now, there is a lot of bias, whether it is the societal bias, because we need to ensure that we need to have a healthy built environment, policy, education, research, access to evidence-based care, culture for wellness, health parity, support, and outcome and evidence-based care. We also need a prepared healthcare system, like trained doctors and professionals, evidence-based care, patient access, which is outcome-driven, a lot of digitalization and digital connects and informatics. We need a lot of leadership, commitment, preventive care, and continuity of care. We need to do a lot of coordination across various teams, population-based outcomes, patient advocacy, and eventually recognize an entity called ABCD, pathophysiology. And all this is for a single goal, which is to optimize outcomes. And the idea is to empower an activated patient so that he has access to the right information. It recognizes the ABCD paradigm as a disease. It is a partner and shared decision-making with the patient. They are able to self-manage and self-advocate. There is a active participation from their family or caregiver community, and we build a robust, sustainable support system. So we need to understand that there is a lot of bias. And when we screen for internalized weight bias, there is a stigmatization attached to the word obesity. Whether it is at a parental level, familial level, community level, societal level, employer level, or social media, we need to recognize that people living with obesity, we need to break that weight stigma, whether they are overweight or obese, because it has direct psychological consequences of anxiety, depression, maladaptive eating behavior, rebel mechanisms, eating disorders, and avoidance of healthcare. So it's like a vicious cycle people get caught in. And therefore, we need a cognitive psychological construct. And we need to ensure that we are able to respond and have call for action to medical and surgical options which are available. Often we falter and have not very good outcomes. So as I told you that when we look at a biophysiological and social model for obesity or adiposity-based chronic disease, and I like the word ABCD more than the word obesity, which my friend Dr. Cmre Mechanic was a past president of ACE coined long time back. It is a mixture of psychological factors, social factors, and biological factors. We all are knowing that there are some irreversible genetic factors or biological factors like age, gender, genes, but epigenetics is environmentally influenced genes, adiposity-based complications, comorbidities or multimorbidities, medication, nutrition, and physical activity. Then we have social factors like socioeconomic status, access and educational status, marital status, social support, built-in environment, food security, and recreation. And then we have financial stressors, economic stressors, life events, medication burden, misuse or abuse of drugs or recreational drugs or tobacco or alcohol or binges, physical inactivity and sedentary habits and recreation. So those are some of the crucial factors in the biophysical social model. Having said that, one of the biggest challenges today in planet Earth is that we are 8 billion people living on planet Earth. And, the number one killer on planet Earth is heart disease. And the prime driver for heart disease is underlying obesity. And prime obesity has a major comorbidity in diabetes. So if you look at the triangle of obesity, type 2 diabetes, and cardiovascular burden, it has a factorial of more than 3-4 or 75%. And that is the equation which we are seeing the entire burden of disease. So I wanted to allude and educate everybody, if you don't know, this beautiful model of CMB-CD, which is cardiometabolic based chronic disease model, which was postulated by Dr. Cmre Mechanic way back 5 years back. And it is based on adiposity-based chronic disease or dysglycemia chronic disease, and there are ACE guidelines on them. So adiposity-based chronic disease has two components. It reflects the abnormalities in the mass structure and distribution of fat. And the chronicity tells us the risk, presence, and severity of complications. Similarly, DBCD is dysglycemia-based chronic disease, which includes prediabetes, insulin resistance, and type 2 diabetes, and is associated with risk of progression. But whether it is ABCD or DBCD, we need a medically actionable model to address the underlying pathophysiology, which delineates the interrelationships between obesity, type 2 diabetes, and cardiovascular disease. And that has been labeled as cardiometabolic based chronic disease. And fundamentally, it outlines primary, secondary, and tertiary prevention of cardiovascular disease in end-stage development of chronic disease progression. So, ideal is to identify at risk in stage 1, whether it is ABCD, DBCD, or CMBCD, which is essentially the traits of metabolic syndrome, whether it is dyslipidemia, hypertension, insulin resistance or beta cell dysfunction, or genetics or behavior. Unfortunately, we don't intercept them there, and we'll end up with pre-disease whether it is the ABCD, which is overweight or extra fat or ectopic fat or abnormal dysfunctional fat or pre-diabetes or subclinical heart disease or LV dysfunction with normal ejection fraction and so on and so forth. But we are end-stage specialists and we often see stage 3 disease and stage 4 complications. We know that I don't like BMI as a threshold for obesity, but that's how it is defined. Then we have oxology like waist height ratio and waist circumference as thresholds for ectopic fat and adiposity. And then we have biochemical thresholds. And then, of course, we have complications which could be cardiometabolic, biomechanical, microvascular, or heart related. The biggest challenge when we see people with diabetes is the weight gain during type 2 diabetes because it's clinically dangerous. And this is called as the kg-A1C paradox. For every 3 kilogram of gain, it offsets the 1% drop of A1C. And for every 1 kilogram of gain of weight due to type 2 diabetes, there is a 7% increase heart failure risk. So clearly we see that we need to drop the weight. And for every unit BMI rise, the first year of diabetes, the cardiovascular mortality goes up by 12%. And the heart risk keeps propelling up as we approach the World Heart Day this month. So clearly, the 5 A's for ABCD or obesity are, when we are looking at persons living with obesity, ask if you can discuss weight and health impact of obesity. So first is initiate a diagnosis, respect the person in front of you, and take consent. Can we make a dialogue? Because often people feel offended if you give them curbside remarks. Never call anyone obese. What person in front of you may be obese in India may actually not be obese in New York or Europe. So it's very important to be mindful of the conversation, respectful of conversation, and humble in your conversation so that you are able to get a shared decision. Second is assess the health status and complications. Then give advice on treatment options based on severity of obesity. Then agree in a shared way for a treatment plan and weight loss goals. And then assist a continuous process of weight management with reassessment of goals and treatment options. So we have 3 approaches. One is, of course, a surgical approach, mainly reserved for morbid obesity now, and that will shrink with the big ticket drugs, which are now changing the economies of countries like Denmark and United States. And then, of course, lifestyle, diet, and behavior, which is like, eat less, replace a meal, do physical activity, do behavioral therapy, have patient support systems, or use, artificially enabled based programs like WBT, whole body digital twins, etc. So that is a lifestyle. Very easy to advise, very tough to follow. Adherence is the key there. That's where it falters. Pharmacotherapy space has been cluttered, clouded, and battered till arrival of some drugs now. Orlistat survived the entire onslaught. We had unfortunate demise of rimonabant, sibutramine, and many other drugs due to adverse events. Liraglutide 3 milligram survived. Oral semaglutide, injectable semaglutide 3 milligram, 7 milligram, 14 milligram, and 2.4 also survived. But in the Indian regulator, they still need a regulatory approval for obesity space. Then you have naltrexone, bupropion, phentermine, topiramate, dual agent tirzepatide, and triple agent etrasimod. These are the agents which are approved by the US FDA for obesity. And in India, we have only Orlistat approved. Liraglutide for obesity is not approved. Semaglutide for obesity is not approved. And tirzepatide also for obesity is currently not approved. They are all diabetic drugs, but they are all causing compelling weight loss with outcomes which are appropriate. And then, of course, you could do endoscopic bands, you could do gastric sleeves, you could do Guillain-Barré bypass, and the order goes on for surgeons. But for a weight loss drug, you need 5% weight loss. Metformin never made that cut because it costs 2.5%. So remember that the biggest challenge with weight loss is after you achieve weight loss, our body creates an environment to favor weight regain. So if you have lost weight, physiologically, the hunger will go up because there is an energy gap. So body signals in the mind that you are hungry, you want to eat more, you want to eat calorie dense food. And you are spending less because body feels it like a threat that you have lost weight. So my energy stores are depleted. So in a miserly aptitude, it will conserve energy and there will be down regulation of fat oxidation, up regulation of cortisol axis. And this switch will down regulate the sympathetic nervous system, the body mass, the leptins, and there will be a modulation of the satiety hormone, which will get down regulated, and hunger hormones, which will get up regulated. Hunger hormones are namely ghrelin, neuropeptide Y, the agouti-like protein. The satiety hormones get down regulated like GLP-1 and the peptide YY and the POMS and so on and so forth. So this is actually what happens, and which is why we fail in weight loss, because our body is structured in a way that minute we lose weight, body views it as a threat, and our internal apparatus tries to ensure that it regains that lost weight. So this is the biggest problem in weight loss. And in lifestyle, 8 out of 10 people need an extra intervention even after weight loss. More than 50% of people return to the starting weight within 5 years after starting lifestyle. And most of them will regain weight itself in the first year. So initially, when pharmacotherapy came in, their role was as an adjunct to the primary therapy, which means they were weight regain stopping agents. That is how the obesity pharmacotherapeutics evolved. He let us switch off whatever weight you have lost by whatever method you are doing. Let's not able to regain the weight again. And when it comes to people with diabetes, we have all types of agents. We have agents which cause weight gain like secretagogues and glitazones. We have agents like alpha glucosidase inhibitors and gliptins, which are predominantly weight neutral. And then we have agents which can cause and promote weight loss like SGLT2, metformin. They don't make the cut. Then, of course, we have the pramlintide and amylin pathways, which are now being explored. And then we have the GLP-1 and the peptide single agents, peptide dual agents, peptide triple agents. And that's where the therapy is moving. Initially, our therapy for diabetes was very glucose-centric. And that was called as a downstream approach. Now, the treatment approach to diabetes itself, it is viewed as a comorbidity of obesity. And obesity is now even American Diabetic Association is having an obesity association. Of course, American College of Clinical Endocrinology has been one step ahead of the rest because they have always recognized obesity. Their first guidance on obesity and overweight came way back in 2012. So a weight-centric upstream approach has always been in the ACE guidance. Remember, ADA, ESD is a consensus. AACE is a guideline which will be elaborated by the subsequent speakers in this meeting. It's very, very important to recognize that weight-centric approach is an upstream approach. And therefore, in that upstream approach, we are trying to reverse or slow down the disease course and disrupt the underlying pathophysiology, take care of the cardiovascular risk, micro and macrovascular risk. So even if you get up to 5% weight loss, blood pressure and diabetes is taken care of. If you get 5 to 10% of weight loss, dyslipidemia resolution, PCOS resolution, MAFLD resolution, and prevention of type 2 diabetes. If you get 15% or 10 to 15% of weight loss, you get cardiovascular disease, urinary stress incontinence, MASH, sleep apnea, GRD, and so on. And if you get more than 15%, you can get remission. You can get MASH remission. You can get diabetes type 2 remission. You can get heart failure prevention. So it's clearly disease-modifying agents. These new agents, which cause 5 to 15% of weight loss, are having a disease-modifying effect. They're improving the metabolism, they're improving cardiometabolic risk, and they're improving quality of life. So the entire spectrum started from type 2 diabetes and has emerged into the weight loss options. They have changed the quality of life. They have improved metabolism. They have improved the cardiometabolic care, but mainly are the modern disease-modifying agents. And therefore, all guidance, including 2024 and 2025, is almost ready. It will be out very soon. Clearly have compelling agents with weight loss, very high, top on the list, tirzepatide, followed by semaglutide, right up there in the categories. And they are right up there in the entire weight loss spectrum. So as I told you, we are looking at CMBCD approach, which is a cardiometabolic based chronic condition approach. And as I told you, BMI is a very poor measure of adipose tissue related disease burden, because it's the fat quantity, the fat quality, the location which matters. And therefore, personally, I prefer to avoid the term obesity. A, because of the stigma and the societal impact. But I like to use the word adiposopathy. And particularly it is true for the thin fat Indians, because adipopathy is the key pathogenic driver for many conditions. And it represents a disease continuum. And the goals of treatment and outcome measures differ by disease stage. So the entire type 2 diabetes management spectrum is person-centric, patient-centric, and is now weight-centric and not glucose-centric, and that's a paradigm change. And therefore, weight has become the center of attention. As I told you, in the US, orlistat is approved, phentermine, topiramate, naproxen, bupropion, liraglutide, and then, of course, we have now the tirzepatides, which are also. But as I told you, every anti-obesity medicine, starting from the 40s thyroxine, the DNPs, the amphetamines, and the aminorex, they all were banned. It was pre-1990s. 1990s to 2000, fenfluramine, propinphenylamine, leptin, all of them. Rimonabant, suicides, sibutramine, CV toxicity, locurcurin, cancers, all of them are gone. So we need to ensure that we need agents which can make a difference. Before that, we need to do one reality check, because obesity has biological underpinnings, it has genetic underpinnings, it has psychological underpinnings, it has social underpinnings, it has environmental underpinnings, and there are a lot of medications which promote weight gain also, including some of the complementary alternatives. So it's very, very important to recognize that it is not a simply due to an individual choice or lack of willpower. It is very easy to blame somebody. He just doesn't have the willpower. It is just not, he's not making the right choices. Do not blame the person living with obesity because he's weak-willed or he's not making poor choices. Because appetite, human appetite, is regulated with a very complex interplay between the gut and the brain. There are people who eat a lot and never put on weight, and there are people who eat a little and they put on a lot of weight. So human body is also very unique, and there is a lot of variability in the weight gain and weight loss. So people with obesity must be aware that obesity is a complex disease. It is not solely attributed to lifestyle, which will lead to hurtful and harmful self-blame and has to be addressed medically and scientifically in a rational and a correct. And for that, we need to understand what are the neurohormonal actors in the energy equation. And that's very, very important, that we spend energy, but before we spend energy, we store energy. We are misers. So we eat food, which is carbs, fat, and proteins that goes to the stomach where ghrelin is made. It stretches, you get leptin, cholecystokinin, peptide YY, oxynomedullin, GLP-1. And then it goes to the liver bypass, goes to the beta cell, the alpha cell bypass, and eventually goes to the adipose tissue. And those signals, neurally or endocrinologically or peptide biology-wise, either directly or through the portal circuit, influence the brain. And in the brain, it is the prefrontal cortex, it is the hypothalamus and the reward system in a very complex way, and the reflex system of the brainstem, the food equation is built. So there are signals from the gut which regulate both energy intake and glucose. The stomach sleep hormone is ghrelin. The beta cells make insulin. The alpha cells make glucagon. The islets make amylin and pancreatic polypeptide. the duodenum makes cholecystokinin and GIP and ghrelin. GIP is the next buzzword after GLP-1, and I'm not going to allude to that in detail, but in the next 1 year, you'll be hearing only about a GIP. GLP we have heard for 2 decades now. Now this is GIP. You see a lot of, the science on GIP. Then of course, jejunum makes GLP-1, peptide YY, and again GIP. Ileum makes GLP-1, oxynomedelin, peptide YY, and fibroblast factor 19. And colon makes GLP-1, oxynomedelin, and peptide YY. When we eat, what controls appetite? It's all about eating. Food is all about eating. Homeostatic eating, which means controlled by endocrine feedback signals. You feel hungry, ghrelin, increased satiety, GLP-1, peptide YY, oxynomedelin, amylin, and pancreatic polypeptide. Reflex eating, hedonic eating, controlled by brain's reward system. Dopamine controls wanting, the motivation or drive to eat. I want to eat. And the liking, the pleasure with food. I love this. I love the rabdi. I love the jalebi. I love the dessert, the sweet, the chocolates. Is opioid and cannabinoid, just like the nicotine receptors. And then we are ultimately cognitive. We are humans. We are not animals. So there is a self-regulatory process which can influence that, and that is that so-called willpower. So, that is a very small component. We have homeostatic eating, we have hedonic eating, and then of course we have thoughts, behavior, feelings, and all of them have to be mindfully handled. Because behavioral intervention is important to empower sustained behavior for control. So as I told you, we have the psychological effects, we have the medication and surgery effects, and we have the lifestyle effects. Because there are 3 functions: homeostatic eating, eating for hunger; hedonic eating, eating for pleasure; and executive function, which is deciding. And therefore, we can modify weight through a lifestyle, behavior, medication, and surgery, the quadrant. And then we lose weight, and after that, our body again has physiology to regain it. So the biggest bugbear for it is maintaining that lost weight. That is the maladaptation. Because we are programmed after weight loss and adaptation to resist weight loss. And that is what happens in our metabolism and the endocrine biology. And hunger increases the response to weight loss. And this is data to show that, and clearly suggests that. And the persistent metabolic adaptation after weight loss is illustrated in these figures. So clearly we have the basis of gaining weight, and we have a basis to regain. But ultimately, the scientists and pharmaceutical scientists exploited ingredients, the intestinal peptides. We know alpha cells made glucagon. If you see the pro-glucagon, it is made up of GRPP, glucagon, IP1, GLP1, IP2, and GLP2. There are 2 pathways of glucagon. One is the PCSK2 dominant pathway, which makes glucagon, GRPP, IP1, GLP1, IP2, GLP2. These are the cut peptides. And then we have the PCSK1-3 dominant pathway, which is GLP1, GLP2, glucagon, IP1, oxynomedelin, IP2, and then of course we have the GRP1, glucagon, IP1, that is glycine. So these are all these incretin-like peptides. It's not as simple as it appears. But pharmaceutical scientists fundamentally exploited glucagon-like peptides, and GIP1. So alpha makes glucagon, K cells make GIP, L cells make GLP. If you combine, say, a GIP, GLP, you get tirzepatide. If you have GLP-1 alone, it is semaglutide, liraglutide, dulaglutide. And if you combine 3, which is a glucagon receptor with a little bit of GIP and a GLP, you get retatrutide. And this is how the equation is. This equation switches off food intake, improves energy intake, browns the fat, lowers glucose and weight. So what is GLP-1 doing? That's the core. Makes insulin physiologically from the beta cells. So it improves, it's like a secretagogue without causing hypoglycemia, and switches off that excess glucagon from the alpha cells. That is the first mechanism. Typically, a gliptin can also do it in a physiological way, but GLP-1 does it in a pharmacological. So the effect is exaggerated, but it goes beyond that because it has a gut action of delaying gastric emptying and gastric motility. And then it has a neural action of switching off food and water intake or appetite. So it has a tricoordinate action. The GLP-1 has a tricoordinate action. And there is data, human data, to show that GLP-1 activates the brain involved in appetite regulation. Here is a picture of the hypothalamus blood flow, which increases the GLP-1 with the regional blood flow of the hypothalamus. So the GLP-1 from the gut and brain, we all know very well, active GLP-1, and it is processed in a particular way. So it improves satiety, decreases appetite, decreases food intake, improves insulin secretion, reduces hepatic fat and lipid content, decreases GI motility, and causes lipolysis, spends more energy, increases energy expenditure, and insulin resistance is decreased. Liraglutide was the first agent with the scale trial and as a part of the scale program, which showed very categorically that it can be used for obesity. And then came semaglutide. It directly activated hypothalamus on the homeostatic appetite mechanism and directly inhibited the hindbrain on the reflex hedonic appetite regulation. So it is basically an appetite quencher and it is here to stay. Semaglutide is available in different forms. In India, we have oral semaglutide 3714. Now there are trials going on 25 and 50. Then there is for obesity an injectable semaglutide 2.4. And there is also an injectable semaglutide for diabetes. And it is all directly reducing, when you activate the GLP-1 receptor, it reduces permeability, triglycerides, plaque burden and lesion, inflammation in the plaque tissue, and is an anti-atherosclerotic effect. That's why they have compelling cardiovascular outcomes. But people didn't stop at 8% weight loss of a GLP-1 receptor agent. Obesity, last year, is a slide from the last year's AD. They wanted to have more than 15% weight loss. And that's where comes the dual and triple agents. The GLP-1 GIP analog, the GLP-1 glucagon receptor agent, the GLP-1 GIP and glucagon receptor agonist, the amylin agents like carglitide or cargamespa, which are coming up. So you have single receptor agents, dual receptor agents, triple receptor agents, which have now emerged as major pathways. And they have data. For example, the step 1 program with semaglutide or the SURMOUNT program with tirzepatide. Compelling weight loss, far ahead of rest. So as I told you, surgery will cause weight loss up to around 25 to 40%. The triple agent can go up to 25%. The dual agent around 15-18%. And the single agent 8 to 12%. These are the chemists. And this year's Lasker Prize has actually been given to the GLP-1 discoverers. Of course, these are not those two scientists who got it. The scientist who got it is a scientist from Harvard, and his student who made actually the GLP-1, who's now at Rockefeller University, and a scientist from Denmark. But this is Dr. Tishop, who got the Banting lecture last year, and his partner Demarchi, and they discovered these multi-receptor agents. And they made a lot of difference. They repositioned the glucagon and the peptide family of glucagon, GLP-1 and GIP. And they created super hormone with action profiles. And therefore, if you see this compelling data, 25% weight loss with retatrutide, which is now available in North America and Europe, can cause almost weight loss equal to bariatric surgery. So controlling obesity is now very possible with multi-receptor drugs. They are closing the gap. And the data is very compelling. Last point before I close is there something called as healthy obesity? Because there was a term called MHO, metabolically healthy obesity. I think it was a transient phenomenon because there's a lot of all-cause mortality and incident heart attacks. And usually all metabolically healthy obesity has metabolic deterioration. Therefore, this term is very, very misleading and should not be used. The final point is tropical paradox of Indians and Chinese. We are 8 billion people on earth, 1.4 billion in India, and a similar number in China. Paradoxically, we have lower BMIs, lower obesity, but we have a thin fat phenotype. Typical picture, Caucasian, same BMI with an Asian Indian. Body fat of the Caucasian is 9%, body fat of Asian is 21%. These are non-diabetic. So we have more fat at any given body index compared to our other racial counterparts. Small body size but thin fat, centrally obese, high waist hip ratio. So despite of small body size, high waist ratio, we also have a lot of NEFA and triglycerides, a lot of insulin resistance. And therefore, we need to move the gear beyond BMI. BMI is a very poor marker. We need to move the gear for a waist height ratio or a waist circumference. So the Canadians at Edmonton and people of Indian origin like Arya Sharma, who now lives in Perth, had this Edmonton obesity staging system. Stage 1, stage 2, stage 3, stage 4, and of course stage 0. And assess a person living with obesity medically, mentally, and functionally. Stage 1 is preclinical risk factors and mild mental and functional disease. Stage 2 is comorbidity with moderate disease. Stage 3 is end organ damage with severe disease. And stage 4 is end stage disease across the board. So stage 0 may not just need lifestyle. Stage 1 may be behavior. Stage 2, 3, and 4 all can be now managed medically. Surgical options are very much. So clearly there is a compelling need for a good long-term pharmacotherapeutic option. Now some of them are getting available, and I'm sure in the next year or two we'll have many more options available. Obesity is a progressive disease, centered in the brain, influenced by complex intervention between genes and environment, and the gut and the brain. It's a global pandemic. The complications from obesity are huge and can be reversed by improving weight loss. We can achieve weight loss through physical activity and behavioral modifications, but it has a rebound. It is limited and difficult to maintain. And maintaining that weight loss is challenging because of the metabolic adaptation, and therefore pharmacotherapy has a role. One caveat before I close. When we lose weight, we lose muscle mass. Somebody above 65, if you lose a lot of muscle mass, due to any mechanism, you may have high mortality. So, and we are thin fat Indians, so we are sarcopenic. So if you use a weight loss therapy, whatever therapy it is, you must have protein because you are sarcopenic. We need to preserve the muscle mass and muscle function. We need to screen them for mental health and cognitive function. We need to screen them for bone health. We need to be oncovigilant because some of them you need thyroid node screening, and we need to focus on health outcomes. It's very, very crucial. And we need to ensure that we need to resistant exercise because to preserve muscle mass, that is the key. Clearly, we are here to stay. Obesity medicine is here to stay with all these caveats which I have highlighted. And of course, we need to also understand that these agents, like the GLP-1 GIP agents, may have a small risk of pancreatitis. And we should be pharmacovigilant for new side effects. But by and large, they are here to stay. And by and large, when indicated, should be used under medical supervision. Not just, they are not over the counter. This program is mainly to promote at the CMRE forum due to kind courtesy of Dr. Chawla and Dr. Chakki. The AAC membership in this geography, and I would encourage all of you all to join the American College and Association of Clinical Endocrinology. My last point before I close is that our mantra should be to make a difference in people's life. So happiness and health is as important, and eating slowly, eating less, eating on time, eating right, doing physical activity and resistance exercises, doing yoga like Surya Namaskar, or muscle strengthening exercises, meditation, pranayama, appropriate sleep for at least 7 hours, sleeping on time, and being happy and smiling are important equations in the lifestyle concept, which we must adhere.
Thank you, Dr. Joshi, for that very enlightening talk. I apologize for the delay that has happened, Dr. Monica and Dr. Trents. Apologies for keeping you waiting. We'll have a very quick panel discussion, and let me start straight away with Dr. Shashank Joshi. So now we have the newer therapies which are giving us weight loss almost to the tune of bariatric surgery, 20-25%. So my question to you is, how do you decide which patient should go which path? Is there some particular criteria, some phenotypes or comorbidities that should let us decide whether this patient should go for these newer therapies when it comes to obesity management, or whether you should directly still recommend bariatric surgery for a certain population?
I think currently the biggest challenge with these drugs in countries like India is that availability and accessibility and affordability. And I think the same is true even in the US and Europe, because affordability, accessibility is a challenge, and therefore we have to carefully select. And I loved the way Dr. Agarwal Monica spoke, that we need to really, ensure that the best fit gets it. If there's multimorbidity, if there's diabetes with obesity, I think, and there is a compelling need with cardiovascular disease associated with it, probably they'll get the best benefit. So I think a lot of triaging is occurring. It is something to similar to people during COVID times who got the ventilator, who didn't get the ventilator. That is the current status. Once these drugs are freely available at an affordable cost, probably it would be a different paradigm altogether. But I think currently the restriction is a medical use of it, and an appropriate and a carefully selected one. And in India, we only have oral semaglutide available. Injectable tirzepatide is on the anvil, but it will still take 6 months to a year to come. Injectable semaglutide is not available. And even oral semaglutide, we have seen shortages last year.
Yes.
So, and I think the off-label use should be discouraged. And I think it should be medically supervised and medically prescribed. That would be my take on it. I'm sure Dr. Monica and Dr. Trans also should have some comments from the US, because I'm sure it's not easily accessible to all their patients, because they also may be having shortages there, is what my friends in the US tell me.
Dr. Monica, coming to you, you mentioned how these newer therapies have brought us a weight loss of almost 20-25%. From a mechanistic point of view, the metabolic benefits and the metabolic mechanisms of these anti-obesity medications, how do you see the metabolic changes when you compare them to those that you see with bariatric surgery? Is there a difference in the pathways mechanistically?
Yeah, so these medicines are very effective, and like tirzepatide is what we have now, semaglutide and tirzepatide, and we see these same cardiometabolic benefits as we would see with bariatric surgery, because patients who have had metabolic surgery, there is data to show that their endogenous GLP and GIP goes up. So here we are administering it exogenously. So the same effect, and it's a function of their weight loss. So we could opt for a non-invasive therapy, which is not they would not require multivitamins and other things with Roux-en-Y and bone loss, those things. And we could opt for non-invasive therapy with a similar profile. So the data is very impressive, and we see it in our clinics And I do want to acknowledge that even in US, these drugs are very expensive, and there is an ongoing shortage of these medicines. And part of the problem is that to a certain degree, these are accessible to people who are more affluent and are able to get it by other resources. So discouraging that and using it for medical needs is very important.
Yes. Dr. Mohammed, my question to you, how do cultural factors in different countries influence the choice between surgery versus anti-obesity management? Do you think cultural factors also have a role to play?
We saw a tremendous use of tirzepatide and before it semaglutide for people who can afford it. So I don't think it's a cultural thing. It's a matter of a financial aspect. And unfortunately, that the therapy is available now for 1 to 2% of any population because it's extremely expensive, which actually makes bariatric surgery much cheaper as a choice. So while in the 5 years ago, we're saying bariatric surgery is very expensive to treat obesity and the consequences of obesity, now it becomes a lot cheaper option.
Absolutely, absolutely. Coming to you, Dr. Trends, from a global perspective, especially when you look at the healthcare access in countries like USA, how do you see these newer medications fitting into these obesity treatment algorithms vis-a-vis the diabetes management algorithms? So do you think they will completely replace surgery in these populations where access is easier despite the cost?
Yeah, we keep going back to cost as a big issue because inevitably that is the big issue. And it's also access, and it's access that some weeks you can get it and then another week comes and you can't get it. So it goes back and forth, which is very frustrating to patients that are trying to consistently use the medication. Yeah, I think that it hopefully will come to a point that cost will not be the demanding factor. If it doesn't, and it approaches ever the cost of metformin as an example, that's very futuristic and hopeful in thinking. But I think at that point, we will see a whole change in our algorithm approach. I mean, it is clearly looking at efficacy. If we really want to have an impact on our patients' health care, we really need to look at efficacy. Unfortunately, that's just not the only factor that has to be considered. And what is driving a lot of people here in the US certainly is to looking at compounding pharmacies, looking at some kind of supplement that seems to approach that we have berberine, as for example, which is called a Ozempic. We have oat kinds of concoctions that are being used. So people are desperate for something that is efficacious, but unfortunately it is cost that the bottom line is just driving it. And we have people who will say, yes, I can afford it. I'll afford it for a month or two. And then as we saw, if you don't consistently take these medications, the weight comes back on again. So very, very frustrating for the person trying to manage their diabetes as well as manage their weight.
Since we're a little short of time, this is just an open question and I welcome all the panelists to take this question to wrap up briefly. So is it the end of the road for bariatric surgery? Or do you still think that we can still achieve a balance between surgery and the pharmacotherapy when it comes to obesity management? Dr. Vinod Kumar, sir.
Well, I think before this question, I think that question can be replied by more experienced people, but I have some comments. You see, Dr. Chawla in the beginning and Dr. Shashank in the end, they talked about 3 types of eatings. To my mind, the hunger eating, that is homeostatic eating, and the executive eating are sensible eating. And to my mind, the pleasure eating or hedonic eating is an insensible way of eating. Why I say so? Because there the hormone like dopamine and cannabinoids, which is a bliss molecule, it gives happiness. In market, there is a molecule called anandamide. Ananda, what is anand? It is happiness. So they are eating more because of these things. And what is happening in a developing country like India, they are eating with pleasure more carbohydrates. You won't find people eating lots of proteins or fat.
So they are eating all the time carbohydrates, and this carbohydrate is the source of eating pleasurely, for pleasure. And this leads to this pot belly, rice belly, wheat belly, and all those kinds of things. So that is one application to the Indian eating. The second point is, Dr. Shashank very rightly said that it requires self-determination and discipline to fast or to do a dieting. But I would like to say here that there are now lots of new drugs which have come, which are called caloric restricting mimetics, CRMs. Mild CRMs are still metformin. There are also rapamycin, spermethrin, and even acarbose has got that property. And these properties have a dual effect. They also relieve the person of eating with discipline because of self-determination. They can lose the appetite by eating these substances, by taking these drugs. And when they take these drugs, they have an additional advantage that they get longevity because they are taking less food. And taking less calories and less diet is a sure way of having a long life.
Absolutely, absolutely. So I think since we're running very short of time, it is my privilege to deliver this vote of thanks, especially to our speakers from ACE who've joined in all the way from the US, Dr. Monica Agarwal and Dr. Day Strens. Thank you so much for joining us, and you really made this session very, very interesting with all the knowledge that you have shared. A vote of thanks also to our faculties, our esteemed faculties, Professor Shashank Joshi, Dr. Mohammad Hasnain, Dr. Amit Gupta, Dr. Vinod Kumar sir, on behalf of Dr. Chawla and myself through CMRE, and all the delegates who patiently sat through all these presentations. The floor is open for discussion. We have all the faculties with you here for dinner. Thanks also to our partners in this CME, Eli Lilly, as well as USV. Many thanks to all the delegates who are here, and I request all of you to join us for dinner. Thank you so much. Thank you, Dr. Agarwal. Thank you, Dr. Trends.
Thank you.
Thank you.
I'm so sorry. Can I have the mementos, please? Rahul, are you there? Arix, anyone here? Can I have those mementos, please? I'll request everyone to please join us for dinner and drinks.